Yes, Dinesh, what is happening?
Yes, sir. You are live. You can start, sir.
Good afternoon to all friends across the globe. This is Mahendra Verman on behalf of Sun Pharma. I extend my heartiest and warm welcome to all the delegates today. Today, since there is an overwhelming response, we hereby move ahead with another webinar focused on live surgical demonstration on advances in endoscopic sinus and skull-based surgeries today again. There was only 1 week gap, and in fact, last Sunday there were lots of calls that is there any program of Dr. Satish Jain today? Whether you are conducting or someone else conducting, there was a lot of discussion on that day. So it is again, then we are come back to our normal webinar, Sunday for Satish Jain, Dr. Satish Jain. Yeah, my heartiest welcome today. For first, my heartiest welcome goes to Dr. Guest Emeritus Professor Darlene Blue from South Africa. Madam, this is my heartiest welcome from Sun Pharma, the organizers of this webinar. Please do come, please join us. And we have Dr. Professor Sethi. So heartiest welcome to you, sir. And we have today again, we have our stars today. One is Dr. Samit Lal from Ranchi. And I think then yes, with his presence, then we can make this webinar more delightful. And we have, of course, our close friend, Dr. Vidyasagar from Vijayawada. Again, there will be a massive contribution from his side. And of course, our speakers, Dr. Rajiv Pachori, who is the brain behind this entire webinar of Explore the Legends. And we have with us Dr. Paramita Saha, moderator, and Dr. Ubo Mittal, our moderator. And of course, Dr. Satish Jain is a star. And I would say that he is the leading light for all of us. And this will be absolutely, again, an amazing webinar for all of us. So once again, my heartiest welcome on behalf of Sun Pharma Care Division, which is dealing with Cipodem, Montepex, and Recipar. Of course, we have Betavet as well. So once again, my heartiest welcome. Before I hand over the session, I would like to play a small video, which is just run for 1 minute. Yeah.
Wait, ready? Yeah, over to Dr. Rajiv Pachori.
Okay, please. So again, good afternoon, all my friends from my country, abroad, and all the viewers and those who are with us since almost 2 months. And can you see something on the screen? Screen is on. Yeah. Hello.
Yeah, now we do
Able to see.
Yeah.
So again, welcome to all my friends and those who are with us for last 2 months. This is our 18th webinar, live webinar, surgical webinar, and I think most of us, all of us, are enjoying this live feast and shown by our Dr. Satish Jain. I welcome Professor Darlene, Dr. Samir, Dr. Vidyasagar, Udvav, Dr. Paramita, and I think they are doing a lot of. They will do a lot of work today, and they will enjoy. They will share their views, their concept, their suggestions during the surgery. So I will not take more time now, and I think we should be over to Dr. Satish Jain. And thank you very much all again, and I think all the best for your 6, 7, 8, 9 hours live surgical demo. Please, I request everyone to share their questions, their views on the question desk, and we will try to give our views from our side and from Dr. Satish's side. And we have wonderful panel today, so they will also share their views also. Thank you very much.
Thank you, boss. Thank you. And good afternoon, everyone. It's a pleasure to welcome you all to our very interesting webinar today. And it's a great pleasure to welcome our important guest, the guest emeritus today, Professor Darlene Dubey from Cape Town, South Africa. And I'm grateful to her for consenting to be part of this scientific program. Thank you so much for everyone. She's a hardcore academician in the University of Cape Town. She has a deep interest in endoscopic skull-based surgery and developed some approaches in endoscopic transorbital surgery. She has developed a very interesting tool, a tracheal dilator and a stent for the tracheal stenosis patient, which in one of our case of respiratory papillomatosis, I'm going to show you a short video about that. She has been a faculty in various international workshops and a lot of presentations and publications to her credit. Thank you so much, Professor Darlene, for being with us. Thank you very much.
Thank you so much for the invitation, Satish.
Thank you. It's a pleasure for us. Thank you. And I can see Professor Sethi on the screen, who is the the source behind our energy, our work, what we are doing, and he's the man who is always guiding us to a better side. Thank you, sir, for being with us. And today we have two important guests. Thank you, sir. Thank you. We have two important guests with us, and you can see ever smiling Dr. Samit Lal. He is, very popular amongst us. He is organizing. He was supposed to organize this 2021 AOICon, which is postponed now, and now they are organizing in 2022 with great interest and a lot of new concepts, and we are looking forward to it. Thank you, boss. He is always in. Thank you. He's always in forefront of academics and develop new concept, new surgical techniques in the state of Ranchi. He's in the forefront of introducing cochlear implant surgery and many other surgical procedures. And his angiofibroma surgeries he did last month was a very interesting. Pulling a lot of crowds to his work, what he has been doing. Thank you.
You are an inspiration, sir. You've
Thank
inspired
you. Thank you. And then we have Dr. Vidyasagar. Vidyasagar is president of Indian Association of Sleep Apnea Surgery. His deep interest into sleep apnea, we all know, he is in the top sleep apnea surgeons in this region. He did his fellowship not only in sleep apnea but reconstruction surgery and many other surgeries from USA. He is practicing right now in Vijayawada and a lot of publication to his credit and involved in academics like anything. And he always, we have had several times discussion on JNA and other endoscopic skull-based surgeries with him, and it is always enlightening to hear from him. Thank you so much, boss.
Thanks so much for your kind invitation. I'm so privileged to be in this panel to see and moderate your sessions. It's a great privilege. I'm looking forward to learn more today.
All right, thank you. We are all thankful to you.
Bonus for me.
And to moderate this, we have this young man, I call him Young Dynamite, Dr. Udvav Mittal, who is always fully charged, and today also he is going to bring us some important questions as well. Thank you, Udvav, and Paramita for being with us. Paramita, thank you in spite of not keeping well today, being with us. Thank you.
Thank you, sir.
So, today's plan, like discussed in the invite, we scheduled 7 cases and 2 more added to the list because of the urgency. two more cases besides the two JNAs with different deep extensions and a huge skull-based papilloma and some respiratory papillomatosis cases. We have today three interesting extensive allergic fungal sinusitis patients, and two of them have presented with vision loss, which we are keeping today because of the urgency. So three extensive with different deep extensions. One of the patient has bilateral abductor palsy with the vision loss, another has a sudden vision loss, and one has a huge proptosis and a vision loss as well. So those are three interesting cases along with our list of papillomas and inverted papillomas and JNAs. So without wasting time, our first case, can you share the screen please? The first case is a child. We can see on the screen. Are you getting the picture on the screen?
Yes, we are getting.
Yes, sir.
We are
Yes, sir.
getting.
We are getting.
So this patient is a 14-year-old male patient who presented to us with a history of nasal obstruction and recurrent bleeding. And you know, a child, adolescent male presenting with a history of nasal blockage and bleeding, and on endoscopy, a masked lesion in the nasal cavity and nasopharynx is almost always suggestive of a juvenile nasopharyngeal angiofibroma. And this diagnosis is almost always reinforced by radiological findings, because there are certain characteristic features of JNA on radiology, because it has a characteristic pattern of spread. We are never supposed to take a biopsy assuming being a JNA, as it has a propensity to bleed like anything. So radiology is most important, and we have discussed in our previous number of JNAs, we demonstrated how radiology goes about. Our predominant radiological investigation we order upfront is a contrast CT angiogram. It serves the purpose of a contrast CT. At the same time, it gives us valuable information of an angiogram, giving us the full idea of the vascularity going to the lesion, as well as the the cross circulation at the level of the circle of Willis. In case the tumor invades the carotid artery or in close proximity, we need to have that information, which is very, very vital. And this patient, this investigation is our first and the foremost and the most useful investigation I always mention. So this patient, if you see, has a classical pattern. Let me reconstruct in the coronal as well. See, as I always mention, we always get this investigation in our DICOM format. See this. This is a classical pattern of spread of this lesion, and see the huge lateral spread, which is different from the previous JNAs we have demonstrated. So, yes, the extension is amazing, and this is predictable. I always call JNA as a predictable tumor, and we need to understand the concept of spread and vascularity in order to carry out a safe and a complete surgery, because this is a benign lesion. Like any other benign lesion, we need to remove it completely to prevent the so-called recurrence. It never recurs. It is not malignancy. But there are certain areas, difficult areas where it invades, which are difficult to remove, and one can easily overlook the tumor removal, and that is the cause of the recurrence behind this lesion. So this lesion, I will take you through certain characteristic findings or the spread findings of this lesion on this CT angiogram. Let us see on this sequence. See, I am coming from anterior to posterior. As I always mention, our predominant approach for all primary JNAs is endoscopic. By and large endoscopic, whatsoever the spread is. And this is based on our own study on the pattern of vascularity and the behavior of the tumor, and the use of coagulation as a main tool for surface coagulation of the entire lesion, because the most of the vascularity is lying on the surface. So which we are going to discuss during surgery. Now, as I come from anterior to posterior, since this is a contrast scan, see, this is all secretions which are not enhancing. Can you see?
Yeah.
And see the tumor which is coming from behind, and see the bunch of vessels. This tumor is all about vascularity. That's why we are discussing it. Otherwise, there is nothing great in discussion with this tumor. So this is all bunch of vessels coming to this tumor, which I am going to show you how they are entering into. That is the role behind, that is the reason behind getting this CT angiogram done. Now, see, coming from here, anterior to posterior, This is the lesion which is protruding from behind the posterior wall of the maxilla. See this? It is this much of the posterior wall is protruding and almost obliterating the maxillary sinus as we go behind. Then this lesion which is arising from the area of the pterygoid wedge, this is spreading, prolapsing right down in the cheek, far laterally in the infratemporal fossa, is mandible, and almost occupying the entire infratemporal fossa and prolapsing down in the cheek. Then this is the pterygopalatine fossa which is widened and then coming into the nasal cavity. And as we go behind, this is in the inferior orbital fissure. That's in the superior orbital fissure. And as we go behind, this is the region of the cavernous sinus where this tumor is going. And this is important to understand three-dimensionally in surgical planning, because these are the area where we often overlook this tumor, and that becomes the cause of the so-called recurrence. And see what is there in between. This entire pterygoid wedge. See this pterygoid process on the other side, and this one widened and completely infiltrated with the tumor. As we go behind, this is the entire pterygoid process which need to be completely drilled away. Of all causes of recurrence, of all causes of residual disease, this is the prime cause. The residual disease left behind in the pterygoid is the biggest cause of the residual disease. And to identify this, let me put you some important, T2 weighted MRI along with. To identify this disease in the pterygoid wedge, even a CT scan sometime may not pick up. Intraoperatively, you may not find a huge lesion to identify, and one can overlook a microscopic disease. How you can pick up easily? By means of a good T2 weighted MRI. And that too, if you do a, fat suppressed T2 weighted. The reason is, this pterygoid wedge, where the disease is, this is pterygoid wedge. See, fat in the bone is always something enhances on MRI. If we suppress the fat, if there is no tumor, that the bone will appear dark. This is the opposite side pterygoid process where there is no disease. And you see the disease on this side with enhancing pterygoid region because of the micro invasion of the disease into the pterygoid bone. And that is something we need to get done. In all cases, we always get a fat suppressed MRI to pick up this, bone marrow invasion of the pterygoid by this disease. And this becomes the principal cause of so-called recurrence. More than 90% of the time, this is the principal cause of recurrence. The invasion of the bone marrow pterygoid is the cause. Now, coming to the CT angiogram again about this extension. This tumor is extending behind into the, the posterior part of the infratemporal fossa, and then as I mentioned, this into the minimal prolapse into the cavernous sinus. Now, let us see in all planes how I said this is going to in the cavernous sinus. See, coming on to the axial part, axial sections, if we see carefully, there are a lot to be seen on axial sections right from the beginning. Number one, what I want to see is the vascularity. See this I am coming from above downwards, below upwards. This is the common carotid artery, can you see?
Yeah.
Now dividing into the external and internal carotid. This is internal carotid, and a lot of branches arising from the external carotid. Going up. Now the main external carotid going behind the mandible. And then it divides into two important branches. See this?
Yeah.
And see what is this, the huge branch. This is maxillary artery. What I want to see here with the maxillary, see how it is entering into the tumor here. Can you see here?
Yes.
Yes, sir, yes.
Had this artery been passing behind the tumor, I would never keep this case for endoscopic surgery. In the next case is a more complex case where you will find a lot of vessels coming from behind the tumor, and that is counterproductive for the endoscopic approach. The hallmark of the endoscopic approach is reach to the area where the vessel is first before entering into the tumor. For this patient with this lateral extension, how I am going to come? I will come by the Denkers, modified Denkers, removing the medial wall and part of the anterolateral wall, and come head on onto the tumor. And see my vessel here. The first structure I see here is this vessel. See, let me show you again. The first structure, see this vessel with my cursor. With my cursor running into the anterior most part of the tumor. Can you see here?
Yes, sir.
So as I come from front, the first goal of my surgery is to catch this vessel to devascularize this tumor to some extent so that I can remove it endoscopically. And this is something very, very important for us to see on CT angiogram. Not only the information of vascularity, which vessels are supplying, how the vessels are entering into the tumor, you need to see yourself. This radiologist is not going to tell you that you have to either ask the radiologist to see yourself and then plan your surgery. So now, this is the vessel which is entering into the tumor, and that is how I am keeping this case for endoscopic surgery, because in this surgery, I will make my approach to this area by, after doing modified Dankers, come on to this vessel. This part of the tumor, see how it is protruding into the maxillary sinus. The classical Hallman-Miller sign, where a tumor coming from behind, pushing the posterior wall of the maxillary sinus anteriorly. And this is all retained secretion, nothing else. The mucosal hypertrophy or retained secretion, this is the vessel which is entering into the tumor. Now coming up, if I come up, see this, the tumor which is coming lateral to medial, the entire tumor. We demonstrated earlier, will pull it out of the superior orbital fissure in the cavernous sinus. That is going to be our goal. Now, coming to the again to the three-dimensional reconstruction, we need to see this relationship with the carotid artery in all planes. See this tumor. See this. This is the carotid artery. Let me put here the carotid artery onto the tumor. This cursor on the carotid artery, and what we have seen, this cavernous sinus extension of the tumor on this axial section. We have to pick up through the axial the coronal part. See this part, and now we see here in the sagittal. So clear now. Now see, this is your carotid artery. See, this is your carotid artery which is ascending from here. The paraclival, posterior band, horizontal, and the anterior segment of the carotid artery. This is the carotid arching, and this tumor is coming from the superior orbital fissure into the cavernous sinus, but not invading the carotid artery. I hope it is very clear.
Yes, sir, yes.
So this is how we need to see three-dimensionally where the tumor is going to, how the vessel, see this is the vessel. This is the vessel, and this is how it is entering into the lesion. Can you see this?
Yes,
so
sir, very clear.
all the aspect of vascularity we need to see from this. We need to see the cross circulation, the level of circle of Willis. See the vessel in the axial plane, vessel in the coronal plane, and this vessel in the sagittal plane. And this is how it enters into the tumor in the most anterior part and branching inside to give a lot of branches to supply this tumor. And this is the hallmark of, this Jain. Because of these characteristic findings, radiological findings, this is confirmed, diagnosed as Jain. We don't have a histology. And see, secondly, last thing on CT angiogram before we start the case is the cross circulation. See this. This is the cavernous carotid going intracranially, dividing into anterior and middle cerebral here. So clear.
Yes,
and these, if you go behind, you will find there's a basilar artery dividing into posterior cerebral, and these giving this branch to the joining the posterior communicating artery to the carotid artery. So this is how you can see how the vessels are, joined at the level of the circle of Willis to complete the cross circulation. So this is a basic picture of the CT angiogram. There are, to show you certain important things on the MRI, like I've already said, this is the enhancement pattern of the tumor. See how intense enhancement is, how vascular it is going to be after the post-contrast injection. And see, this is the tumor, this is the vessel, which is pushed laterally, running along the lateral surface, and then it comes inside the tumor, like here into the tumor. This tumor in the nasal cavity, this is into superior orbital fissure, and this into the cavernous sinus. So this is on the post-contrast scan. You can see in the axial as well as, and see the amount of contrast enhancement in this tumor, which signifies the intense vascularity. But according to our planning, we use a coagulation, we'll take the vessel into control, and then after only we'll enter into the tumor. Vidyasagar, anything you want to add?
Yeah. Yes, sir. I have a few questions.
Yeah.
From a beginner's perspective, when we see a patient with the JNA, the two things will come into our mind. One, it is JNA angiofibroma.
Yes.
Whether there is going to be an angiomatous component is going to be more, or a fibrous component is going to be more. So from a CT, how are you going to tell the juniors how to look for whether this patient is going to have the fibrous component more, which would be friendly for a surgeon, or whether the angiomatous component, like what you have shown in the contrast, is going to be more?
Yes, that is a very important question. And I tell you, see what sequence is this? This is T2 weighted MRI showing the, what you are seeing is a salt and pepper appearance. See the number of vessels, bunch of vessels, all these dark, bigger vessels. Pepper are the larger vessels, and all small white dots are smaller vessels. You can see the angiomatous component by means of a contrast enhancement on MRI and by means of this, the flow voids on the T2 weighted imaging. That's important. And more the patient younger the patient, more is vascular. As the child grows to an adult, the more and more fibrous component goes in. As the tumor enlarges, more and more central area becomes hypovascular and periphery more and more hypervascular. That is how the routine pattern of the JNA is. Professor Dubey, you have been doing a lot of skull-based surgeries, must be JNAs, and you must have your own investigation protocol. Anything you want to add or anything you do differently?
I would like to ask you, it sounds like you don't do pre-operative embolization.
Not really. That's the important thing. We have discussed many a time, but yes, your question is very important for everyone. Embolization is a good strategy to devascularize the tumor pre-operatively. It has a lot of advantages, but it is not free of, adverse events as well. So our strategy in our country, looking at a lot of financial aspect and other aspects, we went into the, the vascularity of the tumor, and we finally realized majority of the tumor, unless it deeply invades the skull base, are supplied by internal maxillary artery, and sometimes in deep posterior spread by other branches of the external carotid. Like this tumor is predominantly supplied by internal maxillary artery. So our goal in surgery is to go and catch the vessel first, to devascularize it, and on surface use the coagulation, and it gives almost the same effect as you get with the embolization. So majority of the patients we are not embolizing. But yes, some patients wherein the vessels are coming from behind, or there are multiple feeders coming from behind, which you can't catch without removal of the tumor first, then obviously the embolization is the only way. That can certainly help in devascularizing. And once it comes to embolization, your intervention radiologist has to be very good and experienced to prevent complications. We have seen complications with the embolizing material inadvertently going to the internal carotid circulation and giving complication. Blindness, so many things. So once it comes to embolization, cost is a factor, complications are a factor. Intervention radiologist has to be very experienced to pick up the dangerous anastomosis between external and internal carotid artery. Then preferably a fluid embolization like glue or something. And nowadays, if the patient can afford, we do intratumoral onyx embolization. That's supposed to be the best one. so far. I don't know what is your pattern, what you have been using, how you are doing.
So we do the same investigations, a preoperative CT and MRI with the angiography, but at the same time as angiography, we would always do embolization. We're very lucky that we've got a very experienced neuroendovascular team, so two neurosurgeons that do all our embolization for us. But the problem that we always have is obviously the branches from the internal carotid artery and your Vidian artery, which I find is always the major bleeder. So we normally do the embolization about 48 hours and not longer than 7 days, because otherwise the tumor becomes very fibrotic and hard and difficult to remove. But I'm very interested to see how you do it without embolization, and I'm certainly going to look at the scans at the vessels like you have kind of showed us to devascularize it before tumor removal.
So that is great, and you must be getting a good field once you have an experienced intervention radiologist with you.
Yes, certainly. It makes really a big difference for the preoperative embolization. Although I find that you still, if you enter the tumor, there's still a lot of bleeding. So we often use the cell saver to kind of collect all the blood and transfuse the patient with that, and that has reduced the need for blood transfusions post-operatively or intraoperatively.
Great. So you are so fortunate, you have a good team. See, that is a teamwork. And Professor Darlene, what is the cost factor in embolization approximately in your country in terms of US dollars for embolization alone?
Probably in the region between $1,000 and $1,500. So it's not. Patients are admitted as a day case. So it's not really. Even in our state sector, we're able to do embolization. But yes, it certainly is a factor for many places in Africa. We don't have those experienced endovascular surgeons. Then the risk is very high of stroke. We've been very lucky that we have had no complications, but it certainly is a consideration.
Oh, great. So here in India, many of the patients, are low to medium socioeconomic group, and this affordability of the embolization itself is a big problem many a times. And that's how we developed this technique, which I'm going to share with you today, that how we do without embolization and majority of the patients even without blood transfusion. This is our technique which we have developed, which I'm going to show you. But yes, embolization is a good way if you have a good intervention radiologist, your patient can afford. But yes, it is not always 100%, problem-free. There are a lot of problems associated with embolization. Embolization doesn't mean that tumor is not going to bleed. It is going to reduce the vascularity as compared to without embolization, certainly. But here, your surgical technique has a lot of impact, and this is what we have modified. That majority of the patient we have been able to do without embolization and without transfusion. However big the patient is, it is the vascularity, the orientation of the vascularity, understanding the vascularity, and the use of coagulation all have a significant impact. Are you getting the endoscopic picture now?
Yes, sir. Very clear.
So we have we are on with the case now, and what I want to show here. Hello,
Dr. Satish, can I ask a question?
Yes, please. Please feel free to interrupt me anytime.
Thank you, Dr. Satish. So here in this patient, you seem to have this large internal maxillary artery, but I also see the tumor going posteriorly. So how do you decide that this patient doesn't have a feeder from the ascending pharyngeal as well?
We saw through angiogram, there were small tiny vessels we could pick up on enlarging the angiogram, but there is hardly any big vessel going to the tumor. And this, internal maxillary has a lot of branching inside the tumor to supply the tumor wherever it is going. So predominantly internal maxillary is the vessel. Can you see the tumor behind?
Yes, sir.
Very nicely seen.
Section. See, this is the tumor behind, and this is the primary picture without any preparation. The first preparation which I have done is just now I packed with saline adrenaline gauge piece, and this is the primary picture of this tumor which is coming from behind the, the posterior part of the middle turbinate. So like, as I mentioned, my primary tool for the surgery is going to be the coblation. Can you say coblation meant?
Yes, sir.
No, wonderful tool.
Professor Darlin, please feel free to interrupt me any point of time. You want to ask or you want to add on anything. Your comments are most welcome. They are most valuable. Please feel free to comment anytime.
Thank you very much. I'm just curious, do you inject with adrenaline, lignocaine and adrenaline into the before you use the coblation or not?
What I have injected?
Do you inject anything?
No, nothing. We never inject anything into the nose for anything. For any case we do, like sinus surgery or skull-based surgery, we never inject into the nose. We believe only in topical, application. And see what I am doing here. I am using this coblation. This is a pro-size max wand of the coblation. And see, I am going to use this throughout on the surface of the lesion. See the surface vessels.
Yes, sir.
See the moment you touch the vessel, they bleed like anything. That shows how vascular is the tumor. And see what the coblation is. It devascularizes on the surface.
But sometimes it can bleed a lot with coblation. Like
yes.
So how do you handle your coblator?
Yeah, you don't use the pressure on the vent. Just apply on the surface and press coagulation. Coagulation, not the ablation. Okay. We are not supposed to enter into the tumor unless we completely expose it from all around and devascularize completely. Then only we'll go to the tumor. Why did I do the surface coagulation at this point of time? So that inadvertently, if my instrument happened to touch, it is not going to bleed. This is simply for that purpose. Now, my 90% of the time in this surgery is going to be spent in exposure, exposure, exposure. So, here now, my first goal is to do a modified Dankers to reach onto the tumor head-on. The lateral component, the tumor head-on, will reach there, will open the pterygopalatine fossa, the anterior part of the tumor, catch the vessel, devascularize it, and that is going to be our goal, the first goal. So in order to do the modified Dankers, what we intend to remove, we intend to remove the medial wall of the maxilla as well as the anterolateral wall partly to go head-on to the anterior wall of the pterygopalatine fossa and the infratemporal fossa. And here, my superior limit is going to be the orbit. This is what I need to, preserve. I need to avoid this complication of unwanted entry into the orbit. So I will show where my, the maxillary roof is or the orbital floor is later. But by and large, in this closed area, when I devascularize the lateral wall, I stay roughly a centimeter below the axilla. Just a centimeter below the axilla, and coagulate this mucoperiosteum. I am just coagulating the mucoperiosteum of the lateral wall of the nose. See that?
Dr. Satish, if by chance you have a gross septal deviation, would you address it first, or what is your technique? What do you do?
What? Can you repeat?
If you have a gross septal deviation on the side of the tumor.
Yeah.
So would you?
Unlikely to be on the side of the tumor. Rather, most of the time, because of the tumor bulk, it is pushed to the opposite side. But yes, if there is anterior sharp deflection, it is always better to correct that rather than compromising your axis.
Exposure.
Do you have to remove the part of septum also to get good exposure?
Not for anterior exposure. Posteriorly, I will remove posterior most part to see the bilateral access into the nasopharynx. That I will do at the end. I will show you. That is the important part of the approach. So here what I'm doing, I'm completely coagulating the lateral wall, staying a centimeter below the axilla.
Axilla.
Now see, where is the piriform aperture? See this, now I'm using the ablation, cutting. And see at this anterior edge.
Yes.
This anterior edge is going to be my piriform aperture. See this edge of bone anteriorly. You have to be careful while coming more anteriorly not to damage the lower ala. That alar cartilage injury can lead to drooping of the nose in that region.
Nasal
That is
valve
certainly
collapse.
we are not supposed to do. Now see the anterior edge of the piriform aperture.
Yes, sir.
Very clear?
Yes, sir. Sir, what are the coagulation settings?
This is full 9 and 5 for the coagulation and ablation.
Okay, okay.
See right down to the floor.
Yes, sir.
So here if I remove medially, that is going to be the anterior wall, like this. See, I can remove this vascular mucoperiosteum without any significant oozing. Can you see this?
Yes, sir. Yes, sir.
And this tool, that's why I call this coagulation as a man of the match tool. Professor Darlin, I use this coagulation throughout my surgery in one hand as it serves multiple purposes. Coagulation, cutting, suction, irrigation, all the time with the same tool. It's a multi-purpose tool, you can say. That's why I call it as a man of the match.
I do think the multifunctional instruments make such a difference to our endoscopic surgery. And I must say, I've only used a coblation once during angiofibroma surgery, but it looks like it works wonderfully. The one problem that I had was the continuous blockage. But I see you don't seem to have that problem. It's just high flow.
Yeah, no, you know what? How can you overcome? First of all, this band is a Pro Size Max. It has the largest bore inside for the suction, so it doesn't get frequently clogged, number one. Number two, the suction backup behind. We have a powerful suction behind. You will see in the fungal cases.
Yes, sir.
Another man of the match today for all the surgeries is going to be the suction.
So 1 HP.
Yes, it's a full, and now we have converted to a central unit, high power central unit, and you will be amazed with hardly any blockage of the vent or the suction tip during the whole day.
Is this the same instrument that you use for tonsillectomies, the same coablator tip?
Yeah, same probe everywhere, but I don't use too much for the tonsils and other things. That I do with the dissection only. This surgery...
But it's the same probe.
Yeah. This surgery is different, you know. Here I don't want... And see, wherever there is a bone, bleeding coming from the bone, never try to use the wand, otherwise that will ruin the wand. Never use the wand on the bone, never.
The probe, what he is using is Pro-Size Max, but the commonly used probe for tonsils is EVAC 70.
EVAC, and you can use the Pro-Size Max as well.
This also. Yeah.
So how we do in tonsillectomy, we never use this as a dissector. And we use, do the tonsillectomy mostly with the dissection method, the classical one, to avoid too much of chairing. And then in the end, if there are oozers, we use the coagulation of the, coagulator. Now see what is there in the lateral wall. This is your inferior turbinate, which is always a separate bone. Can you see?
Yes, sir.
So here now, I am removing this anterior part of the inferior turbinate. When we, deal with the inferior turbinate, some bleeding is expected because the major vessel to the inferior turbinate comes from behind, from the sphenopalatine, which we have not taken into control yet. So some sort of oozing is expected when we, when we remove the part of the inferior turbinate anteriorly. So we have to be prepared with that, with little bit of the oozing that will anyhow bring it.
Yes.
Yes, sir. Sir, Dr. Sohail from Karachi is asking, can we use bipolar also?
Yes, you can use bipolar, but bipolar cannot be as quick as cobblator.
Yes, sir.
See this cobblator, now I am elevating the periosteum of the anterolateral wall. See this?
Yes, sir. Yes.
See this anterolateral wall, and I will remove a good amount of anterolateral wall in this case as the tumor is going far laterally.
Far laterally.
Sometime when the tumor is not going far laterally, we don't remove that much, but here you can go right up to the, the infraorbital nerve. See this? And
Yes,
this
sir.
bone, now the bone which is standing in between these two walls is to go.
Satish, can I ask, are you holding the endoscope or have you got
it is
a
me.
assistant?
It is me who is holding the endoscope.
And you've got an assistant as well?
Yes. I have, 6 hands working with me. My 2 assistants, one holding another section all the time, another, irrigating all the time, the other holding in between retractor. So many things to be done simultaneously. Now this is the bone which is going to go. Can you see very clear?
Yes.
Yes, sir.
To enter into the maxillary sinus, up, I would say head on. Now, section rakh niche. Now see this anterior thin part of the bone, I am removing through my lux forceps. Whatever thin bone I can remove, otherwise I'll have to use my drill. So now first, before going anywhere behind, this is my high-speed stylus drill from the Medtronic. Can you see this?
Yes, sir. Yes, sir.
I am using right now 60,000 RPM. The third tool which is going to be, man of the match today is going to be this drill. As we have many draft procedures today, probably all the 3, all the 3 AFRS patient will require probably draft. And obviously the inverted papilloma case as well. And this drill is my very important tool. This is going to be, wait.
Satish, can I ask the question?
Yeah.
Yes, please.
For your 6-hand approach, wouldn't removing the anterior part of septum will be better assisted?
Pardon?
So if you remove the anterior part of the septum, and most assistants will get more space if you do that.
Anterior part of the septum is nowhere in between. See, our septum is nowhere coming in between. Now this is the other drill I have taken. Now first what I am going to show you, what I want to show you, I will enter into the maxillary sinus and show you the roof of the maxilla, so that when you remove this wall, you are not supposed to enter into the orbit. So here I will enter into the maxilla like this. This is the anterior wall.
Dr. Satish, I obviously believe that having a best tool is always a key. But for this particular step, can a beginner use a chisel and hammer too? Only for this particular step?
Yes, see, the drill is the main tool by which you can work precisely. If you don't have a drill, you can use the chisel hammer. I have shown many times using chisel hammer as well.
Yes,
Yes, sir.
seen that.
So, but drill is going to be more precise, more control. And see, now I am already into the maxilla. नहीं, suction करना है, yeah. See, I am already into the maxilla. Hello?
Yes, sir.
I am widening.
Very nice listening.
I am widening to show you the upper limit, and then I will remove this wall thoroughly. Yeah. See, this is the maxilla. Give me the debrider. Let me remove this mucosa. This is just to show you where I am working and why.
Right.
Guru Phata. Guru Rende.
Somebody is retracting the ala for you.
See now, I am into the maxillary sinus here, from here. Can you see very clear?
Yes, sir.
And now I can remove this wall very well without entering into the, orbit. This entire wall has to go, right up to the posterior wall of the maxilla to give me full access. This is part of the axis. So my 90% of the time is going to be invested in the axis, and axis. And this tumor, with a tumor occupying majority of the maxillary sinus itself, pushing too much of the maxillary wall anteriorly, you have seen.
Yes.
So maxillary sinus is pushed to a very, very narrow compartment. See, I am removing this rest of the turbinate, inferior turbinate, and remove everything. The moment my Denker is done, my majority of the work is done. This is the most important part of the axis. All this mucosa, everything has to go. Sometime you can use the shaver to expedite your process, just to expedite. Cobblator. And now I can use my cobblator because it will make the field absolutely bloodless. See, right to the floor. Can you see?
Yes, sir.
You have to flush to the floor of the nose completely. Posterior wall of the maxilla, it is so, the posterior part of the turbinate is supposed to be vascular, which we need to control. Forceps. And now this entire wall I am going to drill away. Now this you can drill away. You can, use a chisel and hammer, whatever. Retractor. See now our target. Our target is very clear now?
Yes, sir.
Very clear.
Very nice.
And the nasolacrimal duct area would be somewhere.
Yeah, that is important. Like Dr. Vidyasagar mentioned, the most important structure going to come here, which we are supposed to preserve to prevent morbidity, is the nasolacrimal system. And we'll show you how we are going to cut that shaft to prevent any epiphora in the post-op period. So this is the bone which need to be thoroughly drilled off. See this?
Satish, one thing that I've also tell our registrars when we start drilling in, especially the anterior part of the nose, is to that stylus drill that you use. It's got a very nice little small shaft, a short shaft of 1 millimeter. But one has to be very careful with certain drills where you have a shaft of 1 centimeter or more, that can catch the muscle or the mucosa in the nose.
Yes, that is very important. You have to be careful.
Okay, sir.
So I am getting another drill here.
Do you always identify your infraorbital nerve before you start the drilling process?
Not really, not yet identified. But yes, as I go laterally, I need to identify to prevent damage to it. And most of the time, that remains my, the lateral limit. Lateral limit of bone removal is majority of the time the infraorbital nerve is. So I have not gone there. And see this. Most of the time, identify the nerve far laterally and avoid injury to it. Look now. That is going to be my infraorbital foramen there. See there.
Yes, beautifully.
So that is going to be my, lateral limit all time. So my task is to remove this thick bone. Thick bone, this is really thick. And I want to remove it as fast as possible.
Dr. Satish, while you are doing this part, can I ask something different about the patient itself? Yeah.
Yes, please.
It's not related to this particular step. Just to have a discussion going. That's it.
Yes, please.
So let's say that you don't have an access to a very good embolizing team, and you have the tumor coming in between. Can you have an access in the neck? Would it be a good way to do it, or it doesn't matter actually?
Access in the neck
for external carotid artery, having a loop around the external carotid artery.
Let me tell you one thing. You have to be very careful, clear. Taking the external carotid artery in control distally, is not going to have that much of the impact in reducing the overall bleeding, because first of all, that is not an end artery.
Yeah.
See, in embolization, we are supposed to embolize the microvasculature of the tumor.
Yeah.
Main vessel embolization doesn't have that much of impact. See, that is the sinus inside.
The reason is, yeah.
So external carotid artery ligation practically doesn't have that much of the impact than what we believe.
Okay. Correct.
See the sinus itself. This particular patient has a really thick bone. See the sinus and the tumor which is bulging from behind. Can you see?
Yes.
Very nice. Listen.
I have to simply get rid of all this bone by anyhow. I just keep thinning this with the drill, then remove with a punch or this forceps, and so that you don't have to drill too much. See, this is my nasolacrimal duct which is hanging from above.
Yes.
Very clear?
Very nice and clear.
Very nice.
And I will show you how you can avoid the post-operative epiphora. I am removing all this soft bone tissue drill. Now all this bone anterior to it has to go.
Right.
I will ligate this, or I will cut this, duct right close to its exit from the floor of the orbit, right flushing to the floor of the orbit, so it doesn't hang anymore in the sinus to get blocked. Doesn't hang anymore. I will completely go up and flush with the floor and cut there sharp. If I cut below, hanging, and leave it hanging, it is going to get fibrous in the times to come. Yes. See the nasolacrimal duct hanging.
Yes, sir, very clearly.
All around it is surrounded by bone, so that you have to clear all the way. All around. All the bone around the duct has to go. Completely go. Forceps. See, imagine how this duct is coming in the way. Once the duct is removed from the way, you have a full exposure behind for your work, whatever you want to do behind to the level of the skull base. Only thing is this duct should be completely skeletonized, and then only I will cut it, debrider. See now, this mucosa within the maxillary sinus. This is towards the roof. See this?
Yes, sir.
Yes, yes, sir.
पकड़ पकड़ clogged. I will remove all mucosa, everything bone all around it, and then cut it sharp. See, behind is the uncinate process.
Yes.
पकड़ लो. See, keep the duct away.
Then
This is uncinate process I am removing.
yeah, I can see that. Very nice.
See that the bone of the uncinate.
Here you don't like to use splitter?
Not really, because some bone pieces, I have a fear of injuring the duct, so I am keeping it away.
Okay.
And now, scissors. And now see at the level of the floor of the orbit.
Yes, yes.
See at this level.
Yes, yes. Yes.
I will cut it
Up cut.
sharp.
Clean oblique cut.
Straight cut. See this?
Straight.
Now see where the duct is. See this?
Yeah, very nice. Oh, yes.
Yes, sir.
Absolutely. And
Fantastic.
this will not now impede my visualization at all. See this?
Yes.
This is not going to come my way any point of time. I hope it is clear.
Very
Yes,
clear.
sir.
Very nice. Very nice.
Medial wall of the bone of the medial wall of the maxilla has to go. You have to flush it right till the posterior wall of the maxilla. I have to remove all this mucosa as well, which is going behind and over the posterior part of the maxillary sinus, over the pterygopalatine, part of the tumor which is bulging. All this mucosa has to go. See, more and more exposure improving.
Very nice exposure.
This part you can do faster, you can be a little slower, whatever the way you do. But I generally go little fast on this point to save time. I can save a lot of time at this point of time, debrider. Now,
Dr. Satish, there has been instances wherein the molar tooth would be present in this area posteriorly, and that can come into the way.
See, molar teeth, Dr. Vidyasagar, they come in the floor.
Exactly, yeah.
Which I am not going to. At the most, what I am going to do inferiorly is going to flush this flush with the floor. See, this is my floor, and I am going to flush this with the floor. That's it. Not more than that drill. Let me show you. After that, I have nothing to do inferiorly. See this? And why I am doing this flushing? So in the depth when I work, the instrument will not be impeded. So this is always better to flush in the floor. To flush in the floor. Just flush in the floor to the level of the floor of the nose. Completely that level. Your molar teeth are going to come from the floor below that.
Yes, yes. No, I'm not talking about the normal anatomy, sir. Very rarely we have seen the molar tooth impacted inside the maxillary sinus. And in one such case, I came across a patient wherein the third molar impacted molar tooth was present just in the posterior wall of the maxillary sinus. So I had to remove it to access the...
And that can lead to orodental fistula.
Exactly.
That can lead to orodental fistula.
Fistula.
If that happens to occur, you have to treat at the same time.
Same time, yeah.
Because that time it is treatable.
The other question I want to ask is, like, post-operatively, when we remove these mucosa, this gets replaced by a kind of polyp or like a cyst kind of thing that forms.
Yeah. So that is the reactive mucosa.
Yeah.
Because of the ongoing probably infection, inflammation. That's why we follow a strict protocol of douching in the post-op period, you know.
Yeah.
For these patients. And obviously, you have to give some antibiotics as well to prevent secondary infection. That is reactionary.
Yes, sir.
See now, the approach so far?
Yes. Very nice.
And we all know there is a lot of bulge of the tumor. See this? This is all tumor which is bulging from behind.
Yes, sir.
Last case, if you remember in our last Jain demonstration, we saw a tumor which was coming in the nose, coming in the anterior part of the 45, anterior part of the maxillary sinus, making our life difficult.
Yeah.
Yes, sir.
Similar to the one we had, Dr. Satish.
Yeah. Our next case today of JNA is something which you can imagine all possible difficulties one can pose. With anterior extension, with multiple vessels coming from behind. Yes.
I think, Dr. Satish, what's important here as well, one sees you keep the middle turbinate at all times. You keep that so you have your natural landmarks. You keep that till the end.
This middle turbinate?
Yeah, you keep the middle turbinate throughout your whole surgery. Or are you going to try and preserve this whole case?
I am going to remove it.
But you keep it up to this point, just to keep your anatomical landmarks.
Yeah, because right now, my first goal is to go behind to catch the vessels. And after that, I will come to the turbinate. Because my vessel is coming from here behind. My vessels are coming from here behind. And right now, my goal is to catch the vessels, you know. So turbinate.
I also find it's important to keep the middle turbinate as a good landmark for, to know where you are at all times, especially if you're not using navigation.
Yes, yes. You are very, you mentioned a very important point because it keeps orienting you all the time. See, all this is just... Anupam ko bulana. Just a minute.
Professor Darlene, there is a question to you. Can I ask it?
Yes, for sure. Yes.
Yeah. This is from Dr. Ranjan Roy Chaudhary from Kolkata. He has asked Professor Luke, how common is Jain in South Africa? And is embolization always done in your practice?
So, so we've got a population of about 56 million, and most of the angiofibromas come to Cape Town. And I would say we only do about probably 6 to 10 a year maximally. So it's not, I think, as common as you see in other parts of the world, especially India.
Yeah.
And we always do pre-operative embolization, but I'm very interested to see what Dr. Satish is doing here, and we'll definitely incorporate this technique using the, going around. We always go around the tumor, but I don't use the coblator as the standard, which I think is a beautiful tool. So yeah, so we do probably about 6 to 10 a year.
Okay, thank you. And you have any far experience with the far advanced CT, like 4D CT, angio, etc. in your center?
No, we've never used that.
Okay, thank you.
See, this is the tumor bulge coming from behind. And see, lot of, thin bone over the tumor. You can see all the way.
Yeah.
All the bone being pushed from behind. See this? But this is never thick. See, this is never thick because of the prolapsing tumor from behind. It has become, thinned out. Now I am further improving my lateral axis. I have to improve my lateral axis to get onto the vessel, which is coming from laterally and behind.
Dr. Satish, I've got another question from Dr. Alagudivel from Madurai. So there are chances of collapse behind ala when there is no bone. Do you see that in your practice commonly or not?
Not really. That's why I always mention, when you come to this piriform aperture, see here, don't come to the ala anteriorly.
Okay.
If you damage the lower alar cartilage, that can happen. That you have to be careful.
Okay.
See, I am more and more improving my posterolateral axis.
Yeah.
Yes, sir.
It is all about axis. This surgery is all about, rather any skull-based surgery, is all about exposure, exposure, exposure.
So in this particular case, you can even remove the entire lateral wall of the maxilla to have the access?
If needed, I can, though it is not required.
Required. Okay.
See what exposure I am gaining here.
Yeah.
Is to improve my access to the vessel.
That's it.
Not to the tumor directly. Okay. That I am not going to remove the entire tumor lateral part. For that my access is good enough. Because I have already shown a couple of times, I will divide this tumor once I take the vessel in control. First remove the medial part and second remove the
lateral part.
Lateral part once I get enough space in the nasal cavity.
Have you used? Have you used external manipulation with the help of index finger or anything from the oral cavity posterior?
Yeah. That is mentioned for all cheek extensions. You can push from that side, but same thing can be done by pulling from this side.
Okay. And when you're pulling from this side to get more access, would you do a little bit of window in the septum so that the assistant
not really. This Denker, see the access.
That is enough.
That is more than enough. The access given off by the Denkers is more than enough. Now, my next goal is to open up this bone. Give me coblator. See, this is my infraorbital nerve. You can see very clear.
Yes, very clear.
Here it is. Can you see this?
Yes.
Hello?
Yeah, we can see it, sir.
So now we have reached the limit. In case you have to go beyond, I can transpose it, completely transpose it. This is one of the technique proposed by Professor Paul Casanova to transpose the V2. See, now I am removing the bone from over the tumor which has prolapsed, you know. And we have seen on CT angiogram, our vessel is running anteriorly. See this?
Yes, sir.
Behind what you see is the periosteum of the pterygopalatine fossa. And behind this periosteum in the pterygopalatine fossa, you know, the vessels run in the anterior plane. I hope the picture is good there.
Very
Yes,
nice and clear.
very nice.
Thanks to Mr. Dinesh, who gives this transmission, who does all this for us. See, I will remove this entire bone anterior to the tumor cord completely, so that I can enter to the anterior wall. See this little bit of the oozing from the periosteum.
Yeah.
I can any point of time take into control with the cobblator. Let me show you.
So once this periosteum is gone, you will get the fat, Dr. Satish? Is that how it
Yes.
comes?
Yes. So there is fat anteriorly, sometimes it is compressed. See this anterior wall. You can control this oozing this way. See what the cobblator is. What a useful tool it is.
Superb tool. We being a sleep apnea surgeon in addition, we are fan of this tool.
Yeah, in sleep apnea you have immense
Especially
role of
on the
this.
tongue base.
Yes. You are versatile.
And this particular wand is so good and aggressive.
Yeah. See this complete removal of this?
Removal of the bone. Yeah.
Bone anterior to the tumor from all around I am ensuring.
And where is the infraorbital nerve? Can you just show us how it comes?
Infraorbital nerve is here. Already we have seen this is going there.
There, okay.
The tumor which is, coming from behind so much anteriorly, it displays the structures,
Yeah.
What is the instrument you are using? Silver? So this
No, this is a curved for Blacksley.
bless.
Just curved Blacksley, nothing else.
I've got some questions from the audience. I'm just asking it. Dr. Anuj Kansara from Ahmedabad has asked, what are the chances of atrophic rhinitis post-operatively in this case?
Not really. Atrophic rhinitis as such is a different disease. That's an immune complex disease.
Yeah.
Which is basically vasculitis of the vessel supplying this region. And that leads to, that persistent crusting and dryness. Here, after change in the nasal flow dynamics and raw areas, in the beginning you may have some additional crusting. Yeah, but with the regular douching and cleaning, you overcome this, and couple of weeks after the surgery, it gets mucosalized and it doesn't lead to any additional problems.
Dr. Mukesh Edward from Melbourne has asked a question. Can you do a blunt dissection with cotton to get the access?
Yes, I am doing in between, and I intend to do more. You're right.
Dr. Salat from Islamabad has asked, please ask the landmark in the lateral wall to find piriform to prevent injury to the lateral cartilage. I think he has shown it.
Yes, sir.
Piriform to avoid injury to the
Lateral cartilage. Piriform, alar cartilage, I think.
alar cartilage. Just stick on the anterior limit of the piriform aperture and don't try to come forward. That's it.
I'm just asking few questions, Dr. Satish.
Yes,
Dr. Prakash Munka from Bokhara Steel.
Yes.
Good afternoon, sir.
Good afternoon, sir.
There is DNS and turbinate hypertrophy. Will you like to make more space by removing? I think I have addressed that.
Turbinate?
Turbinate hypertrophy and DNS, deviated nasal septum.
Yeah, if it comes in the way, obviously you have to deal with it. Anything coming in the excess, you have to deal with it. As simple as that.
Dr.
Maybe it is turbinate. See, turbinate we have already removed. Turbinate is already gone.
Dr.
Turbinate
is already gone.
This tumor almost always have an attachment to the middle turbinate as well.
Yes, sir.
Almost always, and that also we remove most of the time.
Yeah, mostly the postero-inferior part, right, Dr. Satish?
Yes. See, now removing more and more bone. Okay. Every part of the bone I am removing to enlarge my exposure.
Yeah.
Simply to enlarge the exposure.
Dr. Tushar Sharma from New Delhi. Good evening, sir. When do you go for external carotid artery ligation in the neck?
Rare.
Very rare.
But yes, embolization I would consider if I have multiple feeders, not only the internal maxillary but other vessels coming from behind supplying. I would take the help of...
I came across a very good article wherein they are mentioning about 4D CT angio. In this 4D CT angio is not just 3D but also 4D, wherein it tells us the flow of the vessels, that is the contrast through the vasculature in dynamic imaging.
Yes.
So by doing so, it tells us which is the dominant vessel, and also which tells us if there are multiple vessels, how it is coming to. So do you think this may have a role in our JNA especially?
Yes, it can have. See, if you get any additional information, why we are getting the CT angiogram which I had shown you. We always get a CT angiogram.
Yeah.
That is our first investigation, not MRI. You don't get always MRI done. Because CT angiogram gives you a by and large information about the vessel supplying. Not only that, how the vessels are entering into the tumor.
Yeah.
See this tumor now exposed from anteriorly?
Yes, sir.
And now I will open up periosteum a little bit, At one point of the, I can see my periosteum opened up. Can you see?
Yes, very clearly.
Yes, yes, yes.
And that is the tumor surface. And that is how I am going to go on to the tumor vasculature now.
Yes.
Which is, I know from my angiogram, is coming from anterior to the tumor. Just like this. Can you see the vessel behind?
Ah, yeah.
Yes, sir.
There you go. Yes, yes, yes.
Let me clean this field first.
So how much topical adrenaline are you using on the...
1:1. These are young patients. I can afford to use 1:1 without any problem. Coagulation. See my vessel behind.
Yeah.
What I intend to do here,
the structure behind what you're coagulating, is that
this
the
is the
vessel?
periosteum.
Yeah.
This is the periosteum which I have coagulated, you know.
Yeah. And the glistening thing that we see most likely.
Yeah, that is what I'm looking at.
So usually we see a fat plane also. There's very less fat.
Pardon?
So usually we have fat plane also.
Yeah, but with it, that is compressed because of too much of the mass lesion.
Yes, yes.
Scissors. See this massive prolapse from behind.
Yeah.
That makes your life difficult, you know. You have to be prepared with this.
So many audience are asking, can you show an external camera to see how your assistants are assisting while you're doing
last time also I wanted to show, and this time we installed, and a couple of minutes coming, the external camera.
Yeah.
Coagulator. See, I am opening this space.
You need to have a good assistant to do all this.
Yeah, you have to form a team, boss. Just now, leave it. Now give me a good wash. I will remove everything and then show you again. Wash, give me.
I know you are in the critical phase. Can I keep asking questions, Dr. Satish?
Yeah, all the time. Please, feel free.
Dr.
See the tumor now, very clear?
Yes,
very
sir.
nice and
Yes.
clear.
Coagulator.
Dr. Kantilal from from Pune has asked, is there a role of lateral rhinotomy with medial maxillectomy in this kind of tumors?
Not really. See, I tell you the reason behind that.
Yeah.
What does this endoscopy give us? This gives us amazing visualization. On-site, visualization. Magnification. Here you go.
Panoramic view also.
Yes.
When you do just a lateral without any...
It's not that avoiding a scar is the advantage.
The part that you would achieve by lateral rhinotomy, you have already achieved with the Denkers as of now.
The advantage is the visualization.
Yes.
See, as we go behind to the pterygoid part, see the vessel.
I think that is...
Yes.
I think that's the vessel.
Yes. But what is your take on maxillary swing, Dr. Satish? Along with the after maxillary swing using endoscope?
Give me the section. Rakhna. Pardon? After the?
Do a maxillary swing and then using an endoscope.
Maxillary swing is a different approach with different advantages and different goals. That is a useful approach everyone should know and keep in the armamentarium once you plan intend to do such surgeries. As far as open approaches are concerned, maxillary swing is one of the open approach which gives you. Can you see the huge vessel?
Yes, sir. Very clear.
Oh, wow.
Population. See the beauty of the coagulation.
Yes.
Yeah.
Sometimes you can use it as a dissector, you know. See, I have coagulated that vessel.
Vessel, yes. I was just about to say.
Now I am coagulating all these vessels, leave it, on the surface, you know. See that?
Yeah.
And this is the vessel. Here. This is what I wanted to.
So what is the size of the vessel that you think can be just coagulated even without the use of...
See, even in the beginning, if I happen to coagulate to get rid of the vascularity, to get rid of the bleeding, doesn't make any difference, because once I remove the lateral component, I will face the vessel per se, and then you can, you know, clip. Okay. But it is always advisable to use a clip on the large size vessels, you know. Smaller size, no issues.
And any particular diameter in your mind, which we can say smaller size, larger size?
Beyond 3 millimeter is a larger size vessel.
Okay.
Yeah.
So is it
see the main vessel now?
Yes.
That was one of the branch, and this is the main vessel, you know. What I was telling is, at this point of time, you know, even I can take this main vessel in control with a coagulator.
Yeah.
But I cannot rely it for, you know, for long. So what you can do, right now you can coagulate, you know.
And then put a clip later.
Later, once you remove the tumor, the lateral component, the vessel will come in front. And
but when you have the tumor, it will give you more firmness to put the clip rather than if it is not there, no, Dr. Satish?
See, it is so adherent.
Okay.
See, within the convolutions of the tumor, you can see this vessel.
Yes.
See this?
Yes.
Yes, sir. Very big vessel.
I can try to separate, but I can injure the vessel at this point of time. Section.
Dr. Palniappan from Trichy has asked the vascular clips. You would be using it here, and if so, size.
See, I have shown you several times the vascular clips.
Yes.
sir.
What size you would use? 200, 300?
200 most of the time.
Okay.
Most of the time 200 in JNA. And you know, the clips can be applied only when you have a complete vessel in a loop, you know, where you can apply the clip circumferentially. Now see, I know my vessel. See this?
Very nice.
But the problem is, if I try to separate circumferentially, I can end up injuring this. So what I will do at this point of time, see now.
I think Professor Darlene wants to talk.
Yes.
No, Dr. Satish, I just want to ask you, it's a magnificent exposure that you have. Do you, it seems like everything is done through one nostril. Do you find for most angiofibromas, you can work with multiple assistants and instruments through one nostril? Did you get enough access?
You can use another nostril as a port for more instrument. Yes, you can.
I think it's, do you work with the same assistants for a long time, or you have different residents assisting you all the time?
That has been our policy, which we, you know, what I have done, leave it. See what I have done, I'll come to your point. I have coagulated this vessel here rather than catching it right now. Okay? Hello?
Yes, sir.
Yes, sir. Yes.
Yes, very nice.
I have coagulated to devascularize at this point of time till I operate and remove this tumor. When I remove the lateral component, I will again come to the vessel. Okay? And then put a clip. Okay?
Yes, sir.
Now coming to what Professor Darlene is saying, is to use the other nostril as a port, you know, to introduce more instrument. That is a good strategy, and we have been doing couple of times. That you can do, I am not against that. Now, this is middle turbinate, you know.
Yeah.
Now is the time for me to remove this middle turbinate. Now is the time for me to expose more and more from up and behind, you know. Now first let me expose the medial wall of the maxilla completely, straight forceps. This region completely, this bone has to go completely till the posterior wall.
Right.
What I have achieved so far is just devascularizing the tumor. Can you see?
Yes.
Yes, yes, sir. Nice and clear.
Sir, your take on using a monopolar cautery around the vessel internal?
Not yet. I have not used monopolar cautery yet.
But I've seen you use it sometimes.
Yeah, I have used earlier. I used to use, you know, the insulated forceps to catch the vessel and coagulate it.
Now you don't no longer use that?
No, more and more this thing, coagulation and a clip. Now see this bone in between. This is the tumor which is coming out of here from the sphenopalatine foramen.
Yes,
see this part of the tumor on this side and this side?
Yes.
What I intend to do is removing the intervening
bone.
Yes, bone and the part of the soft tissue, anything here.
And the sphenopalatine artery would be coming right there?
Yeah, it is passing through the tumor only.
Tumor only. But it is already addressed with your
coagulator.
One piece. So I will make this as a one component all the way.
Yes, sir.
Between these two components of the tumor, there should not be any intervening bone. Yes, keep it like this and removing this intervening bone as well.
Sir, Dr. Giyas from Peshawar is asking if we are getting excessive oozing, can we block intermittently external carotid artery by bulldog?
That doesn't serve that purpose, sir, much. Believe me, that is hardly of any use.
Yes, sir.
But yes, you know, if you are scared, you want to, there is no harm, I would say. Because the goal is tumor removal. Goal is to minimize the bleeding. See that tumor? Medial component,
yes,
lateral component together.
Yes,
can you see now?
Yes.
Yes, very
This is the place where I am going to divide this tumor later on. That is the bottleneck. You can see very clear now.
Yeah.
Okay?
Right.
So in next 10 minutes, I will complete my exposure now from above and behind and everywhere. One more. Now at this point of time, I will just pack for a minute here and reorient you. That is my lateral component. See all the way. That is the medial wall of the maxilla. This is my tumor all the way. This is the turbinate above and the sinuses above. This tumor happened to, you know, ascend into the sphenoid sinus, never through the ostium, but either through the pterygoid or through the floor. Now I am removing this middle turbinate properly. I have to ensure if any tumor ascending in the sinuses. What I need to do now? For superior and posterior exposure to see this tumor, if it is ascending to the sphenoid sinus, ethmoid sinus, see now I am doing ethmoidectomy.
Right.
Yes, sir.
And my lateral limit is going to be the lamina. See this? That is lamina papyracea. Can you see?
We can see.
Yes, yes.
And now keeping that as a lateral limit, I can carry out the ethmoidectomy in no time. this ethmoidectomy will give me a superior exposure of the tumor. As I told you, I need to have a 360-degree exposure.
Yes.
Yes, sir.
So here I will remove, open up the ethmoid to ensure there is no tumor. Superior limit of the tumor I need to define. See this? My tumor is below. I am defining my superior limit. My 90% of the time, as I said, is going to go in exposure. And this is what we are doing. We are not in a hurry to go into the tumor at this point of time. Scissors, scissors. Now see, this is your, see this. This is your tumor behind, and this is your tumor medially. See this?
Yeah.
Above, it is absolutely free. Similarly, medially, I need to see, go behind and see if the tumor is going in sphenoid. Most of the time, as I said, it ascends through the floor. See, the more anterior part I don't need to go because we don't know. We know there is no tumor there.
Right.
Superiorly. But yes.
So, Dr. Satish, I have a question.
Yes, please.
So let's say that, I mean, many situations we do have the tumor coming so anteriorly that you will not have this much of space to work on the sinus and all.
Exactly.
In that case, since you
have a case in the evening, exactly.
Oh, okay.
Tumor is right coming up to the anterior nares, you know.
Nares. So in this case, once you achieve
it looks like a sphenoid.
Yeah, nice.
Let me confirm. I am not
Is it
sure about this unless I see him. But yes, I am widening this ethmoids.
Yeah, that looked like roof of a posterior ethmoid. So my question is, like, in those cases, as soon as you have achieved the control over the vessel, can you go for the piecemeal removal?
Yes.
If the,
at some part in the anteriorly, you have to coagulate and remove it piecemeal.
Okay.
To get some space to maneuver your instrument.
Yes.
Okay. Once you get some space to maneuver your instrument, it comes to same. See, that is the anterior wall.
Nice and clear.
See, I have kept my gauge piece over the tumor.
Yeah.
Yes.
See, remove this and see, this is the tumor.
Tumor. Yes.
See, this is all tumor.
Yes, sir.
So, wash.
So, in the case that I had a discussion with you like at 10 days back, sir, so that was exactly the problem. So it was coming all the way till the nares.
Wash.
So we had to actually, it was actually the tumor that was bulging into the maxillary sinus. So it was even more difficult to get access, get the vascular access also.
Yeah.
So with the difficulty after coagulation of the tumor, with the narrow space, we achieved the vascular control.
Yes.
And then we had to go bit by bit and we had to remove the tumor in the nasal cavity and in the vestibule. Yeah. And then we had to go to the posterior.
So you have to make your space somehow.
Exactly, yeah.
Now see, this is your the sphenoid sinus, most likely.
Yeah.
I will confirm after. This is the tumor which is attached to the nasal septum here. Can you see here?
Yes,
you can see.
Very clear. And here
Very
what
clear.
I can do, I can devascularize.
Yeah.
See, this tumor here acquires the vascularity again, sometimes from the opposite side. Okay. All midline vessels. See this tumor I have separated subperiosteally.
Yes, sir. Very nice.
Of the sphenoid wall. Can you see?
Yes, sir.
Yes, sir.
This is of the sphenoid wall, subperiosteally.
So you will be doing posterior septectomy in this case or not?
I will, because we have a huge nasopharyngeal component, huge like a ball. See the anterior wall of the sphenoid.
Yes.
You have to completely ensure that no tumor is going inside the sphenoid, and now you can be very sure. Can you?
Yes, sir. Yes, sir. Very clearly seen.
Secondly, this tumor doesn't involve the mucosa of the sphenoid at all.
Sphenoid.
Doesn't take attachment to the nasal floor. See, all this periosteum which is attached, it gives some sort of oozing, you know.
Yes, sir.
Which I can control with my coblator.
I think the coblator is best used in this place where it separates off the mucoperiosteum from the tumor very nicely.
Yes.
So I think we discussed
everywhere on the tumor surface, you can use the coblator so easily.
Yes.
I have few more questions from the audience.
Yes. So now, so far, what I've achieved the anterolateral exposure. See this?
Yes, sir. Yes.
Superior exposure, posterior superior exposure. Now what is left for me before I start removing the tumor? The superior, the medial and the posterior exposure. See now, very clear from above?
Yes, sir. So we discussed that the ossification process of the sphenoid bone is different from the other bone. That's why the tumor doesn't arises from the sphenoid bone.
Dr. Vic mentioned last time.
Yes, sir. Very nice point he told.
Yes. See this. This is the tumor which we have separated from above. Laterally, we have coagulated a vessel, and now I am going to go behind because this tumor is prolapsing in the nasopharynx.
Nasopharynx.
Why behind? Because this tumor has an attachment in the roof of the nasopharynx. You know. So I intend to do here a posterior septectomy behind the level of the tumor, not the entire septum. See the anterior surface of the tumor?
Yes, sir.
Only this little part I need to remove to go to the opposite side, you know. And I will separate it from the roof of the nasopharynx.
So there is a question from Dr. Sandeep Mehta from Ahmedabad.
Yeah.
Is there any chance of empty nose syndrome in this patient?
Not really. See, these patients otherwise do not have any immune disorder or anything. These are young patients. Only thing is this tumor for which we have to remove a lot of this. So they do not develop by and large all this. See now, I am removing this part of the bone. Going to the opposite side, can you see?
Yeah.
Only this part, and I will separate the nasopharyngeal attachment, and I'll cut away any blood supply coming from the opposite side, you know. Because that is the area where the tumor acquires most of its blood supply from the opposite side if it is coming. See the opposite mucoperichondrium?
Yes, sir.
Mucoperiosteum here because it is bone.
Question from Dr. Talak from Islamabad. Does using a coblator increase the risk of infection? Excessive use of bipolar increases it's due to a lot of
Coblator is by and large as compared to other tools is safe because it is all the time being irrigated.
Exactly.
It's not giving that much of collateral damage as compared to the cautery and other things.
Pottery will char everything.
Yeah. See, this is the mucosa of the opposite side. And if I open this, see, going to the opposite side.
Opposite side. Yeah, yeah.
Very nicely shown.
That is the inferior turbinate.
Yes, you can see the inferior turbinate.
That is the inferior turbinate. That is the remnant of the septum. According to the need, you have to go behind. See the Eustachian tube on the opposite side?
Yes,
Yes, sir, yes.
And now, this is the midline.
Little
See
bit
this?
of sedimentary
Here I am segregating by drawing a line deep to the bone. See this?
Yeah.
Yes. To remove any blood supply coming from the opposite side.
Okay.
To cut off. Below is the adenoid surface, which never gives attachment to any tumor, you know. Never ever. So it is above the adenoid level, higher to the adenoid level, that you need to work.
Dr. Fazali Wahid from Peshawar, Pakistan.
Yes.
If one hasn't had access to Coblator, what to do if I want to remove such
Later
tumor
makes your life
endoscopically?
easy. You can keep doing by other tools slowly.
Yeah.
But see, Coblator is
Can suction
I would
diatom
say can
replace-
make your life so easy. It is a essential tool, I would say,
I think
if you
so.
ask me.
Dr. Mlauzi from Cape Town. Can
now,
suction diathermy?
I have separated from the nasopharyngeal roof, from the opposite side.
Yeah.
Yes, sir.
And little bit I will separate more on this side as well. Some more.
This part of the
See this
tumor
nasopharyngeal roof.
Yes.
Yeah.
Coblator works very nicely in this part.
Yeah, this Coblator has a huge role here. Otherwise, it's so difficult to handle
Yes.
this area.
Cutting,
Otherwise.
coagulating, all in one. You know.
All in one. Cutting, coagulating, irrigation,
Suctioning,
suction.
irrigation.
See in endoscopy, clearing the blood with the suction all the time is equally important to maintain your visualization.
Yes, sir.
See now, completely cleared off from the opposite side.
Yes,
Yeah.
very nicely.
So we had anterolateral exposure, posterior superior, now the medial and the posterior exposure. See the adenoid surface.
Yes,
Superb.
sir. Yes.
And now it is the time for the tumor removal. So now remember all the components of the extensions of the tumor. First of all, I am going to remove this medial component occupying the nasal cavity so that I can bring in the other components into the field.
Yes, sir.
If I try to remove the lateral one first, the medial occupying the nasal cavity will not allow. You know,
Right.
there is no space. So first of all, let me remove this medial component. Now it is the time for the tumor removal. See, everything is exposed. See the
Yes,
tumor.
sir.
Very nice.
Field is
Wonderful,
good.
sir.
No bleeding.
No, sir. Total
Nice and clear.
360 exposure.
See now, I don't care about little bit of the oozing going on because we got used to now. Now, at this point of time, again, the Coblator is my key to divide the tumor.
Can you
Sir,
show where exactly the descending palatine artery comes from? The
Pardon?
descending palatine artery?
The descending palatine is right had
There?
been here,
This-
right on the tumor, which is probably gone now. See this, coagulated?
Yeah.
Professor Darlin,
I think she is not
Hello?
there. Hello?
yeah, see what I am doing is a plant division. Pakad isko. This is a plant division now. This has been our policy to do in most of the such extensions, to do a plant division. See now, I am catching the medial component. See that?
Yes,
Yes.
sir.
Using my Coblator now, I will divide it.
Ablation mode or cautery mode?
First, first coagulation, then ablation.
Okay.
Because I told you there are number of branches. Number of branches this vessel give, even if you catch one, vessel may not give you the freedom from other branches. See this?
Yes, sir.
See, dividing the tumor like butter.
Cake.
Cautery mode. You're cauterizing it.
It is, the entire thing is this exposure which I have got.
Right.
Exactly.
Wonderful.
Sir, I want to know Vidya sir and Samit sir, what are their approach? Do they do anything differently in this case or same
See,
thing?
this is the tumor which is going in the pterygoids.
Yes.
And this is going to give little bit of the oozing which will control. See now my area, my level of, separation is the medial wall of the maxilla.
Yes, sir.
See all the time. This is my medial pterygoid plate hind.
Right, you can see that.
Can you see this?
Yes.
Yes,
Yes,
sir.
yes.
And this area is the one now which I am separating.
Dr. Udbhav Mittal,
Yes,
the question,
sir.
yeah.
How?
Yeah.
I think this is the best approach that we can use for such kind of a tumor. Always the sure depends on the type of the tumor and the extent of the lesion. And for this type of a
Can you
tumor,
see now my tumor is divided.
yes,
Yes,
The
sir,
lateral and medial component have been divided. Just for this.
Yes, sir.
See, this component is the going into the pterygoid bone. You can see.
Yes. The
There's
one
a
which is-
huge tumor infiltrating the pterygoid fossa.
very good wedge area.
Yes.
We know that. And
we saw
removal of that part, being of the pterygoid, is an essential, I would say, one of the most important part of the procedure to prevent recurrence. So here, this tumor in the pterygoid, I am pressing with a piece of this, Surgicel for a while. See now?
Yeah.
Now see my lateral component and medial component separate.
Right.
Yes.
Yes, sir. Yes.
See, this medial tumor removal becomes so easy. The all difficulty you have to, you come across is during the exposure. See this tumor.
Yes. It's almost out.
Yes.
So Dr. Udbhav, only
Yes.
thing I do differently here is I remove the septum also, so that my assistants can hold the suction. I have more space.
See this?
Nice and clear.
See the tumor. See the Eustachian tube below?
Yes.
Yes.
Yes, sir. Yes,
And
sir.
the tumor which has gone out. See this?
Yes. It's out.
This
Super.
is the adenoid component which doesn't contain tumor. I told you earlier.
Yeah.
Very nice, sir.
See, the medial component came in 5 minutes.
Yes.
So after the exposure, my tumor removal started. I told you, under kar diya na? The next 2 patients are induced.
What is the
So-
next case you bring, sir?
So we have 2 patients next quickly, and then we'll take the inverted papilloma. So next 2 are, one is a adult respiratory papillomatosis,
Oh.
and the other one is an extensive allergic fungal sinusitis, unilateral.
Oh, nice.
We have 3 allergic fungal and 2 with a vision loss.
Okay, okay.
See now, this component I have removed from behind.
Yeah.
Wonderful cases today.
So that is one part. Now the lateral part, again is a cakewalk. See, once I remove the medial part, I have ample of space to deal with the lateral part. Can you see?
Yes.
Yes, sir.
Now I can mobilize the lateral part into my field. See this? So easily. So easily. See this?
Yes, sir.
So now, first of all, cobblator. सीधा करके दे, सीधा करके. So now I will see the the adenoid part first. क्या कहा था? See this little bit of the adenoid tissue, the periosteum?
Yeah.
Are you removing it? Okay.
I will remove this. And below is the simple. This is removing the part of the periosteum. See that?
Yeah.
No tumor over there, just to remove this excess periosteum which we have elevated. And that is the adenoid. Completely, never it takes an attachment. See the eustachian tube on both sides.
Yes, sir.
We are never supposed to damage the eustachian tube at the same time. Okay?
Yes, sir.
Now the next part is, give me a pack here, is the lateral tumor removal.
Yep.
Again in no time, I will remove this, and the last part would be the pterygoid component and the little bit prolapsing into the orbital fissure in the cavernous sinus. See this medial pterygoid plate? Coming like
Very nice.
anything. See, it has become so thin a plate of bone. See this?
Yes.
Yes,
And
sir.
see all tumor inside. I have to drill it completely to remove the existence of the tumor.
Yeah.
Cobblator right now. For anywhere soft tissue bleeding, see this? I have a magic wand.
Hope later.
It gives you so sense of security
Right.
that you have something to control the. नहीं, इसको क्या हुआ है? दूसरी लो. रखा करो नहीं क्या? 1 घंटे में लाएगा वो. Yes, just leave a small pack over here. See this? And now we'll mobilize the lateral component. You have seen this?
Yes.
Yeah.
How big it is, how it is inferiorly going, and see now how you can easily remove it. Again, this is going to be a cakewalk like the medial component, believe me. Hold it.
What about the internal maxillary artery that was attached
Yeah.
to it?
I
that
will
you have
show you.
coagulated?
Once I mobilize, I will show you the artery.
So now is the point where we would like the external camera to see how your assistant is
Yeah.
holding
Just
the
a minute.
tumor, you know.
Come. I am waiting for the coagulation to start.
Okay.
See now. Everything under control.
No bleeding at all. Right?
Yes, hardly any.
So you are holding the endoscope, and once you get a grip on the tumor, you will hand over the.
No, I will keep, my assistant is so trained. See now, I will give him a catch hold of the tumor.
Yeah.
And then we'll play with the traction and counter traction. I will show you.
So now you are holding it.
Strong one. No,
And-
not now. Yeah. See this? We'll
Is that
keep
you holding it,
mobilizing. Keep mobilizing. Yes.
Okay. And now you are giving the forceps to your assistant.
Yes, just a minute. Yeah. Okay?
Okay. So now we have
चालू है?
the coagulator in your hand.
Yes. यहाँ पकड़ो. Pull. See, we have to advance our pull all the time.
Yes.
Traction is important.
Traction. This is a huge component. See this?
Oh yeah.
And this is counter traction by? Wait.
Coagulator.
Yes. traction. Niche. See, this is traction and counter traction.
So is it your routine Blakesley or is it something different?
Pardon?
You get a good grip on the tumor without punching on it. Is it kind of a modified Blakesley or a routine Blakesley you have?
Yeah, routine Blakesley, routine. Now see, what is there above? That looks like the nerve.
No, yeah.
That we have to respect. See this?
Yeah.
Yes, sir.
This is V2. See
So
how
I
you
want
have to separate the V2.
Me too. Again with the coablator.
Yes, I'm using not the. I'm using
Not
it just
near
as
the
a yes
perineum, but just
dissector.
yeah.
See that?
Yes.
Sir. Yes.
So have you come across this trigeminocardiac reflex in your cases?
Only once in life, and we could manage it since we knew that can happen.
Okay.
See, whenever you are dealing with the ophthalmic branches, this can happen anytime.
So you get bradycardia, hypotension, and
Now, see, this is the component which is going behind into the superior orbital fissure. This component, this one, this one.
this one, yeah.
This one which is
Laterally
ascending.
you have the
This is your V2.
V2.
Yes. I'm separating all the time the V2 from my field.
Okay.
And he is keeping a traction on the tumor. I am giving a counter traction on the important structures, you know. This is some vessel over here. See here. I will just coagulate.
So I think this is one of the major advantages of this approach versus the maxillary swing, wherein you will be most likely injuring intraorbital nerve.
Yeah, intraorbital nerve, the lacrimal system, so many disadvantages.
Yes.
Now see the vessel. See, just a traction and counter traction, nothing else. See my vessels coming in the picture?
Yes, sir.
Here, this one I will coagulate again. No worries.
Wow.
See how the coagulator works.
And without even clipping the vessel, there is so much less bleeding in this case. Magic of coagulator.
Yeah. See separated?
Yes, sir.
Now, we'll pull from below. See this component again. See so much of pull all the time.
Yes, sir. Counter.
I told you there is huge component which has gone down and laterally. Imagine, had we not removed the medial part first, how could we bring this lateral part into the field?
Yeah, it's almost impossible.
Impossible. And see the vessel again.
Is this the fat that we were talking about?
Yeah, that is your limit.
Yes.
That fat is your limit.
This one will clip.
I can remove this part of the fat to improve my access. See this?
Yes.
Yeah.
I am removing with the coagulator only. Now, see this vessel?
Yes, sir. Oh, wow.
See this tumor component again coming from below. Yes. See this tumor?
Yes, sir.
Yeah.
This would have been left behind if it's not traction.
Professor Darlene, are you there? You wanted to see this part? I think she went into the car. Yeah.
Yeah, she is in the car.
I think she is there.
Yeah, she is.
See this last part of this
I've got
component.
intermittent. I'm here.
Very nice.
See the last part of this lower part is coming out. See this?
Oh, wow.
Very nice.
Very nicely.
See it is
Beautiful.
full. It is just traction and counter traction. That's it. Everything is coming out. See now the infratemporal fossa, everything. See this? All tumor out from here?
Yes.
Yes.
Infratemporal fossa is free now.
All tumor out from here and I'm coagulating all the time.
Yes,
See
yes.
behind. If I go behind, this is the empty infratemporal fossa.
Yeah.
Let me remove this fat a little bit. There is a vessel into it. साफ करना. See this infratemporal fossa.
Yes.
Yeah.
Let me show you from inside. See, this is. All this tumor is out now from there. Can you see very clear?
Very clear.
Very nice. So without making any other extra port, just because you have removed the medial component, you are able to.
Yeah. Dankers is in itself is complete. See, all this tumor, so many components we have pulled inside.
Yeah.
Still I have to separate. See, just stay on the tumor periphery. Just stay on the tumor periphery and keep separating. See this?
Yeah.
Yeah. Either se पकड़. Yes. See, this tumor is being pushed. Such a huge component. Could you see here?
Yeah,
Yes,
yeah.
Really, very nice.
Dr.
See this,
Anand,
wait. See this?
Yeah.
Now the empty infratemporal fossa. Completely empty. Under vision.
And is there any particular structures that we need to
No,
think about?
all this is, musculature inside.
Okay.
All this is musculature, nothing. And this is the vessel.
Temporalis and pterygoid, right?
See, this is the vessel.
Yeah.
This is the vessel. Give me a clip. This is the vessel.
Where was the nerve again? Can you show the nerve again?
No. Can you show me the nerve again first? No. See, little bit of the
Is that the
oozing
nerve?
because of the some of the small vessels.
Okay. Is that the continuation of the nerve?
Yeah. The nerve is, turning behind. See this?
Okay.
Show down. See, the nerve is turning behind.
Right.
We are leaving the nerve hanging. Yes. Can you see that?
Yeah.
And there is some vessel behind, probably, which
Yes,
I have to
yes.
take into control.
Leader there.
Give me a pack, small pack. A small pack. Where is? See, that is a small pack which I am going to put there for my section to work. I can suck on my pack easily. And this is my tumor, and my, this thing, pack is beyond the tumor. Now, give me the coagulator. This nerve I have to segregate and get the tumor out. पानी डाल रहे हो? See, all the time you have to preserve this nerve. See this?
Yes.
I am segregating. See how close this is to everything. One can easily damage this nerve if you are not careful. Now this tumor component I am cutting here. This is going up in the superior orbital fissure.
Okay.
This I am intentionally cutting so that I can remove it separately.
Okay.
The pterygoid wedge and the superior orbital fissure,
Yeah.
you will remove it separately.
Yeah. See my tumor going more and more inside. Pushed more and more in the nasopharynx.
Yes, sir.
Suction. पानी नहीं डालता. Put suction. Suction. Suction beta. Yeah. Irrigation. Wash. Wash. Telescope. Yes. See now. This is your V2. This is your tumor going above V2 into the superior orbital fissure. That I will show you later.
Okay.
And this is all the vessels which are going to the tumor, and I have coagulated. See this? See
Those
this?
are branches of the internal maxillary or?
Completely separated.
Yeah.
Yes.
And this tumor now will remove. So now, remove everything. I will remove the pack from behind so that I can suction. Wash. See this pack from behind?
Yeah.
I am removing so that I can push it behind. See now, this is the tumor which I pulled from out. This tumor. That is the tumor which I need to separate from the pterygoids. See this pterygoids?
Yes.
Yes, sir. Yes.
That's the pterygoid bone.
Marrow also.
See this pterygoid bone completely.
Clearly,
Yes, sir. Very clearly seen.
And is that the time you get the pterygoid venous plexus?
Let me show you better. Let me divide this. Let me divide it to show you something. You will never be confused. See this. I am dividing it intentionally again. See this. Why I have divided? Let me show you. Please concentrate, get oriented. What I am trying to show you, removing this, I put in the pterygoid process. Remember?
Yeah.
Right.
Yes, sir.
This component I have divided from above, and this I am elevating from the pterygoid bone. See this, the infiltration of the Haversian system of the bone.
Yes, sir. Yes, sir.
How this tumor is infiltrating the bone. See this?
Yes.
Yes. Yes.
Beautiful. I can see the pterygoid network.
Yes. Now this upper part I am again dividing to show you separate removal from the superior orbital fissure. I can remove at the same time as well. See this? See the pterygoid component?
Yes.
Oriented?
Yes, sir.
Laterally you have the lateral pterygoid plate. Medially you have the medial pterygoid plate.
थोड़ा field अच्छा कर.
In between you have the fossa.
Yeah, let me clean the field for you. Yes. Okay. This is the component above the V2. See where I am. This is V2 below.
Yeah.
I have always mentioned the V2 is separated from the superior orbital fissure by maxillary strut.
Maxillary strut.
See this, I am separating the V2 completely. See that?
Yeah.
Now, give me this part of the bone. See this. This is V2 going in the foramen rotundum here. Okay?
Yes.
And this part of the bone above the V2, that is maxillary strut.
Yes. Yes.
Clearly seen here. Yeah.
Clear?
Clear.
Very nice.
This is V2 and this is maxillary strut, and
And
above
above
that,
is the
this is the superior orbital fissure. Look na. And now let me remove this bone here to show you better. Where is superior orbital fissure? Let me show you something.
anterior to the cavernous sinus region.
Yes, see, this is sphenoid. In the sphenoid,
So the
This
continuation
is
of
the
cavernous
superior
sinus.
orbital fissure here, which is the anterior continuation from the cavernous sinus behind.
Cavernous sinus.
Parallel to the sella is the carotid, and below and anterior, this is superior orbital fissure.
Yes, sir.
Now this tumor is going there. See this here inside.
It is inside the
See this?
Yeah.
Yes, sir.
And
Yes,
from
sir.
there, Carison, from there it is going behind to the cavernous sinus a little bit.
Yeah.
So let me open up. I was trying to show you separately, but I can remove it along with. See this superior orbital fissure component? Can you see it?
Yes.
Yes.
Going up, you saw in the scan.
Yes, sir. So both in inferior orbital and superior orbital going in both the fissures.
Yeah. See that component going in the orbit,
Yes.
orbital apex. That is the orbital apex, and that is the superior orbital fissure. See that? Could you see now very clear?
Very nice.
And this component which is going inside has to be pulled in the same way. See this? See this tumor? This is tumor, this one.
Yes.
Yes, yes.
And see it is out.
Very nice, sir.
Out completely.
Section lagao.
You can see the
See that?
bleeding. Yeah.
That is a narrow conduit. See this? Absolutely clear. What you see behind is the periosteum of the carotid artery. Can you see?
Yes, yes, very good.
Yes, sir.
That
Yes, very
is
good.
your, you know,
You don't get the bleeding from the cavernous.
no, the tumor clogs itself. Tumor itself clogs. See this. Cavernous sinus, if the tumor is going, I'll show you after this how the different extensions of the cavernous sinus you can remove. So one of the video recently, the day before we have done.
Okay.
See this. This is your V2. Can you see?
Yes.
Yes, sir. Yes,
This is
sir.
V2, this is maxillary strut, and above that is superior orbital fissure. Clear?
Yeah.
Yes, sir. Very clear.
This is all pterygoid component which we have removed. Above this is this one, and this is the lower one. See this bone?
Yeah.
This bone invades the Haversian system of the pterygoid process. See how it is removed?
Yeah. And the third plexus of veins will be in there.
See this, how big the tumor is, cannot be removed from the nose. It is too big. See this entire tumor?
Yeah.
Yeah,
Yes,
good.
sir.
Now
Yes,
let
sir.
me pack for a while and remove it from below. I will show you the entire area where I have gone, the anatomy. Once I remove this tumor from below. Let me remove it from below. The last part, okay?
Yeah.
Section. See, you have to have a patience of exposure. What all it needs is the patient for exposure. See this. See this. The huge component which has come.
Yes.
Hello?
Yeah, yeah. You can see it.
Now wash. Thorough wash. I will remove all packs for you. This is pterygoid venous bleeding. Let it be. I will not stop it. I told you the reason earlier. Never ever try to go after the bleeding here in the pterygoid process, because if you try to press, you may further push the micro invasion of the tumor if there is inside. So what? Seedha there. Seedha laga ke de. Now I will show you. I have removed all packs. See this? Hello?
Yeah, yeah,
Yes,
yeah.
sir. Yes, sir.
You can see.
I welcome this pterygoid bleeding here. See this?
Yes.
See this pterygoid bleeding?
Yeah.
This is the infratemporal part. एक pack section और देना. See the nerve overhanging. See the infratemporal fossa, all muscles.
All clear. Yes.
Yes, sir.
The muscle lateralis is the temporalis and
Yeah,
the
that vertical muscle is temporalis. This vertical.
Yes.
This vertical. And this is lateral pterygoid.
Lateral pterygoid. And the lateral pterygoid plate?
Yes, that is the lateral pterygoid plate. And see, this is the horizontal fibers of the lateral pterygoid.
Yeah.
These are the vertical fibers of the temporalis. And this is all pad of fat. See this?
Yeah.
No tumor. The tumor came out intact.
Yes,
And where is the vessel that we coagulated?
Yeah, I coagulated at 3 places.
Yeah.
so we can see the Meckel's cave also in this case, na, by distinct.
Meckel's cave is not here. Give me a pen. Meckel's cave, you need to go in the paracellular region, in the quadrangular space between the, the horizontal petrous and the vertical paraclival carotid.
Okay.
And then you go behind at the petrous apex is the Meckel's cave. In one of the patients of the allergic fungal disease today, we have disease going to the petrous apex.
Okay, okay.
Cavernous sign has completely given bilateral abductor palsy. In a non-invasive fungus, allergic fungal sinusitis, which I am going to show you. This is just for suction. No, don't pack. Drill. Now, having done this, my last goal is to deal with this pterygoid. I told you this pterygoid is a big nuisance. The biggest cause of so-called recurrence is almost always this pterygoid. See this?
Yeah.
Because the tumor entering into this Hertzian system of the bone can be overlooked, and my goal is now to destroy this pterygoid.
Okay.
I don't want to leave finally any possibility of any failure. See this bone I am removing?
Yes, sir.
Fantastic.
Yes.
Lateral pterygoid.
See
So you
this?
mix the foramen rotundum and the pterygoid.
Foramen rotundum is above.
Exactly.
The rest of the median and other canal are destroyed by the tumor.
Tumor.
Those are inferiorly, and many of the time when the pterygoid is involved, the first structure to get involved is the pterygoid, because pterygoid canal, because that is in the closest vicinity.
I think Professor Darlene has come in, so you can talk to him.
Yeah.
Professor Darlene?
Satish, yes, it's a beautiful dissection, I must say. It's really wonderful to see. I just would like to get your opinion on that earlier question about the risk of atrophic rhinitis. And what I found with all our medial maxillectomies, not only for angiofibromas, but inverting papillomas, also for malignancies, is the only time that you get crusting, even with a complete resection like this, if there's a little bit of bone that's exposed.
But it
there's,
mucosolizes very fast with the irrigations.
Yes.
If you see, I can show you my follow-ups after 8 to 12 weeks, and it mucosolizes very fast.
Exactly, but if anybody gets crusting, it's usually a little bit of bone that's necrotic, or it's tumor that's left behind in the case of inverting papillomas or malignancies. That's just been my experience.
See now, what I'm doing, I'm using now not the coarse diamond, using the diamond drill.
Yes.
See this pterygoid?
Yeah.
See, to flush this pterygoid, all these,
So as to prevent the future recurrences?
Yeah, put this Shanti Rakh. Yes, for the future recurrences. See this complete removal of this bone. Go back. See, let me show properly. Yaar. See, Naresh.
Dr. Abdullah from Iran has asked, when will be the first endoscopic evaluation to remove the cutting and cavity cleaning?
When is the first day?
Endoscopic evaluation?
After 10 days.
After 10 days.
Yeah. One day after removal, we will put a pack in this patient for a day or two. Even if it is not required, we always make sure to put a pack. Because in the post-op patient are terrified even with a drop of blood.
Yeah.
And this particular problem, when the patient has come for the bleeding management only, any small bleeding coming terrifies.
Yeah,
And
there's no
then
harm
there
in-
is a call for you.
Yes.
Exactly. Dr. Kuldeep Avoni from Kota has asked, overall approximate blood loss in this approach?
In this patient,
50 ml,
around 200 ml.
150 to 200.
Sometime even less.
Yeah.
See what I am doing. I am excentrating all these cells.
Dr. Ramesh Rohiwal and many others have congratulated you for giving a wonderful clearance.
Thank you. And I suppose with the different extensions we are showing,
Yeah.
everybody can do now with all these difficulties posed by different extensions. And the
true.
second case today
Yes.
is one step ahead than what we have done now. At the huge cavernous extension, parapharyngeal, pterygoid fossa, lateral, and the tumor is coming right to the anterior nares.
Okay.
See now the pterygoid process?
Yes.
Beautiful.
And can you show where the median would be approximately? Where it,
Median is, this is the sphenoid sinus.
yeah.
Here, median is roughly here, running along the floor of the sphenoid sinus,
Okay.
laterally. So here, in this case, median, most of the time we have to, coagulate that. We have to drill the median canal completely.
Yeah.
Majority of the time, I always, make sure to, if it is not involved even, to open the median canal to see if there is any extension of the tumor inside. See, this below is the muscles, pterygoid muscles.
Yeah.
Pani band karna.
And can you show us the anatomy of the carotid and just kind of tell us how it courses?
What?
You have a very beautiful field. Can you show us the clival and paraclival carotid and course of the carotid artery?
Yeah, course of the carotid.
You have a very beautiful field.
No, the sphenoid is not so big in this patient.
Yeah.
What I will show, in the allergic fungal patient, I told you,
Yeah.
it is too pneumatized to have gone to the petrous apex.
Okay.
And I am expecting everything in the sphenoid to be decent. Straight laga ke.
Oh, okay.
And I will show you the complete anatomy in this. See now the inflammable fossa, no bleeding
Nice
at all.
Nice and clear.
See this? This is your pterygoid process now.
Yeah. Drilled
Gone.
already.
No scope of any tumor left behind.
Yes, nothing.
And
This is
for
all
this,
venous bleeding, little bit. You have to pack, it will stop.
with this just Surgicel or chloramphenicol Surgicel or I remember you using a chloramphenicol with the Surgicel combination.
Yes.
So do you still use it?
This is so simple. Even I drill.
It is a small one.
If
Yeah.
I drill for a while, it will stop.
Yeah.
This is hardly anything. See this? And this is the panoramic view. Panoramic view of the entire field. Chhodna. See the entire field. Nasopharynx,
Beautiful.
everything.
Fantastic. Each and every point that you mention is
See the beauty of removal of the anterior and the medial wall of the maxilla. See this? You have an unparalleled access with a 0 degree to the paramedian skull base. Okay? Now, suppose this tumor had been going somewhere else from here. Now suppose where this tumor go to the temporal lobe of the brain.
yeah.
Section. See this? Above the V2. What is this? This
Base
is,
of the
if I remove this, would be the temporal base. Can you see this bone here?
yes.
That is the temporal base. And if I drill here, see the bone.
Yeah.
If I drill here, I'll be right in the temporal lobe floor.
That is the greater wing of sphenoid, right?
Yes, greater wing of sphenoid. So, this is V2. V1 is going through the superior orbital fissure. What this triangle is? The anteromedial triangle. Okay? And look at that. Anteromedial triangle is the commonest area through which the tumor goes to the intracranially to the temporal lobe. Then between this is V2 and my V3 is behind. See, this is lateral pterygoid muscle behind.
Yes,
Yeah.
sir.
Got the pterygoid plate here. If I go behind and up there,
Yeah.
go behind and up there, see there,
Yeah.
I will find the V3.
Foramen.
V3 there up.
Foramen.
This is V2, this is V3, and in between this bone, what is this? The anterolateral triangle. If I drill through this bone, again I will be in the temporal base.
Okay.
So through these two triangles, most of the time tumor ascends into the temporal lobe, the middle cranial fossa. Okay?
Very
And
nice.
similarly, had this tumor been ascending up in the middle cranial fossa, what would I do? Simply, I would enlarge this opening. Wherever this is going through, maybe anteromedial or lateral, I would remove the bone further all around and pull the tumor out like we pulled from the superior orbital fissure. Just opened widely and pulled it. Okay?
Superb.
Last case, today we'll have a tumor extension. That's the Vedian canal. You wanted to ask?
Yes, yes, yes.
See, this is normal until you have to drill it all the way.
Dr. Satya Prakash Dubey from Bhopal, mesmerized surgery, Satish Bhai.
Oh,
What are the
sir,
post-operative
you're watching.
management?
Obliged.
What are the post-operative management? How long the nasal dosing with saline?
Just juicing, nothing else.
How long? How many?
Yeah, this will require few months. See this, no bleeding at all.
Yes, yes, wonderful.
It's a matter of exposure, patience. See this?
Yes,
And
sir.
see the advantage of flushing with the floor. It will epithelize fast. See now my instrumentation is unimpeded if I pass through it. Had I not removed this bone here, my instrumentation would have been difficult. The only area which we have not explored here is the parapharyngeal space. That is behind this pterygoid. Okay? If this tumor, the last case we have a tumor going to the parapharyngeal space, and then I will remove the pterygoid process completely. See this. After removing this little bit of the bone, pterygoid is left little bit of
Yeah. Yes. Very
Yes,
nice.
yes.
Yes. Fabulous. Fabulous. Fantastic work.
Wonderful, wonderful.
It's a beautiful dissection. Thank you, Dr. Satish. Do you do a routine? Do you do a routine MRI in a year's time, or just follow up endoscopically?
So
Do
post-operatively,
you follow them up just endoscopically, or would you do a MRI or CT in a year's time?
Some voice loss is there. Some voice loss is there. Dinesh?
Dr. Satish, I think the question what she asked was like would you do a post-operative imaging like MRI or a CT?
Yes.
Fabulous. I think it's already connected. Yeah. Mm-hmm. Yeah.
Yes,
Yeah.
yes.
Yeah. Yeah.
Yes.
Yeah.
Yeah.
Dr. Satish, wait. Satish, wait. So some issue with the YouTube. Your voice is not there. Wait. On YouTube, your voice is not there. Just
No.
wait.
Yes, sir. 1 second. Going, sir.
No.
Yes.
Yes. Okay. Yeah. Yes. Yes.
Yes, sir.
Yes. Yeah.
Yes.
Yeah. Yeah. Okay. Cavernous. Cavernous carotid area. Yes. Yeah. Yes. Mm, exactly. Yes,
Yes.
yes,
Yes, sir.
yes, yes. Yeah.
Yes, sir.
Yes. Mm, And the cavernous bleed will not be there because the tumor is there. Yes. Tumor.
Begin next second.
Separate incision lateral to it.
Yeah.
So it is your imaging which dictates. That is the point which I wanted to say here. Okay?
Fantastic.
Wonderful.
Now, the next case, I will show you something. This patient is a case of, as an adult female with multiple papilloma larynx, proven case, operated earlier. As I mentioned earlier in the last, of our webinars, we do a lot of things with the papillomas. Surgically, not aggressive removal, but yes, the adjuvant treatment is more aggressive. So
Yes.
two cases I am going to show you. One is, not this, yeah. So what we do generally is this therapy. Monoclonal antibody, bevacizumab, celecoxib, as a adjuvant therapy, then HPV vaccination, PPI, and this broccoli and all these things. We ask the patient to have more and more. Now, this patient is induced, and what I'm going to show you, the other patient, which, yes, we had to do yesterday. We couldn't wait for the webinar because the patient had respiratory distress. This was a 40-year-old patient, let me tell you. 40-year-old, and today this female is again an adult patient. I mentioned earlier in the children, the cause of papilloma either during the birth, as the fetus passes through the birth canal, particularly in the young primipara, or during a vertical transmission from during pregnancy. But in adults, it is mostly due to oral sex. And this adult papilloma are more, have a chance of development into malignancy if you are not careful. So this was the picture that time quickly taken through the monitor. See how the papilloma completely occupying the larynx. And to the surprise, the entire trachea was full of papilloma. So let me tell you what I am doing just quickly. This papilloma, I am removing with a micro debrider from the surface of the vocal cords. See this?
Yeah.
To get the airway. Now see the more and more airway. That is a pack behind the subglottis. As tracheostomy was done immediately. The tracheostomy was done earlier also where he was operated. So we had to do tracheostomy because of the respiratory distress, and tracheostomy is counterproductive because once you do a tracheostomy, it can invite implantation into at the site of tracheostomy, and that is what you see in this patient.
I was about to ask that. Yep.
See this, I am just quickly forwarding, not showing complete one. Just, shaving. We don't do aggressive dissection on the vocal cord. We leave a little bit. Now see with the endoscope inside. What is there?
Oh, papilloma.
Papilloma at the site of tracheostomy. This is the bulb of the tracheostomy. And see the papilloma over it. Could you see?
Yes,
Yeah.
Yeah.
So we had to clear all this papilloma again with the, the tracheal, debrider blade. That is the tracheal debrider blade we could completely remove. Then through the tracheostomy now. Through the tracheostomy now, and the trachea was completely blocked by the papillomas, See this. See this huge papillomatosis in the trachea.
Yes.
Now this removal is not the answer. This is just to make the airway patent. After that, this patient was subjected to IV bevacizumab, VEGF receptor inhibitor. That's a monoclonal antibody to take care of vascular endothelial growth factor to prevent neoangiogenesis. And see how entire trachea was completely shaved off. We had no option but to do this to remove the bulk of this tumor until the carina. Entire tumor was removed, this papilloma was by and large removed with the debrider, not aggressively, damaging the mucosa too much. In the larynx, we don't damage it at all because it may lead to stenosis. Here, we don't want the scarring too much. So, removed with the coagulator from the surface, and then this patient was subjected for bevacizumab yesterday only. So, in such
what about
adult,
the role of cidofovir topically injection?
Yeah, earlier we used, but no more now. Bevacizumab is much better alternative. Morning, Dr. Prakash Munga asked me about the role of propranolol. Yes, propranolol is same VEGF receptor inhibitor, but the problem with the propranolol is the adverse effect profile. Hypotension, bronchospasm, so many things. And with this bevacizumab, you have added on benefit of using intralesional injection. Got my point? So that is the beauty of this bevacizumab. And Professor Darlin, hello?
Yes, I'm here.
I am playing your
Yes, I'm
video.
here.
I am playing your 2 videos. Can you comment on that?
Yes,
Yes, can you comment?
shared with you is on the trachulator. So it's not specifically for papillomatosis, but it is for patients that develop tracheal stenosis after you see such circumferential injury of the trachea or mostly post intubation.
So this is a stent.
For long term.
This is dilator or stent?
Configuration of eight balloons. This is a dilator.
Yes.
So it's 8 balloons that are placed through a supraglottic airway. And you can ventilate patient continuously for the period of dilation, which is usually 2 times 3 minutes.
Through
And
venturi.
here we can see, if you fast forward, so the bronchoscope and make sure that dilated the stenosis. So this is just new little devices that we've developed here in South Africa. Inside the lumen of the balloon, and this is the proximal end, and you can see the 8 balloons. You can even dilate it at the level of the glottis. It will cause some initial indentations, but that resolves after a period of 24 hours. So for supraglottic, glottic, tracheal, and also for distal main bronchostenosis, this is very successsul.
Super. Can you do a repeated dilatation?
Lumen there, we can use a diode laser through the central lumen. It can also be used for jet insufflation if you are running into problems with airway obstruction. And this is the problem.
Okay, and the other video.
I don't know if there's any questions.
Very nice. Very
This
nice.
is the other one.
You have it for the pediatric as well, Dr. Darlin?
Hello?
Yes, can you hear me?
Yes, now.
Can we use it for the pediatric patients as well?
Your voice is not audible.
Dr. Satish, what is this video? What is this?
That is what I am expecting her to comment. It is her video.
Okay. Oh, okay.
Hello?
It looks a good trick.
Dr. Darlin, can you hear me?
Sorry, yes, I'm still driving in my car, so I'll only have good reception in the next half an hour.
Now we can
Can
hear
you hear
you.
me?
Now we can hear you.
Yes. Yes, so even in babies, we use this. We've got the smallest lumen of 6 millimeter diameter that you can use.
And this is stenting.
So the next step is to, after the balloon dilatation, that we use a stent, but at this stage we still use the Montgomery stents. So we usually don't require stents. We redilate the patients after 6 to 12 weeks if it is indicated.
Okay. And what exactly being done this? Can you explain?
So here we have a supraglottic airway. So this is for a patient with a tracheal stenosis, so anything from the subglottis to the main bronchi. So we use a supraglottic airway, a flexible scope, and the advantage is you can continuously ventilate the patient, so there's no risk of losing the airway or the patient deoxygenating. So you don't have that initial rush of having to do an emergency tracheostomy.
Okay.
So here you can see the balloon being placed and then dilated. And let's just see if we can fast forward that. So this is a traditional way with the rigid bronchoscopies that we manage these patients with airway emergencies. You can appreciate the stenosis there. And what we do now is the anesthetist actually runs everything through a LMA or supraglottic airway. We put a little guide wire in. And the advantage is continuous ventilation, so the patient is being ventilated with a ventilator through the supraglottic airway. Now you can see the bronchoscope in the flexible balloon. So what's happening here is you're actually dilating that stenosis in the trachea. We leave that for a period of 3 minutes, and that's what the balloon looks like. So the next step is to use a stent as well if it's indicated, and inflate the balloon inside the stent. So it's just kind of an added technique for those patients that develop problems after circumferential injury.
Okay, great, great. Thank
you. Thank you for showing.
Thank you. And now, before I go to this case, this is already absolutely ready. Let me take you through quickly to the next case finding so that we can go ahead with the both cases one after another. And this patient, again, is a 20-year-old child. You know, this pathology, let me reconstruct it first. And 3D reconstruction, just a minute. Yes. Now see, what is this? This patient has a unilateral fungal disease in a child with this much unilateral fungal disease. See this? With hyperdensities. Can you see this?
Yes, yes, yes.
This is classical of allergic fungal sinusitis, we all know.
Wow.
And there are certain criteria to diagnose the allergic fungal sinusitis. We all know this is more, aggressive in the children because of the bones. And now see where the disease is going to. That is what I want to show you. Wow. Coming from anterior to posterior. This is the type 4 cell. Can you see?
Yeah.
This is the type 4 frontal cell. See this, how big, how superior, and it is full of fungus. See this hyperdensities on the soft tissue window setting. Both frontal sinuses are affected. See this? Interfrontal sinus septum is partially gone. And as you go behind now, as I go behind now, see the amazing finding how this fungus is going up in the rest of the sinus. See the rest of the sinus behind with multiple septations. Can you see this? My type 4 cell is ending anteriorly. This is here. Now if I go behind the type 4 cell in the frontal sinus, the disease is rising high up. There is a huge disease with a lateral partition of the frontal sinus going high up. Can you see?
Yes.
Imagine the difficulty in addressing disease, and what all will this require for sure is a draft procedure. To get over the type 4 cell, go over the type 4 cell to get this cell out, and then when you go behind, there is incomplete septation that you can take all the remaining fungus within the cells behind out. Now if I do a 3D reconstruction at this point of time, let me show you. Let me show you where exactly I was. See this. This type 4 cell, you can first see in all planes. See, let me put this in this. Can you see the type 4 cell in the sagittal plane?
Clear.
And in the axial plane as well. And see the sinus beyond that.
Yes.
See the sinus beyond that. Now keep an eye on the sinus beyond that. See again, on the, just focus on the coronal. I am going behind the type 4 cell, okay? Now this is the sinus beyond. See this sinus beyond.
Yes.
Huge. See this type 4 cell here again, and see the sinus beyond. And that cell has to completely come out to give a complete ventilation and drainage of the entire huge frontal sinus. This is so huge. See this?
It's still not cranialized, right, Dr. Satish?
Pardon?
The bone is still intact behind, or it is
Yes,
cranialized?
It is always intact. In allergic fungal sinusitis, it expands, you know. It may lead to bone erosion by means of pressure, not by invasion. So how you can differentiate the invasive from the non-invasive fungus? In invasive fungus, the sinuses are full with pressure erosions outside. In invasive fungus, the sinuses are not full, very minimal intrasinus disease and more extra sinus disease. That is how you can simply differentiate. And these hyperdensities are classical of allergic fungal sinusitis. If you go to the classical, you know, Benton-Kuhn criteria, I can show you the classical Benton-Kuhn criteria. You all know what exactly, you know, the allergic fungal sinusitis is. According to the Benton-Kuhn criteria, there is a clear-cut classification by means of which there are certain points. Is it there in this same slide or somewhere? I don't know.
I think it's classified into major and minor.
Yes. So the major criteria are fungal positive on stain, polyps, all these hyperdensities, the characteristic radiological findings, the characteristic mucin, and a type 1 hypersensitivity, which you can prove by means of either skin prick test or immunocap or anything.
Exactly.
Minor criteria are young patients. See this classically. All 3 patients today, 2 of them are very young, and that is classical in these patients. Unilateral disease with eosinophilia, high IG. These are classical features of allergic fungal sinusitis. So in this patient, after this papilloma, I will do a draft, you know, at least 2 on this side, and remove this cell and go behind that and use a navigation system to show you a complete clearance whether we have reached to the level of the cell. Okay?
Yeah.
Here the navigation has an amazing role. You know, if you don't have a navigation, you can miss the disease behind. You never know how behind is the disease, particularly when there are septations. Okay?
This is the ideal case for use of navigation.
Yes, ideally.
And there is a high chance of proptosis in pediatric AFRS.
Yeah, this patient also has a proptosis.
Okay. And can I ask few questions, Dr. Satish, while you are talking about?
Yeah, so, I'm going for the case, but you can continue discussion.
Yeah. So this is basically an immune modulation disease, right? Hello.
In this patient, papilloma patient, our goal is to remove this papilloma without damaging the laryngeal tissue superficially. Superficially without damaging the laryngeal tissue, and then we'll inject the bevacizumab or monoclonal antibody VEGF receptor inhibitor to prevent neoangiogenesis and further papilloma growth. And we inject it initially at least 3 doses at the gap of 4 to 6 weeks. And this is something works like magic to these patients, along with HPV vaccination, along with you know, celecoxib and other treatments. That the papilloma that we did yesterday, which I had shown, you know, that tracheal papilloma.
Yes,
those patients, we start immediately systemic bevacizumab. The recommended dose is 5 to 10 milligram per kg. In this patient, we had given yesterday 5 milligram per kg. 300 milligram of IV bevacizumab was given in the drip. That will be repeated after 3 weeks, 3 weeks, 3 weeks, at least 4 doses. And we have seen in other previous patients with, you know, tracheal and bronchial infiltration with amazing results with the bevacizumab.
Okay.
2 of the patients had complete, you know, remission, complete remission. So that is the only remedy.
12,000 rupees per vial.
Pardon?
costing about 8,000 to 9,000 rupees per vial. This is, I think.
Yes, yes, that is 8,000.
And sir, in pediatric patients?
Pediatric patients, you know, when it is limited to the larynx, we use only intralesional.
Okay.
But once it goes to the trachea and bronchi, we have to use systemic. That is the mainstay of treatment then.
So intralesional you repeat every 3 weeks.
Every 3 weeks for at least 2 to 3 times, 3 times, minimum 4 times, until we complete the papilloma subside along with the HPV vaccine and other adjuvant therapy. But that is the most effective therapy to these papillomas, because once they infiltrate into the lung, the cavitation starts, they convert into malignancy, and then ultimately become fatal. So bevacizumab is life-saving in these, and it is pretty safe even in the high doses, you know. And we are in touch with our medical oncologists most of the time. Section.
Okay.
Now, can you see the picture?
Very nice and clear.
See this papilloma. So here my goal of surgery is not a radical excision, you know.
Just to create the airway without much of a disease.
Yes, I don't want to damage the mucosa at all.
So what kind of microdebrider blade are you using?
What
is it a skimmer or a true cut?
This is true cut, but otherwise skimmer is also good. You have to use it, you know, very, very safely.
Low speed.
Yeah, low speed under full control, you know.
Exactly. So, is there any particular reason you moved out of Cidofovir? Cidofovir was not working, or
efficacy, yes. The bevacizumab is better alternative, you know.
So, can we combine both Cidofovir and bevacizumab?
No need after this.
No need. Okay, because there is.
See, at the anterior commissure, I am a bit reluctant.
Yes.
Anterior commissure, I want to stay conservative.
Okay. And sir, do you use coblation also here?
Not really. I can use coblation in the supraglottic region, you know, which is not so important for the function as compared to the glottic areas. Not on the vocal cord and other areas, you know. See this, the airway opened up.
Very nice.
I will use little bit more. Give me the vocal cord retractor. Since this patient has come to us for the first time, and this will be the first injection of the bevacizumab for this patient. Nice, forceps. See this? I will retract the false cord. See this?
Yeah.
Now give me the debrider.
What laryngoscope you are using? Klein saucer or Dido or
Klein saucer. See this, just surface removal. See on the left vocal cord surface.
Yes.
Here skimmer blade, you are much safer. You know?
Yeah.
Here you have to control. Inside is absolutely clear. There is nothing in the subglottic region anywhere. Yeah. See, inside part is very clear, and I am not going on the anterior commissure on the opposite cord because it may lead to stenosis.
True.
See, I am just staying on the surface, superior surface. See, more and more surface removal. See that? Surgery has a role of, establishing the airway. Secondly, preserving laryngeal mucosa at the same time. Just a minute. Yes, Atal. Yes, now. See the vocal cords pretty clear now.
Yes, sir.
Dr. Kageshwar Rao from Bhubaneswar has asked, can systemic use of bevacizumab cause any other systemic side effect, vascular complications particularly?
Uncommon, very uncommon. It can, but those are reversible even if it happens to occur. Secondly, the medical oncologists use this in cancers, as an adjuvant therapy in much higher doses.
Higher. Yes.
Much higher doses than what we are using. See, I am removing the gross lesions.
Yeah.
In this first setting, I will not go more aggressive than this.
You will leave a bit of tissue in the commissure, anterior commissure?
Yes, I will leave. On the opposite side, anterior commissure, I did not go.
Yes, sir.
I will inject there the drug rather than, if it is too bulky, you can come after, 2 weeks to the opposite side.
Yes, sir.
Dr. Chennappan from Erode has asked, you use this bevacizumab for hereditary telangiectasia in nose. How do you inject in larynx and how much you give?
Larynx, my topical dose is roughly up to 50 milligram.
You use the regular scalp vein set needle or you
This
use
is with the
needle?
PCNL needle.
Okay.
The needle which I use here is PCNL, see this
Yeah.
section here.
Size of the needle, anything?
See this, I have injected in the base.
Yes. What is the size of the needle, PCNL needle?
This is 0.3. You can acquire from your urology friends.
Okay.
See this?
Yeah.
This is so simple, you can inject in the base.
So you use it only for this particular injections or any
Yes.
injection laryngoplasty you can use the same PCNL needle?
PCNL is for this only. Otherwise, for fat and other, we have a different laryngeal needle.
Okay. What is that you use, Dr. Satish?
For
the fat and other things?
we
What
have
do
a
you
system from Medicon.
Okay.
That is a foot fat harvesting and injecting system with a syringe, needle, and a rotator that we
Great.
use for the fat. Injection laryngoplasty. This is done.
Superb.
This goal, in this first stage, this will give a remarkable, disappearance of the papillomas. And after 4 weeks, we'll come back. Planned comeback, if there is any papilloma, we will remove. Otherwise, still we'll inject the bevacizumab in the base. We'll inject at least 3 times in a planned way. After that, we'll take a call in case the papilloma comes. Okay?
Yes, sir.
Superb.
So this was a small procedure. Our next case is ready. No IB. बचा ना 50? ये था ना? So the rest, hello. Hello?
Anytime you need to put a stent in these such cases?
Yes. In rare situations, like you saw that tracheobronchial papillomatosis.
Yes.
In extensive tracheobronchial papillomatosis coming back again and again, you have to use a laryngeal stent or tracheobronchial stent to compress the walls to prevent the development of papilloma. So that is one of the strategy in those difficult situations.
Okay.
We had to recommend stent only for one patient so far in our practice. That is so huge papillomas, completely given so many times removed, given scarring, not responding to anything. But that was earlier when we started using, before we started using systemic bevacizumab. But now we are using systemic, so we have not found any need of stents so far in the recent practice. But yes, that is an option. In extensive tracheobronchial papillomatosis, this is one of the strategy to completely stent the trachea and bronchi to prevent the papilloma coming in the lumen and keeping the airway patent. That is the strategy. We are ready for the third case in a few minutes.
Yeah. Can I ask a question about that case?
Yes, please.
Regarding the AFRS? Yeah.
Yes.
So the questions are like, this is the immune complex disease more of, right? Would you agree?
Yes. It is a type 1 hypersensitivity.
Type 1 hypersensitivity. So if that is so, why is it happening only in one particular side and not on both sides?
Mostly it is unilateral. It can happen bilateral. We have one case. The next case of the this disease we are taking is a bilateral one. It is not that it cannot happen bilateral, but mostly in young patients who are more immunocompetent or more severe, robust immunogenic reaction, and that happens to one if the fungi happens to lodge in one of the sinus cavity. See, fungi is ubiquitous in the air, can be lodged anywhere in the nose if it is not cleared by the mucociliary activity. And that immunogenic reaction by the IgE eosinophilic leads to this kind of secretion and deposition and ultimate irreversible. So mostly it happens on one side, but yes, it can happen bilateral.
Yeah, so by chance, like you are doing a surgery on one side, the right side, let's assume, and you're using the same suction tip, and you just do a simple suctioning on the left side, then are you implanting the fungal into the left? And can that be a theoretically because of your surgery?
It's not a matter of implantation. Let me tell you pathophysiology.
Exactly, yeah.
It is the fungus which is lodged and the patient's immune reaction creating this problem.
Okay.
So the goal is, it is a pure antigen antibody reaction. Like for any antigen antibody reaction, the treatment is steroid.
Yeah.
So here, what you need to do with surgery is to remove this antigen thoroughly.
Okay.
Remove the antigen, open up the sinuses, establish the ventilation and patency, drainage, and then irrigate with the steroid. That is the treatment.
Yes.
That is the treatment. Once you start irrigating the steroid reaching into the sinus, let it be. Once you remove the fungus, there is no antigen, no more antigen. When you give the steroid, it blunts the immunogenic reaction and the patient remains symptom free. Yeah. And many times, it is the alternaria which is implicated, fungus.
Yeah.
It is a dermaceous family fungus. So we follow post-operatively after a few weeks, 6 to 8 weeks, with the skin prick testing and immunotherapy.
How about bipolaris? Any?
Yes, bipolaris is also implicated.
Implicated, yeah.
Mostly alternaria. Sometimes aspergillus as well.
Yes. And particularly in the nose, ethmoid seems to have more predilection than the other areas. And what is your take on the inferior turbinate? Why it is not that much getting infected? I mean, affected.
You mean inferior turbinate is a separate anatomy?
Separate bone.
Yeah, yes. Separate anatomy and the separate erectile tissue, you can say.
Yes.
That doesn't participate in the like sinus mucosa does.
But the mucociliary tissue is almost similar, right?
Yes.
Even though the development and the thing is different.
Yeah, it can.
Yes. Okay. And the next question is like, if we leave few fungal material in the maxillary sinus because the novice surgeon is not able to remove it fully, will the disease recur, or with the irrigation it will
Yes,
get?
then your antigen stimulation is persistent.
Exactly. Okay.
It can precipitate again. So you have to, the goal of surgery is to thoroughly clear the antigen. Let me ask Dr. Darlin, how common is AFRS in South Africa?
I think Dr. Darlene is
Okay,
not
she has
available now.
intermittent busy.
Intermittent. Yes. So can you also differentiate between the EFRS and EMRS? How do you differentiate?
AFRS eosinophilic.
Eosinophilic fungal rhinosinusitis and mucinous rhinosinusitis.
See, there are so many endotypes,
Yes.
and the center of all these, majority of these is eosinophilia.
Yeah.
But in allergic fungal sinusitis, that's why, again coming back to the diagnostic criteria laid by Bent and Kuhn,
Yeah.
no other endotype fulfill those criteria. You can simply differentiate.
Perfect.
Eosinophilia is hallmark of majority of the sinusitis. Majority of the polypoidal sinusitis, because ultimately the mechanism, the end effector is the eosinophils.
Like Dr. Kalyan Sundaram is asking, any role of MRI in allergic fungal sinusitis?
Yes. Are you getting the picture, first of all?
Yes, sir, we are getting it. And sir, how to differentiate squamous cell carcinoma and allergic fungal sinusitis on MRI? Because both are unilateral pathologies.
See, this is so simple. The carcinomas, are you getting the endoscopic picture?
Yes, sir, yes.
Yeah. So the squamous cell carcinoma is a tumor, and tumor enhances on contrast. This is a non-tumor disease. The fungus will never, enhance like a tumor.
Okay,
Number
sir.
one.
Okay.
Number two, in fungal disease, I will show in the next case MRI. In fungal disease, the fungus will disappear on T2 weighted imaging.
Okay.
It enhances on T1. So you can easily differentiate the fungus from other disease simply by T2 weighted and T1 weighted imaging. That is what I am going to show you in the next case.
Okay.
Fungus can always be diagnosed with the MRI to almost certainty by using all these various sequences. See this now? I am preparing with a topical solution. We didn't inject at all.
Yes, sir.
This is a primary preparation from beginning now. Next case, we are inducing the inverted papilloma only.
So if any case you are doing in local for nose, in that case, do you inject, or in that case also you don't inject? Only topical?
No, we don't do any nose surgery in local.
Okay.
See now. No nose surgery in local, no ear surgery under GA.
Okay.
Because here airway is the concern. Let me remove this and then go to, can I have have you registered the navigation? Just to show you, can you connect to the navigation console? Fast. Just to show you how the navigation works again, I showed in the previous webinar. Is the navigation console picture going?
Dr. Dhirendra Singh Kushwaha has asked from Delhi, is there any defective mucociliary function on one side in comparison to other side that lead to AFRS?
No, it's not moving. Yeah, what is the question?
Is there any defective mucociliary function on one side in comparison to other side that leading on to AFRS?
It's not about the defective function on one side.
It cannot be.
It is the fungus which is lodged on one side.
Exactly.
And it will be hypersensitivity which causes.
Like this. Yes. Can you see the navigation system now?
Yes, you can.
Now see, every time you can see where I am. That is the value. And this will see when we walk in the frontal sinus. See, I am at the nasal septum.
Yes.
See the coronal plane, all planes, where am I?
Yeah.
Yes.
This is to see how it is. I am at the tip of the nose. You can see now.
Yes, sir.
Okay? So first you have to register. This is the Medtronic.
Medtronic?
Yes.
There is like neuronavigation and
yes.
One which
yes. That's the stealth station from Medtronic.
Okay.
So will you be using hydro debrider in this case?
Pardon? Hydro debrider, yes, I may use.
Okay.
Because this fungus sometimes is so, difficult to remove. And here my suction is going to be my man of the match tool.
Again,
I showed you last time.
Wonderful.
Strong suction.
Second, one of the conferences you told liposuction also is good if you don't have like.
Yes, sir. Liposuction is again a high power suction. See, my suction, I told you, is the man of the match. See this.
Yes, sir.
Your micro debrider life can be increased with your suction only. See this. The turbinate is polypoidal. Polyp medial to the turbinate as well.
Yeah.
Everywhere it is polypoidal. And in such, diseases, my goal is to ensure the post-operative irrigation,
Yes, sir.
So, many a time such, compressed turbinates, I may have to partially resect. I showed you last time. Because we have to ensure, see now the turbinate is so compressed behind. Can you see that?
So we are getting very small picture in 3.
Yeah, can you increase the picture now? Remove the navigation system.
Yes, sir. Now it's good.
Now?
Check. Good. Clear.
Yeah. See now what I have done? I removed this initial polyposis and this distorted, uncinate process and all.
Yes, sir.
Yes. Yeah. See this is axilla and this is the turbinate lying compressed along the nasal septum. See, this is here.
Yeah.
Yes, sir. Yes.
Completely compressed along the nasal septum and see the, this material. This patient for last couple of days we have kept under, steroid and antibiotics for a few days. Just to improve the surgical situation,
So is it Decadron or do you give methylprednisolone or what is
Simple prednisolone. Simple prednisolone.
And so what are the pre-op antibiotics you use in these cases?
Broad spectrum. Generally amoxicillin.
Okay.
See, so anatomy is so distorted.
Has someone voice is coming.
First thing first, it is very important that ये webinar अच्छे से conduct हो. इसलिए मैं request करूँगा सभी students से, सभी parents से कि please make sure that your microphones and your video cameras are off. I know definitely you are going to have some question and answers. And for
I think it is Dr. Rajiv Pachuri. Dr. Rajiv bhai?
Question and answers will remain unanswered, right? We'll make sure that to our expert panel, your question and answers are conveyed to them. They reach out to them.
Dr. Rajiv?
And thank you very much
voice.
for the doctors that are present today, sir.
Can you mute your microphone, Dr. Rajiv?
Some little kids are there.
They are very ready. They are very much ready for everything.
No, sir, the things the doctors have done during especially the time of the corona, sir, we can expect that. It is really, sir, from the bottom of my heart, we all are thankful.
Yeah. See, the entire anatomy is distorted. And
Yes,
this is
sir.
expected in such massive diseases, you know. What polyps you have seen is after 5 days, you know, treatment with antibiotic and steroid in full doses. So they have quite regressed as compared to the when the patient presented. This is just topical application. Now, where is the section? See this? This is your nasolacrimal system prominence. Can you see?
Yes, sir.
Here is going to be your uncinate because it was distorted. This looks like your bulla which is compressed. Everything distorted. And
Yes, sir.
here
Yes, sir.
is going to be my, you know, the maxillary sinus.
Sinus.
Here. So
Yes,
here
sir.
and see
Yes,
the
sir.
fungus 40.
Very
Here
clear.
I will open up this area with my red 40.
So first landmark you use is the maxillary sinus, sir?
Yeah, this is an important landmark. Your turbinate is an important landmark. When the other landmarks are not, and see the fungus.
You're completely filling the sinus.
Completely. Everywhere now I am removing this part of the uncinate along with my divider only. Sometimes you can't go by your traditional ways, you know. According to the situation which demands, you have to go. And here,
Sir, we should identify
since,
the landmark, then use debrider, sir.
yeah. And see, the second thing is, see all fungus.
Yes, sir. Yes.
Since, Naidu,
Sir.
can I see deep? Hi, man.
Sir. Hi, sir. Hi, sir.
See this? Since we don't have a bulla, a big bulla, the bigger are the polyposis, more the bulla you will find compressed. So that again a landmark which you don't have. So what I am doing, I am using this, you know, the frontal process of maxilla as my important landmark. Can you see all the way?
Yes.
Yes, sir. Yes.
And then I have found,
Yes.
see the lamina pepraceae there.
Yes, yes.
Yes.
This is lamina pepraceae. This one. After finding the maxillary sinus below. Okay? These two are amazing landmarks at this point of time for me. See this is the part of the bulla, the remnant compressed part of the bulla which I am removing. In such massive disease you have to be, you know, all the time careful about your, you know, anatomy. And take the help of navigation whenever you find the need. See this? Once I have found the lamina pepraceae, see this? I am going along the lamina. That is going to be my biggest landmark here. See
Yes,
the
sir.
lamina? जरा सा डाल टेलीस्कोप में बेटा. See the lamina?
Yes, sir.
All the way. That is amazing landmark. All the way up, lamina, lamina, lamina. That is one as a landmark. This is my maxillary sinus as a landmark. Okay?
Yes, sir.
Now having seen these two landmarks, now I will clear one by one. First the maxillary sinus. Let me put this pack above.
Dr. Sandeep Karmaka from Pune has asked,
Yeah.
I want the opinion of boss about his experience of the site of affection in FRS. It is my observation that the site affected is more roomier side as it allows more antigen to be inhaled.
Yes, obviously. You will rarely find a site which is affected having septal deviation. It would always be on the opposite side, you know. The
Yeah.
curved section there. Motor. So what I have gained is two landmarks. One is my middle meatal enterostomy. And the other one section, wash. Other one is my orbit. Now see, this is my high power section.
High power, what is the power or anything?
This is using the central one. This is more than 1 HP now.
Because if the suction is not good, it gets very irritating.
Yeah, frustrating. Second thing, what I can do here, body volleyball. I can mobilize this entire tissue with my ball probe as well. See this ball probe?
Yeah.
Completely submerge in it, the tissue, rotate.
And flushing with water, does it help?
Yes, yes. See this?
Nice. Yes, sir. Yes.
So cheesy material. This is classical peanut butter sauce.
Like, do you recommend immunotherapy also in these patients?
Yes, mostly I give. See this entire mass is coming out. See, lodged in a ball probe. See this?
Yes, sir, we can see.
But it slips, you know. Not so all that easy.
Sir, I think we have discussed this before, but Dr. Sanjeev is asking any role of IV antifungals in allergic fungal sinusitis?
No, not really. For everyone's information, in any non-invasive fungus, it is non-invasive, no role of antifungals. It is an antigen-antibody reaction, so steroids are the mainstay of the treatment. Karna hai.
And immunotherapy too, sir.
Steroids, postoperative immunotherapy play a big role.
Yes, immunotherapy has an adjuvant role. The immunotherapy will, you know, build up IgE against the fungal antigen.
Fungal antigen, yes.
To fight with the fungus.
Sir, any experience that commercially available budesonide nasal sprays instead of budesonide ampule, can we use budesonide nasal sprays?
See, the goal is to use the steroid, and goal is to make the steroid reaching the depth of the sinuses.
Yes, sir.
Now, how will you ensure? Spray will not cross beyond the anterior 1/3 of the nasal cavity.
Fine, sir.
See how cheesy it is.
Sometimes it's very frustrating that it doesn't come out.
Yeah, you have to be patient, you know.
Yeah.
Forehand technique.
Dr. Satish, have you come across this article from PGH and Dr. Verma, Dr. Naresh Panda, everyone? Role of preoperative versus postoperative itraconazole in allergic fungal rhinosinusitis.
Yes, itraconazole has a limited role, in my opinion. I'll give you indications.
Yeah.
First off, preoperatively, if you give, it improves your surgical field, no doubt about it.
Okay.
Okay?
Yep.
Secondly, you can use it to buy the time before surgery, you know.
Even in AFRS, you mean?
Yes, even in the AFRS. To buy the time before surgery. Got my point? Patient has an impending complication and surgery cannot be, you know, done for few days for any region. So it can buy the time.
Okay.
See, I'm trying to dislodge with more and more irrigation.
Yes, yes.
Yes, sir.
And if you had seen the paper, they have even commented that postoperative itraconazole also helps in management. What is your comment on it?
Post-operatively, not to all patients,
Okay.
in only 2 situations. If the patient is resistant to steroids or steroid cannot be given for some reasons, like diabetic patient, where oral steroid cannot be given.
Okay.
In
But
fact, I
not
also
as a
think,
routine for not for all patients. Then.
Not all patients,
Sir, in such cases, normally sometimes lamina is very decent. So how should we be careful with that?
Yeah, lamina, I would say the bone erosion patterns, See.
yes, sir.
पकड़ इसको first. The bone erosion patterns in fungal sinusitis are common, and the commonest bone to be eroded is the lamina.
Yeah.
The commonest bone to be eroded is lamina. अजय बुला देना.
I have another question, Dr. Satish.
Yes, please.
So in some of my patients where we have operated for AFRS and then post-operative dosing, saline and venous dosing.
Yeah.
Many times these patients complain of ear block and ear problems, like they develop secondary otitis media with diffusion.
Yeah, sometimes. What you need to do in those patients, instruct them not to blow hard after the douching. Because that pressure which is transmitted to the, through the Eustachian tube can lead to oral symptoms.
Yes.
Sometimes even effusions.
Effusion, yes.
So in those patients, ask them to, douche effectively, but not to blow hard.
Yeah. I in fact say them not to blow at all.
Yeah.
Just to do. But in
that
spite
blowing
of
is the problem.
Yeah. But the minute they stop irrigating, it kind of shows a little bit of polypoid changes. So
Yeah. See, I am just doing a surface debridement. Because sometime in the convolution of the mucosa, you will find a tap fungus.
Okay.
See this?
So you preserve the basal membrane, but you just...
Not to the periosteum.
Yeah.
But surface always. And
so that there won't be any scarring.
See this fungal material in the convolutions of the mucosa.
There you go.
And if you leave the fungus behind, the same story will start again. Wash. So you have to be very, very radical towards removing the fungus, Okay. See how much efforts are required. Back there. I will use the, I will use the angle scope later.
Yeah. How about using a canine fossa puncture and all, if it is needed?
Yeah, in case required.
Yeah.
Now see what I am doing. I am mopping with the marrow cell everywhere.
Okay. Just a plain marrow cell or anything in it?
Yeah, plain.
Yeah, this will
mopping, for all, anywhere the fungus which is hidden, adherent to the mucosa, any convolutions, see this?
Yeah.
Somersaulting the marrow cell, and that will help me remove all this fungus, the remaining one. I don't want to leave any fungal material. This looks nice now. Can you see?
Yeah.
I will show later with the 70 degrees, not now. Let me finish the other work. Could you see that?
Yes.
Yeah, give me a marrow cell. See how the maxillary sinus was. Okay. Debrider, straight debrider.
While you're working on it, I'll just ask few more questions, general questions.
Yeah.
So when you see a patient with polyps and you think of ARS, when would you do a CT scan? Would you do it after a course of steroid, or would you do it in the day one itself?
That's very important question.
Yeah.
Let me answer it in general.
Yes, sir.
Whenever you have a doubt of fungus, any evidence of fungus,
yeah,
it's a straightforward surgical disease. You know.
Yes. The reason you're doing it for anatomy, etc.
Whenever you suspect a fungus, you know, the treatment is surgery, and then obviously the scan is required.
Yes.
So whenever you suspect fungus, don't waste time in medical management or maximal medical therapy or anything. There's no role. See, I'm widening the sinus openings. Widening.
Super.
Removing all these septations because I need now the long-term surveillance.
Exactly.
Right.
I want more and more steroid to be pushed inside. See, I'm using only 0 degree to save time. What I'm doing, I'm finishing off my work with a 0 degree.
Whatever can be done.
As fast as possible.
Would you even debride off the middle turbinate so that the steroid spray would reach the...
Yeah, if it obstructs. If it obstructs. If it obstructs, I will.
Okay.
We'll definitely take a call if it obstructs.
Okay. But you don't do it as a routine?
Most of the time it is done, you know, I can say.
Okay.
But why to be biased?
Yes. Yeah, Dr. Riyaz Afridi from Pakistan is asking, is there any role of canine force approach?
Yeah.
Canine fossa is required when you have a disease which is inaccessible through your, you know, meatus.
Yes,
so you get an additional port for instrumentation through the canine fossa. That's it.
Thank you.
See, full of fungus. Debrider. Without wasting time, you have to keep debriding.
When exactly you would start doing immunotherapy? I mean, allergy testing post-operatively? 4 weeks?
After 6 to 8 weeks.
6 to 8 weeks. Okay.
When the sinus cavity heals nicely. See, I am along the septum.
So you don't give steroids until then? Because if you give
steroid at least 3 weeks.
3 weeks, and then you stop it, and then you do the allergy testing, right?
See what I'm doing? Yes, right. I'm staying close to the septum. You know, I have no other landmark than the septum now. Here, when you work medially. Yes.
So true.
When you work medially, your septum is the biggest landmark. You know. Go along the septum. To find the sphenoid sinus. To find the sphenoid sinus.
Do you take biopsy by any chance? Or?
Yeah, I will take. Always.
Have you come across coincidental inverted papilloma along with this?
Not with this fungus, but yes.
Yes.
We get so many patients, you know.
The polyp and
inverted papilloma referred after a surprise diagnosis.
So true.
So many a times inverted papillomas are diagnosed as a surprise finding behind the polyps, you know. Yeah. See, this is maxillary sinus which I have widened to the maximum.
Maxillary?
This one.
Oh, okay.
Let me show you. Let me remove this cell. Wash. Now see the mega middle meatal enterostomy.
Very big.
Can you see?
Very nice.
The mega.
Huge.
Because of the fungal disease, you know, this requires, I would say, lifetime surveillance.
Yes.
Now, see along the septum.
Yes,
Most important thing is, along the septum, below the level of the maxillary line. See the maxillary sinus?
Yeah, yeah.
Yeah.
I went behind and this is the sphenoid sinus. Not this one. This one. That is the biggest mistake one can easily do. So always stay along the septum. See, always along the septum.
And below the maxillary line.
Yes. Be careful inside the sphenoid. When you are using sharp instrumentation, you need to know where exactly you are.
So many times when we get a bilateral disease, it is posteriorly the disease goes from one sinus and then it crosses over to the opposite side.
Exactly.
And then it comes.
That is what the next case is.
Okay.
Exactly. Sphenoid is most of the time completely involved.
Yes, exactly. And these are the patients who need a lifetime surveillance because the minute they drop out of follow-up, they come back with some
You
kind of-
have to counsel them for regular using.
Yes.
Now, see now the field.
Very nice.
Very nice.
See, once you are oriented, undercut. See, this is all fungal disease. My God. Now, give me the navigation probe. Straight probe. See the disease in the sphenoid.
Oh boy. Sometimes it's so attached to the clival region and
Yes. Now, can you change? Can you see now?
Yeah,
The
yeah.
navigation on the anterior surface of the sphenoid.
Yes.
See in all planes.
Yes.
And see the sphenoid sinus. This is interior of the sphenoid. And see the lateral recess on this side.
Yeah, yeah, yeah.
I am in the lateral recess. See
Lateral
my
recess.
probe.
Yep.
Can you see?
Yes, yes.
My probe is in lateral recess now. See, very clear?
Very clear.
So now I have to widen the sphenoid face and flush out. See, in the sphenoid, most of the time, removal of the fungus. Your strategy remains flushing, flushing, flushing. That is the safest one, number one. And second is suction. Not using sharp instruments. So inside the sphenoid, you have to be careful. See, I am widening. Cobbleter. More and more widening.
When you do widening inferiorly, we have to be cautious about the...
Yeah, this septal branch.
Yeah. Is that the branch that's getting there? No, no.
Now, give me the wash. See this? Full of fungus. What I am doing here is, now see. Suction kar. See the fungus coming out.
Yes, yes. Beautiful.
Mota laga section. Bigger section. And see, this is the strategy in the sphenoid. Flush. See the huge one. Came out single piece.
Super.
Yeah. Now, I will show you later the lateral recess.
Okay. So while you are just doing it, can I keep asking questions?
Yeah.
If you feel, please distract it. Let me know.
ball
So
probe.
in a classical case of CRS, when is the time you would advise CT scan to be done?
See the ball probe.
So wow,
How effective the tool
huge.
is. See, the ball probe has brought everything. So you have to submerge the ball probe in the mass, rotate it, and now it is complete sphenoidal clearance. I will show, once I use the 70-degree, I will show you the lateral recess from inside. See now, by and large?
Very nice.
Yeah, 40 there, no? Each and every fungus. See now the picture is much better. धीरे. See the cell.
Opposite side spinner.
Yeah,
Yeah.
I think so.
I will show you the navigation. छोटा कर्व से भर के दे. I will show you the navigation. Let me clean it. Section रख. See this? Bit flushed. Navigation has an extreme role in such unusual, extensions beyond the paranasal sinuses. And in extensive cases to keep your visualization, orientation. Yeah. Okay. The navigation there. So, curve there, section. Let me put what the cell was I removed the fungus from. Okay. This
Yes.
one. This area which I cleared. See now. See now the intersinus septum. And this cell is completely cleared. See now behind this cell in the center part of the sphenoid is this cell which is going across the midline. Can you see?
Yes, yes.
And the
Almost
opposite,
attaching
beyond
to
that,
the
the
opposite
sinus is
side.
clear.
Yeah. True.
Okay?
Yes.
Straight the navigation. Give me a straight probe for the navigation. Saurabh? Now the important area is the optic nerve. Because this was the onodi cell. Can you see above? Hello?
Yeah.
That is the onodi cell.
Onodi cell. Yes.
I can see the optic nerve running over there.
Very nice and clear.
This one.
Yes. You can see the OCR also.
Verify. Yeah, let me register the state with the navigation. Yes. Now see. Section लगा देना इसके पीछे. This is the straight section which is being navigated now. This is attached to the navigation system. Now see what it is. That is optic now.
Onodi cell.
Can you see the optic now?
Yes.
Optic now, yes, sir.
That is optic now. See on the scan.
Yes, sir.
Yeah.
So that is another thing. Straight. Wash. Let me give a wash, reorient you. What I have done quickly, finish the work with the 0 degree. Okay? Just to save time. Now, give me 40. Now I have a good reference of the skull base behind. Can you see?
Yes.
Yes, sir.
I have a limit laterally. That is lamina. So clear?
Yeah.
See, all these cells I can flush with the lamina completely. See, while working close to the lamina, you are not supposed to use any pressure on the blade to poke into the lamina. And here, medially, this is my turbinate and all this full of fungus. Still with a 0 degree. This is axilla. This is all the cells along the skull base. See, my direction of working is towards me.
Right.
It is towards me, not towards the skull base. So it is quite safe. Got it?
Yes.
Yes.
Now above we know is a huge fungus.
You are in the roof of the posterior ethmoids or?
In the frontal.
Can we see the scan, that navigation?
Yeah, I will show. In between, I am going to take the reference of navigation every time. This is added safety to your anatomical knowledge. बंद है यार, ढंग से खोल यार. See, you have to be careful along the skull base because many a time you never know the skull base is also descent.
Yeah.
So I am coming anterior to it with the reference of the skull base behind, you know.
Right.
So where would you get the posterior ethmoidal artery?
Posterior ethmoidal artery, the best reference point.
Yeah.
Is few millimeters, 5 to 6 millimeter anterior to the optic nerve.
Optic nerve. So that is the optic nerve there.
Yeah, if it is prominent, I will show you. See the optic nerve?
Yes. Very nice.
Preserve the mucosa most of the time, you know. Whatever maximum you can preserve. See, my medial limit is this turbinate. See this?
Yeah. Yes.
Lateral limit is lamina.
Lamina.
I have a huge space, and this posterior limit is your space, and coming anteriorly. Okay?
Yes.
See the size of the cavity, huge.
Yes, sir.
It is expanded by the fungus itself. See the turbinate. It is compressed but not coming in the way. See this?
Yeah.
Yes, sir. Yes, sir.
It's behaving so nice, staying with the septum, which is what we want. Our olfactory axis is wide open. See the olfactory area.
Yes, sir.
Now is the key area which we are going to.
This is that cell which you are opening.
Yeah, this patient key area is frontal.
Frontal.
The cell.
Next two patients, key area along with the frontal is the sphenoid. Both patients who have vision issues have disease in the frontal or in the sphenoid. Now give me a good wash and pack all the way behind. Now this area behind, I am not going to do anything right now. See this, you can orient yourself.
Yes. We are nicely seeing the maxillary side.
I hope you are all oriented.
Yes,
Nicely oriented.
Now I will pack this region and focus on the frontal. I told you this patient has a type 4 cell.
Yes.
Which requires a draft, a planned draft on this side, you know.
Right.
Now I will focus on the draft. Okay.
Right.
It's a huge high up type 4 cell. एक और देना pack. And all these packs will remain below because this area is clear for us now. I will see with the 70 later. I have not changed the telescope yet.
But for the draft, you'll be using 70?
Not now. Draft will be done with the 0 only. 70 will be used later. Now, I had shown in the last webinar, if you remember, about the draft. See, this is my axilla. Can you see?
Yes, yes.
Yes, yes.
I will remove all this, you know. One mucoperiosteum. See the beauty of the cobblator.
Yeah.
You can do it so bloodless.
And so it works like section also, like a section you are using it everywhere.
Yes, you can use it.
This is a Pro Max, way back.
This is Pro Size Max.
Pro Size Max.
Today, Wally. No, periosteum. Now see this mucoperiosteum, I have to bring it behind. See this?
Yeah.
Yes, sir.
See the disease. See, it is already broken into the anterior wall.
Yes, sir.
Now see, taken behind, and my posterior limit is going to be the first olfactory neuron, which I will show you.
So can we see the septal branch with humoidal artery?
Yeah, the septal branch is a lateral one, and the first olfactory neuron is medial one.
Yes, sir.
Most often you see both the structures parallel. And see, still, if I go behind, still, I have not reached the cribriform. That
Yes,
means
sir.
working anterior to it is pretty safe. See that?
Yes, sir.
Working anterior to it here is pretty safe. See, already given away one place. See this? Here.
Yes, sir. Yes, yes.
So now quickly, this area is ready for the draft. You had seen the draft last time.
Yes, sir.
Now this is the draft for different indication. Yeah, next patient is a papilloma patient already induced. There would be a draft for different indication, for tumor.
Sir, kindly explain once again the inside out and outside in technique. You were
Outside
explaining
in is outside in. If I start from above, assuming my cribriform is behind, I start from here and go to the periphery.
Okay, sir.
Inside out is, I start from the periphery. You know, see here, I will define my outer limit first here. See this?
Skin. Yes, sir.
Outer skin first and then go anteriorly. Following the skin would be the anterior limit.
Yes, sir.
To me, that is much easier. See, I am reaching to the outer limit.
Right.
See, that is the outside skin. This is diamond burr only.
What size diamond burr?
4.5. Can you see the outside skin?
Yes,
Yes, sir. Yes, yes.
This
yes.
one. See, if I press from outside, you can see.
See the skin. Yeah, yeah.
Now following this skin, I will go anteriorly. As simple as that. See this?
That's the landmark cue.
Yeah, there is nothing great. Only thing you have to do all this drilling.
Sir, nasolacrimal duct is inferior to this.
Yeah, much inferior.
Not inferior.
Orbit is below, nasolacrimal is below, and see I am following this outside skin only.
Yeah.
This skin. Up. Okay?
Right. Yeah.
See, everything been done with a 0 degree.
Yes, sir.
This is a revision of what you saw last time. Yeah. Just keep removing bone. Keeping, can you see my lateral limit outside skin all the time?
Yes, sir.
Yes.
So that remains your guide, you know. You don't have to look for the anterior skin. This will automatically take you to the anterior skin as well.
Right, sir.
See, this skin is coming anteriorly. See, this all thick beak is being drilled. See how thick this bone is.
Yes, sir.
With this drill, you can do this procedure in no time. We have done several times in less than 10 minutes. And that too with a diamond drill. There is all fungus inside, I can see.
So is there any particular size dimension criteria for the draft? In this particular case, the fungus itself would have opened it for you nicely, so I don't think that would matter. But for the irrigation to be very effective, is there any particular size?
Maximum possible.
That's it, right?
You can't, define in terms of centimeters or so, because every frontal has a different dimension.
Different dimension, exactly. So
What you
anteriorly, the
what you
limiting factor is
everywhere. Go to the limit skin. See, I'm reading the anterior skin now.
Okay.
See, my skin is rotating anteriorly.
Yes, sir.
My focus is just drilling on the bone. See, your entire frontal sinus now is visible with a 0 degree. See this?
Yes, sir. Yes, sir.
Very nice.
Wonderful, sir.
Next.
So in this particular case, it was, I believe, it was crossing to the opposite side, right?
Pardon?
The disease was crossing to the opposite frontal as well?
Not really. Opposite
Not
frontal
really.
is a mild disease, opacification.
Okay.
That is not fungus, but we'll address that.
So are you planning to do a draft 3 in that case, or
Not really.
Sir, can we
Draft
do
two.
subtotal Lothrops by removing the septum and then
Yeah,
going
we
to
can
the
remove the septum also.
Yes, sir.
See the exposure. This
Very
is being
nice.
done with a 0 degree only.
That is
Wonderful,
the
sir.
amazing thing.
That's the beauty of it.
And this was the type 4 cell.
Yes, sir. Yes.
Which you opened up right now.
See, this is the cell wall, this one.
Okay.
I will show you better. Let me drill a little bit more.
So please put navigation also. Right.
Yeah, I will. Yes, that cell I will show with the navigation.
Yes, sir.
Navigation. Give me the curved one. Give me the curved one. See this? Where I am in the cell. Can you see?
No. Yes,
Can you see in all three planes?
Yes.
I am in the middle of the cell.
Right.
See that?
Yes, sir. Yes. We
And
can
this
see.
is my cell wall. See what I was trying to say. This one.
Very clear, sir.
I will remove and show you. Let me drill. So I just clear the cell from inside. That's it. I will show you to remove the cell wall and then we will go beyond. Drill. See this now? Yes, wash. क्या हुआ?
So what is the speed of your diamond burr?
60,000. Check the.
You are using on any particular angulated
15 degree, I think.
Is it the 15 degree one?
Pardon?
Is it the 15 degree angulated?
Yeah, it has a natural 15 degree angle. Just to keep your shaft coming in your way.
Yes.
Just to keep that away.
Dr. Satish, do you find it helps to extend the patient's head a little bit for the Lothrop if you're using a 0 degree and a straight drill? Do you extend the head?
Yeah, it's all 0 degree and, all the time 0 degree only.
Yeah, but is your head slightly in an extended position?
Any extension?
Yeah, is your head placed in extension to increase your
not
visualization?
Not really.
No.
Neutral position. It's still in the neutral position. Not really, because my opening is right till the outside skin, This anterior bone removal should be complete to give a good exposure of the Lothrops.
Can you show for the audience the drill bit and its angulation with the endoscope?
Yes.
So that they can
see this 15 degree.
Yeah, very nice.
Very nice, sir.
And see, so sleek. Now see, this bone I am removing. The biggest mistake people commit here with the exposure is they don't remove the bone up to the skin. They directly jump onto the pathology.
So again, the exposure is very important here also.
Everywhere. Exposure. In the last case, Jain, it was all exposure.
It was all exposure.
Tumor removal didn't take more than 10 to 15 minutes. Wash. See my outside skin here laterally?
Yes.
It is arching here anteriorly. Wash. Any bone Until the skin, any bone coming in the way, I am going to remove. This is how you can make the biggest possible opening and a good access.
Dr. Satish? Hello.
Yes.
Dr. Satish?
Yes, please.
Yeah. We are seeing currently post-COVID, we are seeing an increase in the invasive or mucormycosis disease per se, post-COVID.
I don't know increase, but yes, we are getting many cases.
Many cases, I mean, they have become COVID positive, and after COVID positivity, they have started presenting with
you know,
COVID.
two of patients, unbelievably,
Yes.
two of our patients,
Yeah.
we diagnose, mucormycosis.
Okay.
With our MRI and the findings.
Yeah.
On initial examination,
Yes.
Then as a protocol, we sent for the COVID testing.
COVID. Yeah.
Positive.
Yeah. So I don't know. There is something.
That is the
going on with
intersinus
this.
septum. See this?
Yes. Yes. Yes.
The other side.
No, I think intersinus septum, right?
The fungus there.
I will show you the anatomy here, very clear section.
So I believe that this COVID is actually going to cause increase in the amount of mucormycosis,
Hold.
especially in patients
Yeah,
with
maybe, but I don't know the immunity role of immunity, but here, COVID also has to do a lot with the immunity.
Yes.
And these patients are already, diabetic, immunocompromised.
Exactly.
Maybe. Now, give me. Yes. See intersinus septum.
Yes.
See, I'm in the opposite sinus.
Yes, you entered.
Give me navigation. See, I have reached the level of the subcutaneous tissue.
Yes, sir.
And now I will show you the type 4 cell with a 70 degree from up. Yeah, give me the navigation probe. Navigation. Ajay, navigation. Suction kar de वहाँ. Can you see the opposite sinus?
Yes, clearly.
Yes, sir.
See my probe in the opposite sinus,
Yes.
which I opened from here. Can you see?
Yes,
Yes, sir. Very well seen.
Now, let me show you the type 4 cell. You see the disease from the opposite sinus coming out. We'll flush it. Now, with a 70 degree, the entire extent of the type 4 cell. And then we have to look beyond that. That was our goal. This is 70 degree now.
Okay.
Can you see?
Yes, sir.
Let me show you the opposite side first. Suction curved. See the opposite frontal sinus?
Yeah.
Yes, sir.
We will remove the fungus, we will irrigate more. Okay? That is the outside skin. Now that is the wall of the type 4 cell. Now see how much it looks like frontal sinus, isn't it?
Yes, sir.
Curved section. See again. See the difference. This looks like frontal sinus itself. Can it?
Yes.
Do you see? But
Yes,
it
sir.
is
Yes,
not.
sir.
But it is
Not.
not. See this. See the fungus beyond this.
Oh,
Yes, sir. And plus, sir, the galloping is absent.
Yes. See the sinus behind.
Yes, sir.
Can you?
Yes, sir.
Clearly. Very nice.
That is, can you imagine this cell coming out without a draft?
No, it's not possible, sir. Not possible.
Unless
Impossible.
Dr. Darlin?
Unless external, not possible.
Impossible.
Yeah. Beautiful view.
See, I am pulling out this entire cell as a whole.
I think, Dr. Satish, what you've also shown here is that with that you didn't remove the superior part of the septum, but you can actually do a lothrop from the side and access
but
the
see,
contralateral frontal.
Yes, you are right. That I'm going to do probably in the next one. But in this, since the contralateral side is not showing extensive disease, so I didn't find the need of doing a removing a intersinus septum. See this? See the sinus wall?
Yes, sir. Yes, sir.
Cell wall, sorry.
Cell wall.
Thick cell wall.
Coming as a whole.
Yes,
oh,
sir.
Broken.
Yes, sir.
Coming as a whole. Some more wall left. This cannot be simply done without a draft. Cannot be. That's a joke. See now the sinus beyond.
Yes, sir.
And this fungus beyond. Oh my God.
So how this fungus has reached there? This is also very.
Pardon?
Sir, despite having type this kind.
Hello, are you able to hear me? Hello. Yes, hello. Yes, Dr. Satish, are you able to hear me? Yes, I am able to see your picture. Yes. We are able to see the picture. Yes, perfect. Yeah. We can see that. Type 3 or type 4? Type 4, yeah. Yes. Very nice. Superb. Almost there. Yes.
Yes, sir.
You see?
Yes.
Yes, Dr. Satish.
That's still the remnant of the cell. And see the disease beyond, fungus.
Oh, yes.
See the amazing disease. This is my very favorite Nagashima, forceps.
Superb.
These are a lot of special frontal sinus instruments.
Yes, sir.
Is it the one that has the 5 action thing?
Pardon?
That is having the 5 joint.
Yeah, articulated. That is not articulated. This is not articulated.
Articulated punch. No.
The floor of the cell. Now see the cell, the sinus beyond the cell. See the huge one.
Yeah.
Amazing this disease this patient had. And see, the key is a proper radiology, instrumentation and the navigation.
Yeah.
See how useful the navigation is in this particular. Now I am flushing this fungus beyond.
Can we use a hydrodebrider at this point?
Yeah, hydrodebrider if used, if the fungus is so cheesy, not coming out.
Okay.
This is coming out easily. See this?
Okay. Yes, sir.
This is almost completely out.
Very clean, sir. Yes.
And I will show you the navigation, the farthest point. In the next patient of the allergic fungal, after the, this papilloma, has the sinus even beyond this. The expansion of the sinus even much beyond this. What this patient is. And that too bilaterally.
Wow.
See the opposite side. Mucin.
Yes.
Yes, sir. Yes.
Opposite side will do a formal ethmoidectomy and frontal sinusotomy. I am not going to, my colleague will be doing. Now, navigation. This is my reverse blade. I call it as a skull base blade. See this?
Yes, sir. Yes.
This is called suprabular cell.
Yeah.
Section. See the fungus there was in the cell.
Yes.
Yes, sir. Yes.
Frontal is now completely clear. Now give me the navigation probe. Navigation probe to show you the
scalloping is amazing to watch.
Yes, sir.
Beautiful.
Now see where you are.
Beyond
the disease. See this?
Exactly.
Yes, sir. Yes.
See this? This is dura.
Yeah.
Yes.
See this?
Dura, I mean the bone.
This is dura. This is the posterior table. This could
Wow,
be the
okay.
skin. Outside skin, sorry.
Okay.
This is outside skin. You can see anteriorly.
Yes, yes.
In the sagittal plane where it is broken.
Yes.
Yes.
See that? In the coronal and sagittal plane, you can see where it is broken.
Yes, yes.
And if I revert it, this is posterior table.
Yeah.
See this? And this is the entire frontal sinus. Very well mucosalized.
Exactly.
Slightly brighter. And final part, I will show with 70 degree the frontal and the maxillary and the sphenoid sinus. Maxillary and the sphenoid sinus, yes. Wash there. Partially block है यार, वो समझा करो ना. सुनाई नहीं देता क्या उसको? So in next 2 minutes we'll be through. Yeah, could be Ladana. पैक कर दो. Give me section forceps. See that cell above? Hello?
Yes, sir. Clearly. Very beautiful exposure.
And this
Wow.
is...
Wow, beautiful.
This is right at the skull base, you know.
Yes. You can see the skin also there.
Right at the skull base, this one.
Ah, yes.
Now, finally, let me clean the field for you and show you everything. There is some oozing.
Some oozing happening there.
Yeah, that will take care. Don't worry.
Can you show us the anti-ethmoidotry also?
Could be some branch. I don't see anti-ethmoidotmy coming so anteriorly, but yes, could be. Doesn't matter. Now with the 70 degree. See the maxillary sinus from side?
Yeah, absolutely.
Wash.
Mucosa well preserved.
Now with this big opening, with the steroid going inside freely. See this?
Super.
Clear? Now I will show you the sphenoid, particularly the lateral recess, which you have not seen yet. What I will do, see with the 70 degree.
Sir, Dr. John Shadow from Australia is saying, amazing demonstration. Each webcast has been very great. The collection of the webcast together is the best by far. I have been to many conferences, absolutely world class.
Oh, thank you, man. See, I am in the sphenoid sinus now, and can you see the lateral recess?
Yes,
yes, sir. Yes.
This is with the 70 degree.
Yes, yes.
There was fungus, but now it is absolutely. This is maxillary, and see behind and laterally. This is lateral recess. See this?
Yes, yes.
That is your,
Very
optic
nice.
now. That is your optic now. Your rest of the skull base. See this?
Yes, sir.
And that bleeding has almost stopped. See? I didn't bother about that and it has stopped. Wash.
Yes.
So sometimes you are not supposed to be so aggressive at every point. Don't get terrified. Now give me 0 degree to give you a final picture, and then our next case is ready. We are already behind the schedule. 4 more cases to go.
Is there some fungus there?
Yeah. That's what I'm checking at the level of the skull base. Every cell.
There's fungus there.
There is fungus.
Every cell you have to take care of, you know. Every single cell. See my anterior artery behind that. Hello?
Yes,
Yes, sir.
See the vessel.
Okay.
Yes, sir. So many people were asking for it. Thank you.
The brighter. Now it is clear. See now that cell is completely marsupialized.
Yes.
Nice.
So that is frontal bullary cell. Above.
No. This is the ethmoidal cell.
Yeah.
This is just the ethmoidal cell.
Okay.
See, all these are skull base cells along the skull base.
Nice.
See, this was massive case. And the next fungus is, believe me, 10 times massive than this. So with time, you know, the bleeding automatically stops, field gets clear. See that?
Yeah. Very nice.
So that is our final picture. We'll just wash it and my colleague will do on the opposite side some ethmoidal and frontal recess work. Okay? Thank you.
How
Fantastic.
How do you pack the nose, sir? Like what all packing? How many Mirocell you put?
Mirocell, one in the nose and some pieces above.
Okay.
Not much. We'll irrigate at least for 10 minutes in the end.
Okay.
That is the best thing. Irrigate with the saline and the steroid solution. Okay. And can you change? The next is a very, very interesting case. Now. Hello?
Yes, sir.
Inverted papilloma.
Yes. This patient has been operated twice and then came to us. And both times were operated for the polyps. No histology before, no doubt of papilloma before, and the nose was full of polyps. I had doubt because in revision cases and 2 times operated with full of polyps, I always get, MRI done. And this is how I got the MRI done, and to your surprise, I mentioned several times, MRI is diagnostic for, inverted papillomas for many reasons. Not only diagnostic, but it gives a lot of information in surgical planning as well.
So the typical convoluted pattern which you
see this.
Yes.
Can it be polyp?
Doesn't look like polyp.
So, looking at the MRI, the doubt was very clear. It is papilloma. Now the question was how to prove it before, because take the biopsy from the surface, it may turn out to be polyp only. So you have to take the biopsy from the proper area. You know, for that, we define the area by means of the MRI again.
Yes, sir.
Let me show you. What is the most representative area?
So we would go for a T2 wherein you look for a convoluted.
Yes. See this. In the area on T2 weighted, where you find the convoluted pattern. See this behind.
Yes, sir.
What is there anteriorly? Nothing. Polyps. Can you see?
Yes.
So we took the biopsy right from the depth and it turned out to be papilloma.
Okay.
So first of all, the convoluted pattern is diagnostic of papilloma, number one. This is classical pattern where alternate hyper and hypointense band you see.
Yeah.
On contrast in T2. On T2, hyperintense band is mucosa, inflamed one, and the hypo is the tumor. Because this, as the name implies, inverted. The surface epithelium goes back in the stroma. You know, the squamous, the sanitarium epithelium becomes squamous and goes back in the papilloma. And that is how this picture gives rise to. And secondly, you can many a time trace the origin of papilloma, the site of attachment, by means of looking at the convolutions, you know.
Yes, sir. From where they are arising.
Where they are arising from. In a big case, sometimes it becomes difficult. See this? And I believe this is here attached to the skull base.
Wow.
See this? The
Yes,
huge
sir, yes.
one from here and there, it is attached here, either in the ethmoidal cavity or the skull base.
Yeah.
Now, more than that, this papilloma picture, you know, on contrast, this sinus is clear.
Yes.
On the right side is hardly any disease. Left side is massive.
Yes.
Now,
Frontal
the
is.
next question is whether it has turned into malignancy or not. Because the whole game outcome depends upon the correct diagnosis of ongoing malignancy. We all know papillomas, are associated with certain challenges. One of them is it is locally so aggressive. It goes into the bone where it is arising from. It has a propensity of recurrence, so-called recurrence. Again, like I mentioned for Jain, the recurrence is never a true word for these, as these are almost salvage, residual lesions left behind. So as being a benign lesion, if on the first surgery or any surgery, if you remove it radically, it cannot come. So you have to remove the underlying bone. Okay? And the third thing is for malignancy diagnosis, because they have a chance to convert into malignancy. MRI is most useful. MRI is most useful.
You take a diffusion weighted image?
Yes.
Yes.
That is one. Let me give you an example. This patient came to us after, I tell you, 5 surgeries. Yes, see this. This patient came to us with after 5 surgeries. Let me show you. And always a diagnosis of inverted papilloma without malignancy. When he saw the scan, the lesion was so massive. Let me show you. So massive a lesion with temporal lobe edema. Can you see this?
Wow. Okay.
This small lesion going in the temporal lobe and extensive skull base involvement. So let me put the contrast one. Yes. See this lesion going into the temporal lobe of the brain.
Yeah.
That was good enough to give us an indication of an ongoing malignancy. Number one. One is beyond the confines of the paranasal sinuses and the nose, breaking the bone and going intracranially. This is good enough. Number two, in this patient, as you said about the diffusion, we had a strong doubt of the ongoing malignancy. What we did? See the diffusion. Not only it gave us a diagnosis of malignancy, Array, come on. But it directed us where to take the biopsy from. See now, this lesion.
Wow, yeah.
Can you see something on diffusion?
Hypocellularity.
This is malignant degeneration, restriction.
Restriction.
So we took a deep biopsy from this region, right? Coming from here to this region, we extrapolated this diffusion in all three planes, you know.
Yeah.
Let me show you.
So
and that help us take the biopsy from the right area.
Okay.
That was the right area where we had to take the biopsy from, in the center. So we took a biopsy and turned out to be malignancy. See the game, the diagnosis.
Exactly.
Because if it is a benign one, the plan is altogether different. In a malignancy, you have to take enough adequate margins as well to prevent the recurrence, you know. Even in the benign nowadays, we have started taking margins because it has been proven that at least 5 to 7 millimeter of the surrounding mucosa, which may be, you know, subclinically hyperplastic, should be removed, which may become the nidus of future papilloma. See how important it is to diagnose on MRI.
So do you do a PET scan following that, obviously, or not really?
Not really. PET scan we do if we suspect distant metastasis. Number one.
And these were mostly squamous cell when you did the biopsy?
Mostly. Yeah. And papilloma turned squamous cell carcinoma is different prognostically from de novo squamous cell carcinoma. They have a better prognosis from papilloma.
Okay.
This papilloma turned squamous cell carcinoma have better prognosis. So this patient, this is the story. Now there are a lot of things to be known in planning. Number one, where the lesion is attached to, it is most likely to the roof. Okay?
Did you also get a CT by any chance to show any osteogenesis?
Yes, I will show that.
Yeah.
Now, the important finding on MRI.
Yes.
The most important thing I want, whether there is malignancy inside. I have a strong doubt about this patient having malignancy. The reason is, see, if I come from anteriorly, see my nasal septum. Can you see nasal septum?
Yeah.
And see above. See above.
Eroded. Wow.
Completely destroyed this disease starting on this side, gone across the septum to the opposite side, and filled up the opposite frontal sinus.
Agreed.
Opposite ethmoids, you know. And this side, it has gone in the frontal and gone in the orbit from above downwards.
Yeah. But this side, it seems to be a little bit smooth near the orbit, right? But on the opposite side, there is...
Now see the difference. Now come to the T2 weighted.
Oh, okay.
See opposite side, everywhere is smooth. I don't see opposite side. It has prolapsed into the frontal sinus, but I have a doubt it has any attachment.
Okay.
On the contrary, on this side, see how it is coming into the orbit. Compare the orbit on the opposite side and this side. This has completely gone inside the orbit. Can you see?
Wow. Yes.
And but see the extraocular muscles. Superior rectus, lateral, inferior, medial, and the superior oblique.
Yeah.
See this. All muscles are separate. Can you see the plan? The plane? It has eroded the orbital roof, but still the muscles are not involved. Got my point?
Yeah.
That is important point, because if the extraocular muscles are involved, is a strong indication for orbital exenteration in a malignancy setting. So here it is. Now the third MRI important is the sagittal cut. There is an important thing on left side, how the lesion is coming, you know, how the lesion is coming anteriorly. See at this point in the coronal where my line is coming.
Yeah.
See now the disease.
Yes.
And see now the disease here, how it has come into the orbit.
Yeah.
Can you see?
Yes.
And see anteriorly, see here, it has eroded the bone. At this level, it has eroded the bone. See this?
Yes.
Yes, sir.
See, this completely eroded the bone, but is separate from the outside skin. There is a good plane between the subcutaneous tissue and the tumor. It has not invaded the skin, but it has completely eroded the anterior wall. See this black anterior wall bone. Can you? I am following the black anterior wall bone. Can you see here?
Yes.
And now it is gone. So on the left side, here it has completely eroded the anterior wall and come into the outside the anterior wall, but not eroded the skin. See, so clear about it.
Yes, sir.
Can you see? See, this information cannot be gained from anything else than MRI. A good all sequence MRI. Now, if I see in the axial plane the same thing, again, once you have a doubt of involvement of the outside skin, see this. Can you see here?
There is a plane.
Yes, sir. Again, we can see the plane.
What is this bright thing on T2? This is subcutaneous fat. See the skin outside subcutaneous fat, and there is a plane between the tumor and this. It is not eroded the skin.
Yes,
that is
sir.
so good evidence. Now, bringing in the diffusion, yes. At this level, see this. The entire thing is not showing restriction. But here the patchy restriction at this level, where it has eroded the septum. There is patchy restriction. See, even in the part of the frontal sinus, patchy restriction. Can you see?
Yes, sir.
Yes. But it's not that significant like what the case you showed before, right?
Yes. And see the opposite frontal sinus. See the opposite. So clear.
Yeah.
It is this sinus which has gone, see this, into the orbit, into the anterior wall and into the orbit.
Yeah.
Not on the opposite side.
Orbit.
So our main goal is to remove this disease, which is mainly arising from the left side, gone across the septum to the opposite side, eroded the anterior wall of the frontal, which will require a draft, and this lesion which has gone into the orbit, I will do a orbital transposition. With all the options open, open for the eyebrow approach. In case required, I will immediately take advantage, help of the eyebrow approach. Now in this situation, there are lots of open approaches to the frontal sinuses, you may require. Trans eyebrow approach, trans eyelid, or a complete osteoplastic flap with a bicoronal flap. But in any given situation, even if papilloma centered into the frontal sinus, if it is limited to the medial wall, you can remove inside from the draft. You can drill the underlying bone as well. If it is centered on the posterior wall, still you can remove inside or the draft only. But if it is multifocal attachment, then obviously you have to come from outside. Either use a trephination or the trans eyebrow approach as a second port for the drilling or the telescope. Got my point? Or do a complete osteoplastic flap, but in any given situation, never obliterate the frontal sinus, because then you'll never be able to see the recurrence early. That's my point. So there are so many indications, osteoplastic flap obliteration, but there is an indication for osteoplastic flap without obliteration. Because we want to see if any recurrence coming out. In case you have obliterated, you can't. Got my point?
Yes, sir. So Dr. Fazali from Pakistan is asking, is there any role for angiogram?
Not really. Not really in this situation when it is a diagnosed case of papilloma. Now the most important thing, which gives me the highest, level of suspicion for a malignancy. This is malignancy in my mind, though it is not proven yet. See that? See the skull base. This is at the level of the anterior ethmoids. Can you see?
Yeah.
Let me put the sagittal together. Sagittal together. Can you see this?
Yeah.
This is the hypodense line of the skull base. Can you see coming? Lost.
Yes, and then it is lost.
See that? See it is lost here. See it is lost here. And at the same point of time, see this hypodense line lost here. Can you see?
Yes,
Yep.
sir. Yes.
This is left side where the tumor has eroded the skull base. Though it is not intracranial, but it has eroded the skull base and we never know whether it has involved the dura or not.
Yeah.
Number one. Now coming to the opposite side as well. This is the hypodense line. This is at this area. See this, at this area, again this hypodense line is lost.
Yes.
And see, my cursor is here. See the
Yes.
opposite side at the same cribiform, the hypodense line is lost.
Yes.
So I am suspecting behind the level of the frontal sinus, see in the sagittal, behind the level of the frontal sinus, in
Around
the
the
cribiform roof,
anti-admiratory.
cribiform roof on the bilateral side, the tumor is attached to. And if this is the site, I have planned the frozen section at many sites. Number one, this site close to the cribiform, where it is attached to. Second is where it has eroded the anterior wall of the frontal.
And also the septum area.
If it is not intact, if it is completely intact, no issues. If it is a diffuse, erosion, I will take a biopsy. And if it turns out to be malignant, I will remove this cribiform plate like we did in the 2 weeks back, transcribiform, for olfactory neuroblastoma. Completely remove the cribiform and dura as a margin and reconstruct properly.
But Dr. Satish, if it is malignant, then oncologically, are we supposed to do a craniofacial in that case?
See, that is endoscopic craniofacial only.
That's it, okay.
See, in the open and endoscopy, no difference as long as at the site of attachment, you have a good margin around.
Okay.
No difference at all. So plan in endoscopy is to first remove the luminal component to debulk it and to reach to the site of attachment. What's my point?
Yeah.
Wherever we have a suspicion of a malignancy, we'll keep taking biopsies.
Okay. Okay, perfect.
See how important is MRI in this particular patient. We got so much of information. You have to have a good 3 Tesla MRI. With all these sequences, fine sequences, sometimes sublimetric sequences for all the patients. Now, this is a...
Giving clearance certain area, we have to do a subperiosteal clearance, right? So
yes.
In these areas where you have pointed, like in the skull base or in the orbit,
yes.
What is the plan? In that case, subperiosteal clearance would be a little challenging, right?
Yeah, we will achieve. Wherever demand, we'll achieve. See this sequence is a contrast, special sequence. Fine section 1.5 millimeter, contrast 3-dimensional. This is 3D. 3D with the contrast, and you can say in all planes the same thing. You can see each and everything what we have seen in other sequences in this. So let us start. Remove the intraluminal component. My only concern is I want to harvest a Haddad flap.
Okay, sir.
Because in case I remove the skull base, what I have already seen in this particular patient, the possibility, see this septum?
Yes, sir.
Like you saw in the olfactory neuroblastoma case, the upper part of the septum had gone. Same way, let me start from the anterior. Will I be able to get the nasoseptal flap on the opposite side? See this. Going from anterior to posterior, 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 yes. See that? But below this level, can you see?
Yes.
Below this level, that will be good enough for me. I want anyhow the nasoseptal flap, but yes, if it is involved by the disease, I will never ever think of. And then in case required, I'll look at the other vascularized flap in the region. Fine.
Okay, sir.
Any questions?
Sir, Dr. Kalyan Sundaram is asking what is the commonest site usually for papillomas, inverted papillomas?
Commonest is the medial wall of the maxilla, even rhythmoids. You know, that is how the Krause devised the classification. That's a very clinical classification. Stage 1, purely intranasal. Stage 2, intranasal with ethmoidal cavity or medial wall of maxilla. Stage 3, any other wall of maxilla.
Stage
along
4
with
is,
our involvement of the frontal and sphenoid, and stage 4 is beyond the confines of the sinuses or malignant. So it shows the degree of difficulty, and accordingly, a surgical, the treatment is planned.
Yes.
Surgical treatment depends upon the extension of the disease. See this. This papilloma is going, let me see how it is going laterally. A laterally going papilloma warrants, see this laterally going?
Yeah.
And this warrants
Medial max.
Dinkers.
Medial maxillectomy.
See that?
Yes.
Opposite side is not going laterally. So in this surgery, let me tell you my plan. The right side is a favorable one.
Okay.
I will start with luminal debulking of the right side.
Okay.
I will raise the Haddad flap on the right side. I will do the ethmoidectomy and the frontal clearance on the right side to know that there is no attachment in the frontal sinus.
Yes.
Then once my right side is clear,
Then you go to the left.
no need of the right frontal to be addressed, then I will come on the left side, because left side will require a definite draft 2. Now whether draft 3 is required or not will be decided on the right side finding. And then left side dankers along with draft. You know how amazing a procedure going to be.
Exactly. Do you also follow this minis
and along with the orbital transposition.
orbital
Yes.
orbital transposition?
What?
Do you also follow this minis classification apart from Krauss classification?
Not really. It is, all these classifications, you just know it. It has a
Just
value.
approach.
But see, the approach is going to be decided by your scan.
Yeah, exactly.
This scan directs me to use a draft on this side. It directs me to do orbital transposition on this side. And this probably directs me, I will go inside the
Medial
maxilla and
maxilla.
see.
Right.
Go inside the maxilla and see if it is attached there. It will direct me to do a dankers as well.
Yeah.
So if there is evidence of squamous cell carcinoma, we will give course of radiotherapy also in this patient.
100%. That is the indication for radiation. Sometimes the radiation is indicated even in the benign setting with multiple recurrences, unresectable, no evidence of malignancy. Sometimes the histological criteria are difficult to define malignancy. Regarding the mitosis and necrosis and hyperplasia and all those things are the criteria, and those are so difficult for the pathologist to prove malignant.
Okay.
In this particular patient, any history suggest you of viral infection like HPV or anything?
Not really, but yes, HPV has been in certain studies shown,
Even EPV.
but never proven. But some people believe the HPV as a disease, progression, for disease progression rather than initiator.
Yes.
As HPV 16 and 18 have been proven in some studies, not all, to give malignancy, because the HPV genome once integrates in the host genome, it affects the p53 suppression.
B53.
And that is the reason for malignancy.
BGF and COX2 too. Yeah.
Yeah, COX2 receptors are there in papilloma, Up to 50% of the papilloma COX2 inhibitor, and we have started giving all these patients celecoxib also.
Celecoxib, yes.
If you have a slightest doubt, get a P16 done for HPV. If you find positive, give HPV vaccination also.
Okay.
And HPV-induced malignancies in papillomas are more favorable malignancies as compared to the other.
Indeed. Fantastic discussion. Thank you.
Oh, great.
So we are getting ready for the next one. And
It's going to be a treat to watch.
we have all set with an image-guided system. With our all drilling, we are set for the draft as well as dankers both. So this is going to be a huge case.
Yes.
One of the most extensive papillomas one can think of.
Might need an approach.
After this, we'll take the next huge fungus, with blindness, who came with blindness.
Okay.
We started immediately methyl prednisolone last evening. With 2 injections, he has started improving with methyl prednisolone and itraconazole. And he has shown the, started improving. So we have kept now with all COVID testing and everything done now.
Okay.
Any questions? Is Professor Darlin there?
Professor
She's there in
Elvis
between.
is there.
Yeah, she's there in between.
Yeah. So the inverted papilloma is known for recurrence, right? That is there's a myth, I think I would say, because if you take a proper plane, you take a proper radiology, then if you take
You
it
have
properly,
to go to the site of attachment and completely remove that.
Yeah, yeah.
Drill away. That's
Yeah,
why we define these papillomas. This is our own, criteria. Whether this is favorable or not. Got my point?
Yes, yes.
We define for our sake whether it is favorable or not. In the sense, see this endoscopic pic. If I am able to remove the underlying bone completely,
Yeah.
completely, we call it as a favorable one. Suppose this is attached to the medial wall of the maxilla and I remove the medial wall of the maxilla completely, that's it.
Yeah, that's it. Yeah.
That is favorable. But if it is attached to certain site, which I can't remove radically, then it is unfavorable or difficult to remove radically. And in this patient, there are certain sites which are difficult. One is the skull base involvement, other is the anterior wall of the frontal sinus involvement, orbital roof. All these are unfavorable sites,
Yeah.
Are you getting the picture?
Yeah, we're getting it.
And see the synechia on the opposite side. See the synechia.
That's because of the previous surgery.
See this? Because of the previous surgery. Yes. See the polyps. Is the picture good?
Yes.
See, I am just doing the luminal debulking. I told you I intend to raise the septal flap from this side. See my direction of the blade. Away from the septum. See this? This tissue, if you take for a biopsy, it will turn out to be negative. So where to take the biopsy from should be guided by a good diffusion weighted MRI. This is what we believe. See, this part of the septum looks good. Hello?
It looks good. You can take a flap from here.
And see this all luminal. This is all polyps. Such tissue I will never send for histopathology because I know this is not a representative tissue.
Because recently I did a case similar like this, and the biopsy was squamous cell carcinoma.
See this, how much of the bulk is there. Cobblator. See the luminal debulking.
Yes.
And because of the previous two surgery, all sinuses are partially opened up. See the vessel there?
Yes, sir.
Yes.
Again, this could have very strong suction.
Suction is super fast.
Action is always the man of the match.
Suction is the main thing. I cannot work without a good suction, believe me. And this is what, wherever I go for the workshop, the first thing I ask is suction. 40. 40, 40. Now see the lower part, the septum is good.
Yeah.
See, not even a scratch because I was keeping my blade away.
Directed away, yes.
Yeah, see the opposite maxillary, all retained secretions. See, this was why I started from the non-dominant side. You can understand now.
Yes, yes, yes.
So without a proper radiology, the surgical planning cannot be optimum. See the terminate? See how the lesion is so clear. See the vessel here. Yeah.
It's a huge one.
Suction लगा. Suction करो. हटा. See the vessel, the same vessel.
Yes, yes. Almost 10 years back, I operated one inverted papilloma. There was loss of almost 2 units of blood because there was at that time no carburetor was there. We used to use the bipolar only.
Suction the cautery. Suction cautery coming from the bone. Yes. Just a minute. Yes.
This is a monopolar cautery you're using, sir?
Yes.
Yeah, coming from the bone. That's why. Okay. This is insulated.
Yeah.
Yeah.
You can see the insulation. Black.
Yes. Wash everywhere.
Very useful instrument.
Yeah, at times. Yes. Give me the cobbler. See, my septal flap is good one on this side.
Yes, yes.
Without any issues. Secretions.
Yes, stimulated.
This is superior turbinate. That is the ostium. And here now I am taking off this, synechia. This one. Okay?
Yeah.
And see now the disease through and through. See, this disease is through and through the septum.
Yeah.
Can you see at this point?
Yes. Yes.
Lower part of the septum is good, but see above. Is absolutely through and through. Can you see very clear or not?
Yeah, very clear.
This is the representative tissue also, I think, which can be sent to frozen.
This one. Now I will go to that area later, and first let me raise my flap. I don't want to spoil that.
Dr. Satish, did you take a biopsy from that region where it has perforated the septum?
Yeah, I will take.
Yeah.
I have more better areas.
Get a frozen.
Yes.
Why you're doing a...
Right. The same thing I was planning. Wherever is the bone destruction,
yes,
and papilloma is going beyond, we are supposed to take a biopsy. As simple as that. See this? It is coming from opposite side. See this?
Yes.
And I can take this level. Frozen. Suryam जाएगा. ये तू मैडम. बेच हेमराज बोल. Quick. See that upper area? Everything?
Yes.
Away. And let me take my most important concern is the Hadad flap.
Yeah.
Because in case I have to take the skull base, I have to.
The good thing is inferior part doesn't looks very healthy.
Very good. It looks very good.
That is what we saw on MRI.
Exactly.
All planning is through the MRI.
So,
see, this is sphenoid clear.
Nice.
Yeah.
Just mucosal edema. And now, give me the knife.
Yes.
I can take a good Hadad. ये थोड़ा बड़ा है, ये छोटा दे. Pack, small pack. See my limit of the Hadad here. But to me, it looks enough. In case it is not used, I will replace it. See the lower incision?
Yeah.
I can take little bit on the floor because superiorly I may not get adequate. I can use my Colorado also. And this superior incision, superior incision. See the site where we took the biopsy.
Yeah.
We have to stay away. Hata.
Below that.
We have to stay away. My knife can also feel the intact septum there.
Okay.
Now I can rise up. See, this will be huge one.
almost full septum.
Yeah,
Obviously.
that will be huge.
See, no infiltration done.
Yeah, I saw that. I was about to
I
ask.
never do. You can have a little bit of the bleeding, no issues, but it gives you a, you know, you can use the, if you want, the saline injected, you know.
Yeah.
Dissection.
Yeah, suction.
Why you avoid this local vessel? Why avoid adrenaline?
See, you're not supposed to induce spasm in the vessels.
Yeah.
Exactly. And number two here,
Which has a
being
bearing on the, you know, vascularity, no
Yes.
survival of the flap.
Yes.
Knife. सिर पकड़ना एक जना सिर पकड़ो सक्शन लगाना वहाँ पतला ले जल्दी कर
Are you anticipating a multifocal attachment in this patient?
Could be. इधर कर. Could be. You never know.
Yes. Generally, the multifocal are more aggressive, right?
Multifocal are more
aggressive.
Obviously. When you have a multiple attachment, your planning is altogether different, you know.
Like Dr. Efrain from NSUL is asking which solution you are using for irrigation in between.
This is ringer lactate
Yes, sir.
or saline. Ringer lactate and saline. And you know, nowadays we mix in most of the cases the povidone iodine, 0.5%.
COVID this thing.
Because of COVID. Either. A little difficulty. Sometimes the septum is very thin in this particular individual. So you have to be patient, you know. All are not alike. See, the flap is so thin. Can you appreciate?
True,
Yes,
true,
yes,
true.
yes,
Very
yes.
true.
Very true.
It's not always the same. And let me see if I'm missing the perichondrium. Never know. कर ये मेरा वो elevator नहीं है यार, regular one. Give me the regular one, Cottles. बुलाते हैं उसको. Suction करना है सही जगह पर. चलो. देखना perichondrium रहेगा. Yes, it looks like I've left the perichondrium behind. Can you see? Hello?
Yes, yes.
Yeah, yeah.
You are elevating the pericardium.
Yeah.
Now we can see the septum also.
I can appreciate the feel.
Yes.
Maybe. Not sure.
I think nothing is there.
Look like
Not really.
No, no.
Okay.
You have a perichondrium on the flap.
Scissors. पकड़ो. This way you have to elevate it. See, such a thin flap. Can you appreciate?
Yeah, it's a thin. That's what.
Because you can't use too much of pressure. This flap is so vital for me.
What if we are not able to harvest hadad? What else do you use, sir?
There are so many options we have. Hadad is the most robust, most reliable. It is like नीचे करना रुको रुको ना अरे अंधा है रुको. It is like PMMC for head and neck.
Right.
Yes, yes.
Time tested one. The vascularity is so robust. Other flaps you can use the lateral nasal wall flap.
Okay.
That is, you can reach quite big in size at the same time. Or if not at all available in such situation, we recommend the pericranial flap. That also you can place endoscopically. The only thing is you have to come with a external incision, though
Then you
it
rotate
is well hidden in the hair, but still it requires an external approach. See, you have to be cautious.
Yeah, yeah. Even it.
might get torn.
I have to be careful from the upper side, not to go to the. See this? To stay away from the disease area. Can you see?
Yes, yes.
And this is absolutely uninvolved part of the septum. See this?
Yes, sir.
The upper part is involved, which I don't want to take. Section. I've taken a part of the nasal floor as well.
Is there any free grafts which you take sometimes?
Utha. Pardon?
Any free grafts or which you take?
Free graft should be avoided. Free graft should always be avoided because, yes, we have used earlier, but the free graft takes time to, vascularize, and this is ready-made vascularity. There's a huge difference. So the infection rate is less with the vascularized flap as compared to the free graft. See now the flap coming up?
Yes. So even in CSF leak repair, you take hadad.
Hadad is one of the best for the CSF leaks. See the anterior surface of the sphenoid?
Yeah.
Where the pedicle is?
Right, yes.
Very thin flap, very thin.
Very thin.
Yeah, relatively thin. Doesn't matter. Every time you can't expect a favorable thing. Yes. See, I am pushing it behind in the nasopharynx.
Yeah.
Now, whatever alteration in the length, if required, I can release it from below further.
Yes.
Depending upon the need, we'll do later. Okay?
Yes, sir.
I have protected with my gauge piece. Now, for this side, this is my first target it was, and it is done. So, luminal debulking and debrider. Hadad flap. Straight. And now I will go to the, let me widen the sphenoid. I'll go to the frontal recess on this side. Now the most important observation that I have to make is whether it is attached anywhere into the frontal recess on this side. If it is not, then I will not need a draft 3. I will be through with the draft 2 only. That is the sphenoid sinus.
Right.
But it was not affected, so I will not do much. Now, give me 70 degree. And let's go up in the frontal and finish this side. And then go to the core area on the opposite side, quickly.
This side frontal also has some intracranial.
Pardon?
This side frontal also has a little bit of intracranial extension.
This side frontal?
And does it have a bit of intracranial extension? Or has it
No,
eroded?
not really. On this side, frontal has no intracranial extension. The cribriform is something where it might be attached.
Okay.
Not frontal. Frontal is clear on this side according to the scan section. See, this is the sphenoid.
Yeah.
The Hadad flap we have raised. This is the maxillary. This is the flap protected. I am with the 70 degree.
Oh.
And now I am removing this gauge and see the tumor going up. See, coming from the opposite side.
Yes.
Debrider. So it may be attached to the cribriform, which I expect. See this?
Yes.
See, this part of the septum I am going to remove.
Yes.
Few millimeters beyond. Okay?
Yeah. You've got a margin here. Now.
लिख के लाए अगर उसको बोल कौन बोल के गया See, that is the frontal recess behind.
Yes.
Let me see. कौन बोल के गया था ये? लिख के दिया कर बताना
Hello.
Yes, yes.
See the ethmoidal roof.
Yes.
See, attachment and involvement, these two are different things. See laterally in the frontal recess, 120. See laterally in the frontal recess, it looks like it is protruding. See this wall, this mucosa, there is no attachment anywhere. Can you see?
Yes.
Wash, quick.
We can see artery also, I think. Looks artery?
Yeah, this one. Give me the cord section. The same vessel which I am going to take care of it thoroughly now. I was waiting for the frontal and then we'll see this vessel.
Yeah.
रुक जा कॉर्ड से वॉश कर नीचे से धीरे से. Can you see the frontal?
Yes.
Now see why I have taken this blade to confirm whether it is protruding. See this?
It's not attached.
Can you see? This is protruding.
Yes.
See, this is coming out because there is no attachment inside.
Yes, there is no
Yes.
See, it will come out in no time. See, you have to ensure everywhere because the site of attachment information is very important. See the smooth mucosa below.
Yeah.
Give me wash.
Can be elevated off.
This is so important to ascertain because all this has a huge बड़ा देख लगा लंबा. जूता लग. See? Washing out.
Yeah.
Cord section. This is all secretions. Can you see this?
Yes, clearly. Normal mucosa.
Attachment is ascertained with the underlying mucosa. How smooth it is. See this? All the way.
Absolutely.
No question. Laterally. Medially, not sure yet. One thing is sure, the laterally nothing is required to be done.
Right.
See that?
Yes, sir.
Medially see the tumor across the septum and then into the frontal as well.
Yes, sir.
Okay?
Yes.
Medially we never know. Now give me the cobblator. So this is very clear now that medially I may have attachment, not very sure. But laterally, for that matter, I don't need to drill anything. Okay?
Right.
Cobbler. I have to drill this part of the beak here. See this part of the bone where there was a lot of vessels.
Yes.
Yes, sir.
Could be because of inflammation or whatever. I will not take a chance and drill away.
Okay.
Cooler code. Hata, hata. See, all small things are important. नहीं रुको, पहले वो दो. Cobbler. ये तो रहता. रुकना. Cobbler. All these areas are important. So important to rule out. See this bone of the anterior wall. Not looking good. Drill.
Is
See
it
this bone.
CSF, Dr. Satish?
Pardon?
Is that CSF coming out by any chance?
No way.
Oh, really?
Where is CSF? How
No,
can
no,
it come now?
no, the fresh blood coming there. I thought it was.
You know, this bone, which was looking inflamed or of vascularity there,
Yeah.
I am drilling in order to get a good, healthy area. I am with the 70, right now. What is good now? I want to ensure this part of the lateral part of the sinus is healthy. Now give me the curved section. See, this lateral part of the sinus is healthy.
Yes.
And
yes.
all this bleeding I will control. No issues. There. तेरू कॉटरी नहीं चल रही. Why not working? दूसरा दे देना यार टिप. Oh God. No. Yes. Yes. Give me the debrider and wash. See, I don't want to leave any chance of, ascertaining any disease in this frontal sinus. Now it's a much better picture.
Yes, sir.
Very nice.
Then I have.
can you again tell type of lothrops? Many people are asking hemi lothrop, mini lothrop.
Types of lothrop.
Yes, sir.
See, last time you saw the draft 2.
Yes, sir.
Again, I show the draft 2 today.
Yes, sir.
Draft 2 is draft 2A and 2B. Count section there. According to the medial extent. Draft 2 is ipsilateral removal of the floor of the frontal sinus, like you saw in the last case.
Yes, sir.
If you do up to the middle terminate level 2A and go up to the septum, intersinus, lagana, intersinus septum, then it is 2B. Okay?
Yes, sir.
If you do the 2B on both sides, along with removal of the intersinus septum and the upper part of the nasal septum, it is draft 3 or modified endoscopic lothrops.
Fine, sir.
Okay?
Yes.
Now, in situations where that is the most radical procedure, I would say, biggest procedure. Now this side is clear. This was required to be done on this side. And now quickly give me 0 degree. Wash, give me good wash. Let me show what I have done on this side. I'll come to the draft. Wash. See the frontal recess on this side?
Yes, sir.
The skull base, everything is clear. No doubt of any disease.
Yeah, absolutely.
Attachment on this side, inside the frontal, okay?
Yeah.
Yes, sir.
We have already raised the hadar. We have seen the septal which is perforated from above, from where the disease came to this side, and see the part of the frontal we exposed.
Yes,
so,
sir.
Draft 3 is, now we'll go to the opposite side. Bilateral removal of the floor of the frontal sinus with removal of the intersinus septum and the upper part of the nasal septum. It's a complete marsupialization of the frontal sinus in the nasal cavity.
Both sides. Yeah.
Both sides. Yes, sir.
Now, when you do a draft, like we did draft 2 in the previous case, with
Yes,
removal of the intersinus septum and going to the opposite side, you know?
Yes, sir.
That was hemilothrops.
Hemilothrops. Yes.
Had I been requiring going far laterally to the same side, which I am not able to go to the medial approach, I mean through the draft 2, I will come through the septum opening on the opposite side. If I come from the opposite side and go ipsilaterally far lateral through that ambulation, what my point?
Yes, sir. Yes.
Along with the intersinus septum removal, that is subtotal lothrops.
Fine, sir.
If you don't have to work laterally and work in the central part, medial to the turbinates on both sides, and removing the floor in the center, that is central lothrops.
Fine, sir.
If suppose you are operating on an ipsilateral frontal sinus disease, which was operated earlier, orbital fat prolapse, there is a lot of neoestrogenesis, and you really can't reach to the same side frontal with a draft. You go to the opposite virgin side, do a draft and remove the intersinus septum and drain the opposite sinus through the normal side. That is modified mini lothrops.
Yes, sir.
Now see to the opposite side. See the massive papilloma.
Yeah,
Yes, sir. Yes, sir. Yes, sir.
Now this is predominant side, you have to be careful. Here we have to stay most radical.
Oh, suction.
Look at the suction.
Yeah.
Fantastic, sir. Fantastic. So it is looking like we have fast forward the video 2x, 3x.
See, in surgery, wherever you are working with a less important step, you know, you can expedite and save time.
Yes, sir.
You are working at a crucial step, you have to invest time. That is how you can do fast. The luminal component removal can be done fast. See the freed straight forceps.
And for update, just narrate the different flaps, especially for septal perforation.
Yeah, we'll keep. You want a case of septal perforation?
Yes, sir. Yes, sir. Please, septal perforation case.
Yeah, we'll keep.
And which flap you prefer means different, like different.
There are so many varieties, you know. According to the need, there are, 10 techniques which we do differently for different situations. Keep one by one. Now, give me 40. See this luminal component. Now we have to see the lateral part. We don't know where it is attached inside the maxillary. Because that is an important decision making for us whether to do a Dankers or not.
Yes, sir.
Better to do it.
Better. It is, see, infiltrating.
Yeah, that is that.
Let's see. There are certain procedures which are very common in our practice, or for any endoscopic surgeon, I would say must be well versed with. Every day we do in our practice, one is Danker, another is draft, and third is nasoseptal flap.
Every day?
Every day.
Wow, that's great.
So every endoscopic surgeon, what I always say, must be well versed with these, three important procedures.
This is our 10th Dankers is of this webinar.
Pardon?
This would be the 10th Danker of our webinar.
Yeah, because this is such an important procedure. Suction. Yes. Looks like it was not invading the inside walls of the inside wall of the frontal sinus. Let's see. Section there.
Professor Hellstrom is also with us.
Oh, sir is there?
Yes, sir. Sir was there.
Hello, sir.
He was there, but he's muted, and that's it.
Oh, so nice to have him, sir. Hello. Good evening, sir. Touch kar. See, the maxillary sinus doesn't have attachment. It was prolapse inside the sinus. Could you see?
Yeah.
Yes.
That I told you we'll take a call for the Dankers if required. We can't take a prior decision. We can't get biased. We have to be careful. It could be attached to the lacrimal system. We have seen papillomas going into the nasolacrimal duct and then lacrimal sac and then into the orbit. We have seen isolated without any involvement anywhere else. Okay, probably I don't need the Dankers now. Let me clarify. And that is something good.
And sir, also please keep a case of endonasal DCR. We haven't shown a case of DCR.
Yeah, we'll keep, sir. Definitely. I've seen few people doing so good at DCR. Believe me, it's always good to learn from them. One is Dr. Nishi Gupta from the Shraf Eye Hospital, Delhi, Eye and ENT Hospital.
Yes,
A
yes.
huge number of, And another is Dr. Vivek from Thane, Vivek Jadhav.
Jadhav, yeah.
Amazing. You remember he demonstrated in your Agra.
Agra.
He does good in the
And he also does a lot of cases. His wife is ophthalmologist.
Okay.
To feed him cases,
My wife is also ophthalmologist, so I also get DCR.
Oh, good. Look. So one thing I can say now, the dankers is not required.
Yeah.
Rest I will take a call after 70 degree. And see, this is the medial wall, maxilla, sorry, this is the orbit, medial wall. Can you see?
Yeah.
Yes, sir. Yes, sir.
Now what I will do, put a pack. I will remove this upper part of the septum to define my superior extent here in the midline. Because my, the lateral is planned. कोई सेट तो करना हो वो भी करा दे. Next case we are inducing is the massive AFS. So after this, 3 more cases to go.
There's one more angiofibroma.
Yes, that is a bigger one. Then a cobbletter. Cobbletter. See, this is lamina.
Yes.
Wherever you have a doubt that you have not adequately cleared the papilloma, wherever we are not 100% sure, I would advocate them to apply the 5-fluorouracil ointment there.
Okay.
Not even fully sure, even if you are fully sure and was extensive invasion, it is best to apply their ointment intraoperatively at the end of the surgery and in follow-up also for some time. That's a very good thing. It has been proven to have a good, role in preventing the regrowth.
You get those ointments by the
Yeah, I will show you our ointment which we use. I will show you after this case, which I will show you everything about that, the brand and what we are using.
Is it only for this particular disease you use, or
for all advanced cases? Earlier we used to use in all adenocarcinomas of the sinonasal cavity, because adenocarcinomas is something like a situation of field cancerization.
Exactly. Yeah.
And in adenocarcinomas, our surgical policy requires complete removal of the sinonasal mucosa radically, because that is something like a field cancerization because of the etiology, exposure to the industrial exposure and all that. Even if you remove the area which is involved, it can arise in the other areas later. So there we remove a radical, excision of a sinonasal mucosa because of this situation of field cancerization. And then we apply the 5-fluorouracil. See this? I am removing this upper part of the septum with some margin. Can you see?
Yes.
Yes, yes.
With some margin. Here we already taken our cut accordingly. And see the papilloma in the center there. See that?
Yes. Yes.
I was expecting the attachment to the skull base. And this is what you can see.
Yes, yes.
See how radiology has an impact in everything.
Yes, sir.
Decision making.
That's the only way you can plan your surgery.
Yes, so you have to have a dynamic, detailed radiology with all sequences according to the need. See the opposite anterothoidal artery,
Yes, yes.
frontal recess. This is the central part where the disease is. See now the situation has changed completely. Now I am removing this ethmoids, you know.
Right. Are you using navigation in this?
Yeah, in this I have connected navigation I will be using. See, all patients which we are operating, our CT, MRI is according to the navigation protocol. Always done. Whenever you feel like, we can connect in 5 minutes. And this is a fusion system. We can fuse both CT and MRI.
Okay. At the same time?
Same time, yes. Right.
Now, I was not aware because I also have a fusion system, Medtronic. They didn't
Pardon?
tell me. Even I have a fusion system, Medtronic, but they didn't tell me this, that I can put MRI and CT at the same time.
No, you can. Why then? That is why it is fusion.
Yes.
Why don't you fuse?
I'll ask him.
MR will give you soft tissue details.
Yeah.
See now, here the ethmoidal roof is clear.
Yes, yes.
No attachment. And see here, this is what I want to ascertain. See here, it is attached. Can you see this difference?
Yes, sir.
No smooth mucosa over it. Can you see?
Yep.
And that is what the site of attachment is. Pani dal, Guru. Oh, what a wonderful finding. See in the center. That is the attachment. Okay?
Yeah.
Give me. Drill.
Though we have answered all the questions, but there are
Negative.
questions coming.
The previous frozen had turned out to be negative.
Okay.
Okay. So this is invert carpet.
We'll take from here now. See the recess?
Yeah.
This is the anterothoidal artery here on this side. See that?
Yes.
Yes, sir. Yeah, we can see.
This is the source of bleeding in majority of such patients, here. Now, see the central area.
Yes.
This one.
That's totally attached.
Yes. And We are ready to remove it and reconstruct it as we have a Hadad flap. See the picture?
Yes.
Yes, sir.
Clean, clean.
Though we have covered all the questions, but we have questions coming from Venezuela, from Namibia, from Ethiopia,
Oh, really?
Pakistan,
Wow.
all over the world, Australia, all over the world, people are still watching. They are glued to the screen.
Oh, great to know. So now, this is the sphenoid sinus on this side now, here.
Yes.
And this is the area of the cribriform, which is where the tumor is attached to. See this?
Yes.
Yes, sir.
You can see the difference in the mucosa here and here.
Here, right.
This is good, normal. This is just, you know, just for the excess. What is this? Is this tumor or not? Frozen.
You got the report, previous report, frozen report?
Pardon?
It's
You got the frozen report?
Negative, sir.
Now I want to ask whether it is tumor or not.
Yeah, you have to reconstruct.
See, we have a doubt whether this is tumor or not, or just a mucosa.
Are you taking a frozen section?
Yes. नहीं है. May not be. Give me the coblation. Let me see. May not be, boss. Hello?
Yes,
Yes,
sir.
yes.
May not be. Let me see.
How does the underlying bone appear to you?
It's good, normal. See this? This could be normal as well. See this?
Yeah.
I'm trying to remove this mucosa and see any slightest doubt.
Looks like healthy bone.
Yeah, the bone looks absolutely healthy. This may not be, See?
Just
This
inflamed.
is just the mucosa which was inflamed, not the tumor. I can be sure now, and we'll wait for the frozen as well. See, I've completely coblated as well. So this looks normal. Can you see the close-up?
Yes,
Yes, sir. Yes.
Looks normal.
That looks normal. Anyway, we have a good exposure here. Give me the Merocel. Many a times you have to think twice on your decisions intraoperatively, you know.
Very true.
I think to be safe is better than sorry. So what we are doing extra mileage is always better.
See? No tumor. Can you see?
Yeah.
Yes, sir.
Very
I'm
nice.
just looking for the close-up. It's all healthy, absolutely healthy. Can you see everywhere?
Even we can put that flap over here, just or you can just any flap to cover
Pardon?
this area.
To cover
Will you
this?
put any flap? Yeah, will you put any flap, anything to cover this area?
I can cover. Let's see, I will put a free mucosal graft otherwise.
Yes, yes.
Not very sure, but looking quite good. Now coming to the area of interest, that is frontal.
Yes, yes.
That is, and for that, this is your orbit, and I have to go above there by means of a draft, you know.
Draft, oh.
मेरी तरफ. And for draft, like you have seen earlier, this patient require orbital transposition, as well as, you know, it may require a outside approach as well. Access. Like, you know, eyebrow or eyelid approach, whatever. Now this is the most important part, because this disease has already destroyed the anterior wall of the frontal sinus
Yes.
and close to the skin and the subcutaneous tissues.
So Dr. Sohail from Karachi is asking, using cobbletter on the cribriform area, does it affect olfaction of the patient?
Yes, like this cribriform area we have cobbleted now.
Yes, sir.
This will definitely affect, but I don't think this patient has a good olfaction already. With this much of disease and completely blocking that region for long. So here olfaction is secondary now. The drill. Now see the bone which is to go.
Yes, yes.
So the second draft of the day.
Yes, sir.
And more to come. देखना देखना क्या कर रहा है यार चला जस्ट करो करो ड्रिल पे करो just a minute we have to wait for the drill उसको मैक्सिलरी खुलवा दे दोनों. The next patient we have already taken, you know. कोई सेप्टर तो करना है तो वो भी करा दे. क्या? See the outside skin?
Yeah,
Yes, sir.
Yes, yes.
I hope after these webinars, so many drafts and tankers, I'll be happy if everybody starts doing on their own.
You have taught so many people so many things. This will also come.
Because this is something, if you intend to do endoscopic work, one should know. And see the repeated requirement of this procedure in so many things, how important they are. We have one more tanker coming up today.
So you're following the skin.
See, this is the disease.
Yeah.
Yes, sir.
See how quickly one can accomplish. चल चल सोए मत.
How excited I am to.
See,
The skin has come.
that is the outside skin.
Yeah.
Yes, sir.
Yes, yes, yes. About to. About to.
जल्दी यार. Right on. Suction. Pull. Come. See the skin.
Yes. Very clearly, very nicely.
This entire bone has to go. And very soon we are going to achieve that.
It's almost done.
See, such a safe zone it is.
Yeah.
The cribriform is behind here.
Yes.
And you are miles away from that. In a different direction. At the most worst to worst, what you can do is a buttonhole. That's it. Boss, you got that 50 burn, huh? 50 angle. Keep ready. Now let me have a look inside with a 70 degree to see the assessment, for the assessment. Wash, wash. See the frontal sinus?
Yeah.
See the frontal sinus of the opposite side, pretty clear?
Yes, sir.
Look, पानी section. हाँ. ये पकड़. And see the disease here.
Yes.
See the disease here.
Yes, sir.
This frontal sinus.
बड़ा था यार. See this disease?
Yeah.
Yes, sir. Yes.
क्या हुआ? 60 लगा. Now this is your periosteal plane if you see.
Right.
Here, wherever required, I find I have to go subperiosteal. See this?
Yes. Lifting off.
For a radical clearance. This is my orbit wall. Oh my God. Well. वो लगाएगा कार्ड बार. कर्व्ड बर, बर नहीं बर है क्या? लगाओ. See this
Is the attachment on this side?
this involvement. Yes, I will see. See this involvement.
Yes, sir.
Attachment can be known from the status of the underlying surface. You know. See this posterior table descent.
Yes.
Yes, sir.
Could you see?
Yes, yes.
Here I have to see very closely this anterior extension which is going toward the skin. That I have to assess thoroughly. Give me the drill. 60. Here I will use the angle drill now. Now the most crucial part of the entire surgery. Here. This posterior table looking good. नहीं यार ये कौन सी दे दी तूने? This is the angled bar, but this is dangerous. This is not the diamond one, boss. Give me the diamond now. Diamond. This is dangerous. Angle rack, sub angle rack. Cobblator. See here anteriorly. See this disease is going anteriorly towards the skin.
Right.
We have to assess this, disease which has broken the anterior wall of the frontal sinus very carefully. In the past, this used to be a indication straightforward for the open approach, you know. But now with the advancement in endoscopic technique, many a times you can deal with endoscopically as well. But I have already told, in any given situation, if I have a slightest of the doubt, I will not think twice to go from outside with a small opening, you know. Yes, drill. See, this is angle diamond bar. It's 70 degree. Wash. This is 70 degree angled. Hello?
Yes,
Yeah,
sir.
this is the angle. Okay.
And I am using the M5. This is not through the stylus, this is through the M5, which automatically gives me a speed of 30,000 RPM.
Superb.
Yeah. Wash.
Any reason you're not using the stylus and using M5?
Because I want an angle here far anteriorly under vision. So I want an angled one.
Yes, nice.
See this? This anterior most involvement.
Yes.
I want to make sure whether it is going in the soft tissues or not.
Okay.
See, this is the separation.
So externally, if you give pressure, is it moving by any chance?
Yeah, that can help you, definitely. Up and coagulation. But नहीं आ रहा है इससे पकड़ में। Other one, giraffe. I can get some good plane at some place.
Does the skin look involved too?
No, what I want to see, the bone is gone.
Yeah.
The involvement of the skin, soft tissues,
Is it looking
that is
involved?
important.
Yeah. Hard to comment. Looks to be involved, right?
It looks like a skin is something is there.
दबा बाहर से दबा. Yes.
And suppose the skin is involved, then what would be your this protocol?
In case skin is involved, then is a indication for a radical resection from outside. See the subcutaneous area.
Yeah.
Yes, yes.
So you will be taking this for frozen? Is that what your plan is?
Yes, I am just separating and take this for frozen. This particular portion here.
Yes, yes.
But the only advantage is if it is by chance anything you can that because it is close to the skin to get a good margin is easier, right? I mean,
120. Huh? Pardon?
by chance,
No,
if it
if this is involved, we have to come from outside and remove the skin.
skin, exactly.
And put a flap. No doubt about it. Wash. Wash, man. Coblation. Coblet. See, you have to full control in the idea. Hmm. 60. See the most crucial area. See, we have a full exposure. There is no compromise in the exposure.
Yeah, exposure is very good.
See?
Both the frontal sinuses.
Superb.
The underlying bone in the frontal sinus looks normal.
Yeah, it is normal. That's why. घूम रहा है यार. लॉक करना है. Underlying bone is good. Reverse the एक बार. See what of inverted papilloma is. When it invades the frontal, the game is altogether different.
Exactly. So true.
That's true.
This is so-called adenoid blade.
Yeah. That's the best blade for this place.
Yes, because it is away from the damage.
Because of you, no one is buying it for adenoid. All are buying it for
I
skeleton.
never use for adenoid.
Yes, sir.
कब लेटर देना?
Maybe chances of secondary skin necrosis because of blood supply.
Chance of?
Skin necrosis?
Not really. The skin is very healthy. See this, the skin from above.
Okay, yes.
No issues. And it cannot. The skin has a huge base. It is not that. It was something in this region, it will lead to skin necrosis. See now, I am removing in the plane, in the subcutaneous plane, all this tissue up to the level of the subcutaneous plane I am removing. See how difficult the anterior wall is.
Yes, sir.
That is the key. Give me the... I'll come to it later. Allah there. Brighter. Wash the neck, wash. Wash. Come. Suction. There, वही दे वापस दे बार. See rest of the frontal sinus.
Yes.
Fantastic looking. Excellent.
Oh,
Excellent
not
view
sure,
of-
boss, yet. Not sure. Reverse the. Secretions. The rest of the sinus is good. See, this is where it is going to the orbit.
Orbit.
See the periorbita?
We'll do orbital transposition.
दबा के रख. See this? Where it was going to the orbit.
Yeah.
This is periorbita. See that?
Yes,
sir. Yeah.
That component is coming out easily. See, there is no invasion.
Yes.
So no need of an orbital transposition here.
This is almost done.
Yeah, done.
Oh, the orbit. This is orbital transposition only because.
Yeah, this automatic done.
Yes.
So what would you have post of protocol in this case for next 6 months?
Irrigation will apply 5-fluorouracil up to 1 month.
Yes.
See, this is transposition orbit.
Yes, done.
कब लेटर देना. I will show you more. Watch करना एक बार. I am cutting off this anterethmoidal artery here. See this? That's it. Go on.
Okay.
This is periorbita.
Yes.
Normal periorbita, which I am using. Here I am using a coblation on the periorbita. It is very safe. See, this is above the orbit. See where the disease was going.
Yeah.
Yes.
Now what I will do, पकड़ इनको.
Any role of radiation in any form?
Pardon?
Any role of radiation in post-op?
Radiation, if it turns out to be malignant, number one. And secondly, even if it is not malignant, turns out to be difficult to remove, you know,
Yes.
then obviously is an indication. So good.
Because we expect some micro residue inside. So that
Yeah. If it turns out to be malignant, छोड़ना उसको रुक. Let me show. Yes. Give me cobblator. See the orbit is decompressed.
Yes, coming out, coming in.
As long as periorbita is there, you don't need to bother about. See this?
Yes, beautiful.
Absolutely normal.
Fantastic.
See where endoscopy can take us.
Dr. Palani, Appan is asking what is the lateral limit for orbital transposition?
Orbital transposition, you can go right up to the lateral wall.
Okay.
And posteriorly up to the anterethmoidal artery. Now what I am trying to do, this skin I have completely cobblated. Like Pachori was saying, if any micro invasion or anything. See this?
Yes.
And now I will remove drill. See where I am working.
Yeah, all
Yeah, this bone. Tablator. See the complete exposure of the sinus. Wash.
Yes.
See orbital surface completely.
Yes, sir. Yes.
Dr. Riaz Afridi from Peshawar, Pakistan is giving full of compliments and credits. Sir, it's easy in your hands because there's brain behind his hands. It looks so easy to watch, but difficult to. Dr. Satish is king of ENT.
It should not be difficult. See, once you get used to, there is no other way to deal with such disease, you know. No other way. See what I have segregated, the orbit.
Yes, yes.
Absolutely. Now give me the drill. And now this entire area, I have to suction. इसको retract कर लेना. Suction. नहीं तो suction रख ले. इसको तो अलग कर. See now?
Yes,
sir. Yes.
Wash.
So
only tip is rotating.
Would it be stage 4 then?
Pardon?
What would be the stage of this disease?
Yeah, we are looking for the cure, boss. That means it is aggressive. We have to stay aggressive. See now the underlying bone.
Yep. Yeah.
Which everywhere I am going to clean up. This raw areas will be taken care of with the irrigation. No issues.
Yes, sir.
See, nowhere I will leave any chance.
Will you be putting the flap back on this?
See how it is cleaned. Yeah. I will be needing your verdict at the end whether I have cleaned it or not completely. See the bone?
Yeah.
Wash. करो पानी डालो. See here, in spite of the mucosa being normal, I don't want to take a chance. Dura. Point डाल. See all underlying bone. Point डालता रहना यार, बोलना क्यों पड़ रहा है? हाँ, डालता रहे. डालता रहे, बिना रुके. Wash.
The dura is exposed there.
I will not leave a single area of doubt of any invasion of the papilloma. And this bone has to go until you find a normal bone. See, this is drilling on the posterior table.
Yes, yes.
You have to be careful to prevent the CSF leak.
Yes, sir.
Wash. See at what level I am drilling. See this disease or whatever, mucosa. Reverse, reverse. Adenoid blade. Find all now. I am removing all this mucosa, you know.
Yes, yes. There's still something there.
Coblator. See, the orbit is absolutely free from the disease. You
Yes.
can say that is separated, segregated.
Yes, true. Very nice.
Hata. Whatever fat a little bit prolapses, you can coblate. Simple. No issues. See these difficult dead areas of the sinus. Yes, wash. See the sinus now?
Yes.
Imagine the disease earlier when we started in this region.
Yeah, yeah.
Now see.
You can see
Drill,
the
drill,
healthy.
drill. देना यार. इसे भी डालते हैं टेलीस्कोप पे पता है. Be careful to avoid CSF leak. Not to use any pressure on the drill here. Because we are right on the posterior wall, which is relatively thinner.
True.
Wash. Coblator. Now absolutely clear in this region.
Absolutely clear. Very nice.
Oh.
So you will not be covering this area with any flap, you leave it raw?
Pardon?
Will you be covering this area with any flap?
No,
or
no,
will
no,
you-
no, no, no. I want to see, follow it if in case any disease arises, you know.
Okay.
I don't want to cover this. And we have left a lot of raw areas as a drill. Such raw areas in frontal many a times while removing such tumors. And they heal well. Irrigate thoroughly. I am now happy with the frontal.
Yes, very nice.
I told you this is a huge case. कोई इसे क्यों नहीं डालता टेलीस्कोप पे डाल now drill is normal mucosa.
Satish sir, where is that area in MRI which we saw that there was a bony erosion somewhere here?
Pardon?
Yeah, this portion, this part.
Yeah, that other frozen turned out to be hypoplastic epithelium.
Oh, good. So skin one. Skin one or skull base? That.
That can be formed.
Okay, good.
Thank God I stopped.
Half an hour.
And the orbital thing that you had sent for frozen, right? What does it come up?
See these areas. though there is normal epithelium, but I don't want to take a chance. Later.
Superb. Beautiful. Look.
Yes. Now give me a wash. See the complete panoramic view of the frontal sinus. Both sides. See this?
Very nice, sir. Very nice. Absolutely great.
So we have done almost draft 3.
Yeah.
That is the Kirby form. Thankfully saved.
Splendid is the word.
Beautiful.
Yes, yes, yes.
Wash. Wash the diya.
Superb. What a view.
So if finally in any of the things it turns out to be positive, we'll follow with the radiation. That's it.
Yes, 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 yes.
For me it is R0 resection. See this key area.
Yeah, the skin.
The completely skin. I went in the subcutaneous plane, one plane ahead of the tumor, then the orbit everywhere periorbita, and the bone everywhere drilled to normal. See this bone.
Yeah, beautiful, beautiful.
So that was a massive resection.
Very nice.
Thank you.
Very
इसको wash करके बंद करना.
Amazing surgery, sir.
It is one of the best surgeries that we could see. Really awesome.
And this was a huge one. And there was no other option, less than this to give this patient a best result. Though we are waiting for the third one also, frozen. Oh, yes.
Beautiful, beautiful, beautiful.
मजा आ गया.
Oh my God. ये बंद किसने किया?
So in follow-up, you recommend to take the same solution with saline, douching with the powder, etc.
Plain saline. We will apply, before closing. This is the ointment which we apply. This is 5% 5-fluorouracil.
1 second. Okay, fluorouracil. Okay.
5-fluorouracil. Tetwa. Frontal or udhar, orbit. So this will apply. Oh, charger. हटा देना यार का. उधर लगा. इधर लगा. इधर दे.
So Professor Aldo Sam has joined us.
Okay, I think he's,
Good evening. Good evening. So nice to see you. Sir is the one whom I have been following for many years. His work, his books, his publications.
Yeah,
amazing.
My dear friend Satish, it was a fantastic surgery. And I think it was the most critical point was the entrance into the orbit. So this is really difficult. So to manage it. You do some complement after this operation, like radiotherapy, something like this or not? Okay. Yeah. That's fantastic. I think that's true. I think one big advantage of this technique that you show us was exactly the orbital decompression. This is really increases your vision, especially the superior part of the orbit. In the past, it was impossible. Now with your technique, I think it's great, not only for malignancy, but for benign tumor as well. So it's really fantastic. Congratulations. Yeah.
What are the orbital complications you expect in such cases, like diplopia, anything temporary diplopia?
Not really. As long as periorbita is intact, nothing is going to happen. It may be a temporary one, but it is not going to have a permanent impact. Now this next case is a very interesting. Sir, we have now 3 cases left. 2 are the AFRS with vision loss. And this is the one, and with certain amazing findings in this patient. Let me show you first, we saw the AFRS earlier with some huge extension to the frontal sinus with type 4 cell and the fungus beyond. Now look at the frontal sinus of this patient. I told you this is even much more. So, this patient, if you look at the frontal sinus, I'll show you some important findings on the role of MRI. How this patient developed, vision loss. Now, look at the frontal sinuses first of all.
Oh my God, yes.
See where the frontals are going. And all this is huge fungus. See this. This is your lesser wing of the sphenoid. This is your optic nerve. And see how the optic nerve is coming to the orbit here. See this? If I follow it back, this optic nerve, you cannot see so clearly in the CT scan. Let me corroborate the same finding. Let me bring in the MRI of this level in this particular patient with this amazing sequence, 3D spur. Now, what is to be seen? And compare the both side optic nerves, this optic nerve on this side and this optic nerve on this side. First of all, what we have seen here as fungus, I told you in T2 weighted MRI, fungus appears as a signal loss. Now see this much of disease everywhere. And what you see on MRI? Nothing. Can you see?
Yeah.
On T2 weighted, it looks like there is nothing, complete signal loss. What does it mean? A fungus. This much of the disease on CT scan, on T1 imaging, and on T2 completely clear like nothing. This cannot be anything else than fungus, as simple as that. I hope it is clear.
Yes.
Now, at this level, if you see this optic nerve, let's see both the optics now together. First the left one. Left one. See this optic nerve where my cursor is. And at this point, the optic nerve has become bright. That is edema. Edema in the optic nerve is a sign of compression. And that is how this patient developed the vision loss. See this optic nerve completely passing through the center of the disease. Can you see?
Yes.
The optic nerve is completely encircled around by the disease. Can you see? Completely. Yes. And this is how, see, follow this optic nerve and see how the both side optic nerve coming to form the chiasma. Can you see the chiasma?
Yes, yes, beautifully.
Now see retrospectively. Retrospectively, this optic nerve, let me enlarge it to show you. Yes. See, this is forming chiasma. And see the same signal on both sides, normal here. Now see, as you come into the canal, this is the optic nerve in the canal, and see here, it is completely bright. Brightness of the optic nerve on T2 weighted MRI in the optic canal is a sign of edema. Severe optic nerve edema led to vision loss. Amazing finding. Now look at the opposite side. How it is there. This opposite side is not showing any vision loss. See this now? See this now? Now coming in the canal. Now see, there is no brightness. Can you see? Can you see?
Yes, sir.
See this brightness of the optic nerve. This optic nerve. And here at this level, it's completely bright. If you see on these drive sequences, the optic nerve, T2 drive, bright is a sign of optic nerve edema. This is almost completely bright, complete edema of the optic nerve leading to vision loss. Now see, follow this, this is optic nerve. There are many reasons to vision loss in the, in such allergic fungal sinusitis patients. When they expand the sphenoid sinus because of the fungal mass, the bone become, dehiscent, and the surrounding neurovascular structures are compressed. And this is how this optic nerve is compressed here. And the second reason is because of this compression and the inflammation in the surrounding all around fungus leads to neuritis, inflammation in the optic nerve. It may compress the central retinal artery for a complete shutdown, and then it is irreversible. So in most unfortunate patients, the vision doesn't come back. Otherwise, most of the patients, they have a vision, coming back with a good surgery immediately without wasting time, And whenever the patient comes with this problem, the first thing to do is to start methylprednisolone bolus dose and itraconazole in the full doses, 400 milligram a day. And this is what we have been doing this for a day. And see, this optic nerve is completely gone. This is one scene. Now, coming to the, again, to the CT. Coming to the sphenoid sinus in this patient on CT scan. See the sphenoid sinus. There is fungus on the right side more, with complete, signal loss on the right side. Yet patient has a vision loss on the left side. Why the reason? He has a purulent discharge here. This could be purulent discharge. This could be fungus with, low manganese content, showing less, signal loss on this side as compared to the opposite side. It depends upon the magnesium content and the water content, proteinaceous material regarding the signals on the MRI. And this is a classical example. Now, see in the sphenoid sinus of this patient. If I come, see completely expanded. See this is the lesser wing of the sphenoid. See the lesser wing of the sphenoid completely pneumatized. And here the region of the optic nerve, this is the lesion all around the optic nerve. Optic nerve is here. See, this is completely encircling the optic nerve. And these are the patients which require prompt treatment. And see, this patient has a bilateral disease requiring complete, and see this is a cell in the sphenoid sinus. This is the cell in the sphenoid sinus. See this? And this is the disease above. Oh my God, what a finding. This is the optic nerve. This is optic nerve. This is optic nerve. See, follow the optic nerve. See, this is the optic nerve which is intact here.
Yeah.
And see if I follow, this is the optic nerve here, which is completely in the center, in the lake of the disease, in the middle of the lake of the disease. What a finding here. And so, by and large, my treatment for this patient is, see both maxillary sinus has simple secretions, no fungus. Ethmoids full of fungus. This orbital, lamina pepperaceae erosion both sides. With, see this orbital roof erosion. Orbital roof erosion.
Yes, yes.
Every possible thing is there. And see how the disease is going up. Oh, wow. And see, this is all fungus. Right up to the area behind, right up to the terion here, right up to beyond the lateral margin of the orbit. Can you see?
Yes, sir.
The pneumatization has gone beyond the lateral margin of the orbit. What is this? This is supraorbital cell. Why I'm saying this supraorbital cell, not the frontal sinus? Anybody? See the level of the cell. Where is the frontal sinus? Let me take you. This anterior most is the frontal sinus. Can you see?
Yeah.
With no maxillary sinus appearing, just beginning of the maxillary sinus. You see this? This is frontal sinus. Now, as you go behind, see this? As you go behind to the level that the maxillary sinus have gone, you have gone far behind, and see the cribriform plate coming in the place.
Coming in the place, sir.
That is already the cribriform plate started. And see this pneumatization above the orbit and beyond. I have seen this pneumatization in one of the patients having pyocele. This pneumatization was till the preauricular region, the entire zygomatic process pneumatized and full of pus.
Oh, great.
Full of pus, which were drained from here. The zygomatic process till here, from the orbit, supraorbital, till the zygoma completely pneumatized and full of pus. And here see, this is the supraorbital cell pneumatized. Pneumatized to the level you can see here on both sides. Beyond the lateral wall of the orbit you can see. So frontal sinus was anteriorly. This was the, this is frontal sinus. This is the frontal recess. That is the beginning of the cribriform. And this is supraorbital cell. Is that clear?
Yes, sir.
And now this is the entire posterior ethmoidal roof eroded. See this? The dehiscence because of the expansion, and this is all the pneumatization, complete expansion and pneumatization of the lesser wing of the sphenoid. See, if I come anterior, see the bone from roof of the orbit to the roof of the orbit, from terion to terion. This is frontal bone. This makes the roof of the posterior ethmoid. See the posterior ethmoids and see the narrow orbits as we have gone behind. Now if I keep going behind, here, now see the orbit is disappearing. See orbital apex. That roof of the frontal bone, see this? This is disappearing. Now this is sphenoid sinus and the roof is taken over. There is no roof laterally, that is the temporal lobe on both sides. What is this roof? It's the lesser wing of sphenoid. And these are the two endoclinoidal processes, and it is completely pneumatized. I expect complete dehiscence of the surrounding neurovascular structures of the sphenoid in such a situation. Now let me put up the sagittal. See this? Everywhere it remains extradural. Can you see?
Yes.
This is non-invasive fungus. More the sinuses are expanded, more it is non-invasive. The next patient which we'll take after this has a bilateral abducent paralysis. 6-nerve paralysis along with the vision loss on one side. And that is something so interesting. See that patient, let me show you. See this patient. Bilateral 6-nerve palsy.
Yes, sir.
Okay.
Again a young patient, massive fungus on a 6-nerve palsy camera.
Follow karo finger ko.
See this? She's not able to turn her eye laterally on both sides. See this, turning medially, but not laterally at all. Bilateral 6-nerve palsy, our ophthalmologist evaluation, he did the evaluation and has a right side 6/12 vision, not complete loss.
Okay.
So, the presentation of allergic fungal sinusitis are varying depending upon the expansion of the sphenoid sinus. Majority of the bigger complication comes from the sphenoid sinus. See this. See the sphenoid.
Yes, ballooning, but not
completely. And this is how the massive fungal loss, put in kgs you can say, it's all about suction now.
yes, strong.
So I have already asked my colleagues to start the case, and he has done bilateral middle meatal enterostomy that we can skip to demonstrate. And now I'll get on to the real job of the frontal on both sides and the sphenoid. And then we'll move on to the next case. Okay?
One basic question is there from Dr. Riaz Afridi.
Yes.
For single isolated maxillary sinus disease, which approach you prefer, sublevel approach or inferior meatal enterostomy? Because why we prefer?
I don't go by the regular approach. And if you find difficulty, you can take another port from the sublabial to introduce your instrument section, microdebrider, whatever.
Is it to insert the instrument from sublabial approach?
Yes, you can. I will show in one of the case.
That
is
part
a good additional port, you know. So, any questions?
Any role of antifungal postoperatively in non-invasive?
Not at all. Only in two situations, if the disease is so recalcitrant that not responding to the steroids, or the patient where you're difficult to give steroid in doses which is required for long, like diabetics and other systemic conditions. Otherwise, there is no role of steroid, antifungal at all.
Antifungal, yeah.
Pre-operatively, such patient, the moment patient admitted, started itraconazole and methylprednisolone.
Yeah.
Itraconazole is the drug of choice for this. Any other questions? And we are getting ready for the next one.
Like this girl, any history of immunocompromised, or why it is only type 1 hypersensitive reaction only? That's all. Any history of any immunocompromised or anything?
Not really.
None of them
these are immunocompetent individual. Classically immunocompetent, where immune system is so, over responsive to the fungal antigen. This is overreaction by the immune system, which is the end result. Because of that, this disease has happened. This is hyperreactivity of the immune system. These are not immunocompromised. That's why it is classically seen in, young immunocompetent individuals.
Yes.
All three patients are young patients. All three had massive disease. And this on the neck presented with vision loss. This is something significant. All three had proptosis also, which was not significant. Once we had a patient who had a massive disease with a, at our center we did a workshop, and Dr. Vivek Jadhav did that case. Had a complete dehiscence of the sphenoid from all around till posterior fossa, laterally, temporal lobe, everywhere. And had compressed the pituitary to give a complete hypopituitarism. Compressed the optic chiasma to give vision loss. Chiasma, at the level of chiasma to give bilateral vision loss. Such findings can come across, in patients.
And what is the principle of removing the mucocele in sphenoid sinus? Because we should take out all the every part of the wall, or just part of the wall is enough to remove like that to prevent the recurrence.
Mucocele is a different condition. You don't need to remove the wall. You have to marsupialize it.
Udbhav, any questions? Good questions.
Why these patients come in so late?
Because this is painless. And this is absolute carelessness of the patient as well. Because not even pain, they have symptoms of nasal obstruction, symptoms of severe cold in spite of that. And the reason is most of the time, GPs.
Yeah, keep on giving.
10% of the nasal symptom patient come to ENT, you know. In general, I tell you, 10%.
Wow.
90% are going to the GPs.
Wow.
Considering as a common cold, and they have a weapon in name of steroid for every patient. Every time they come, they give antibiotic steroid, and now they have become smart to give antifungal as well, and the patient respond. And all patients are reluctant to, undergo surgery. So they feel happy about it, and they linger on for longer until they develop complications. This is the real story I am telling you.
So sad.
See this is all fungal disease, you know. Are you getting the picture?
Yes, they're getting.
Yes, sir. Yes.
एक और बुला ले. What? देख के करना.
There was a compliment from someone. I think from Afghanistan. Different from Western prepaid knowledge, Indians give free knowledge to everyone. That is excellent.
Oh. Cold section. See this is tons of fungus in this patient. I told you, I already got the maxillary sinuses opened on both sides to save time. Now, the debrider. And see, what is this? Tons of fungus.
Your hydrodebrider will be man of the match today.
Yeah, first of all, my section is good. In case I find problem, anytime hydrodebrider is ready. Will not twice. Later. See this huge pockets.
Yeah.
Yes, sir.
Anupam, कर अंदर मैक्सिलरी खुलवा दे और
कंटिन्यू करवा दो.
स्ट्रेट दे मोटा. See the fungal disease.
Yes, sir.
Yeah.
Now, looking at the scenario of dehiscence of the walls all around in these patients, you know, the best tool to remove the fungus is either the suction or the irrigation, rather than using sharp instrument in those areas, you know. Straight in. Brighter. Fast, man.
Like opening up the pockets in the fungus development.
Yeah, they see most of the bone work is done by the fungus only. You have to just keep yourself oriented and keep going. See my orientation, what I have taken is the lamina papracia
Yes, sir.
and the maxillary sinus. I will show you. This is my middle turbinate on this side. And give me a 40, red 40, to show them lamina. Section. That is lamina papracia.
Yes.
Let me clean it. That's an important reference. Oh. Yeah. See, I have to thoroughly define the lamina, which is going to be the best guide throughout. You have to be careful at the level of lamina as well, superiorly, where it could be dehiscented places. पानी डालना है यार. See some pus pockets inside the. See this?
Yeah.
Everywhere is some or other disease, you know. See, such cases can be done fast only when your assistant keeps irrigating and you keep doing. किलोमीटर से आता है यार. See this?
Yeah.
See what a material. This is maxillary sinus, which I have now completely widened, you know. And this is the wall. That is your orbit. See that medial wall of the orbit?
Yes.
Yeah.
And this is now I am going to remove. Straight. So I have got some good landmarks here on this side to go behind. See this part of the turbinate which I am excising here, which can be obstruction to our irrigation later on. See all this, I have to give a huge cavity. Everything coming in the way has to go. I have to ascertain the sphenoid sinus properly so that I don't get disoriented.
So it is always first the maxillary, then the sphenoid, then you go for the front.
Yeah, I will go later. It's not always.
Okay.
See this disease. What kind of material? Biopsy? Which isko? Send for histopathology. Can you see something? Oh my God. All decent, you know. Can you ask him to bring the navigation? Hello. Just a minute.
Is that Dura?
Yes, let me see what exactly it is. Wait.
Dr. Wasim from Saudi is saying he also gets lots of fungal cases in his area of Saudi Arabia, Malwa.
See this. See what is this?
Fungus.
What you are calling as a dura. My goodness. लगा दो अब लगा दो My God, see what a material it is. Wash point on. That is your optic now.
Yes, sir.
Yes, I have seen. Just a minute. See, this is your optic now above.
Yes.
Can you see?
Yes, sir.
I think that was the cell and the largest cell in the sphenoid sinus that you removed, right? That we saw in the...
I will show you some important finding. The carotid is dehiscent.
Yes.
Let me show you.
I think navigation will be helpful in these cases, right?
Yeah. See, navigation is helpful and a good tool to show as well, but it's not beyond your anatomical knowledge.
Yes, sir.
So true.
But I agree with you. See this. That is your optic now.
Yes, sir.
So inflamed.
Yeah.
Angry. This is your carotid artery. See that?
Yeah.
Dehiscent.
That's the OCR in between.
Yes. Completely dehiscent.
You have to be very careful in using powered instrument there.
Yeah. You have to be. I will show you some more anatomy there. Wash care.
So Dr. Sham Somani is asking, Satish sir, by looking at the mucosa, can you tell what will be the future behavior of the fungus?
Yeah. They respond very well. See, this is one of the most rewarding disease, I tell you, if you counsel the patient properly and follow them properly.
When follow. Otherwise.
Yes, always a long follow-up is required, obviously.
Will you trim out this middle terminate or you will take it out?
See this dura, completely dehiscent dura. Can you see?
Yes.
This is now. Let me clean. I will remove this turbinate.
Yes.
You don't use other than obstructing. Dr. Vidyasagar?
Yeah, I'm there.
How common is the allergic fungus in your region?
Oh, very common. Very common.
Really?
We see a lot.
Yeah, even we see a lot of allergic fungus.
We had also patients with visual loss, optic, but not this extensive. This is the first time I'm saying this extensive. Very common. We see a lot.
I'm removing this turbinate here to give me a good access and for the post-operative access as well. See this turbinate?
Yeah.
It's of no use keeping over here. Cobbleter. सोता बहुत है टेटो बुला यार सोता बहुत है बुला उसको wash yes see now the exposure here in this region.
Very nice.
Yeah. मेरे को देख कर्ड में लगा के दे. Now I will flush every structure in the sphenoid is decent, including the planum and everything is decent.
For the beginners, can you? I mean, not at least in this case. In one of the cases, can you show them which is planum, which is tuberculum, and which is
Here everything is gone, boss.
Yeah, here it is all gone. In one of your next cases.
Yeah. I will.
We had a last webinar pituitary case specifically.
Yeah. There I demonstrated.
Yes.
I rather drill the tuberculum and part of the planum.
Yes, sir. Yes.
No, debrider. See now, this is a good exposure in this region.
Yes.
You have to be careful, like Dr. Vidyasagar mentioned, using the power instrument in those areas.
You're on the optic nerve.
Just for beginners, what they should do instead of using powered instrument, like which all instruments they can use.
Yeah, inside the sphenoid now it is the power instrument not to be used at all in this situation. But the carotid is decent in that region. Here again, wash kar. See this. This is the region of the planum sphenoidal.
Yeah.
Yes.
See the posterior ethmoidal roof here above.
Yeah.
Decent. This is optic now. Carotid artery. Here is the sala. And this is the lateral recess. And every structure is decent.
Can you show the clivus once?
Clivus is here in the center below. Yeah, this is clivus. Decent, completely decent.
Oh.
This was all expected, Nothing unusual. Now what I have done in this patient is the maxillary sinus and the ethmoids and the sphenoid on this side. Frontal is still left behind,
Yeah.
Speck. The same thing I will repeat on the opposite side, and then finally we'll come to the frontal. Section dena. Count section. I have covered the critical areas.
Yeah.
Without any pressure.
The step what you have done already should ease out the optic nerve and vision should be coming back most likely, right?
Yeah, some patient respond so fast.
Yeah.
Even in the post-op period, you will find the vision coming to quite normal. But generally, in majority of the patients, it takes time to come back to normal.
Yeah.
Particularly those patients who present late. See this? All fungus has made its way on its own.
Yes, sir. Yes.
I told you most of the bone work is done by fungus only.
Yes.
And you see, it was appearing absolute signal loss on MRI.
Yeah.
Yes, sir. Yes, sir.
Like there is nothing. My only instrument which is working is the suction. Mota dena.
Over the optic now, can we do something like giving a steroid or any stem cell? What is your take on that?
Steroid?
Yeah.
Steroid is the first therapy.
No, over the optic now, can we wrap up with the gel pump with the steroid?
No, nothing doing. Don't do anything, just leave it open. See the fungus.
Yeah.
Okay, I'll pack it and go to the opposite side and come back later. My concern is sphenoid first. Now this side, only the frontal work is left behind. Okay? Let's go to opposite side. See the fungus. What is that? Let me define my maxillary sinus opening. See the maxillary sinus here?
Yes. Yes.
Now, along with the maxillary sinus, the next thing I intend to see is the lamina papycia. Can you see the lamina coming into picture?
Yes, sir.
That is lamina. That is the second important guide. Through cut. इधर रख. नीचे रखा. Section रख. Section. Everywhere fungal pockets. Straight section, bigger one. Big section. Oh, divider straight. See, this is the power section. Straight divider. See, this is your middle turbinate to reorient. Here's your maxillary sinus here.
Yes.
Yes, sir.
This is your coina here behind. And this is your middle turbinate. No, so now I have to go behind for the frontal sphenoid now.
Yeah.
The important step is to correctly identify the sphenoid here. In particular, this patient, you know, the most important thing.
Everything is basic. That's you.
See this?
Yes, sir. Yes.
Now I am in the sphenoid. Everywhere. See the fungus. राइट फ्रंटल इथमोइड कर दे, पीछे मत जाना, ओनली फ्रंटल इथमोइड है ना, राइट. See, this is fungus.
Yeah.
This is sphenoid sinus, which I have opened widely.
Yes.
No. Now, bigger one. Big section. Wash. See the beauty of the section.
Yes, sir.
Yes.
Yes.
Wow.
Peanut butter sauce.
Yes.
A good suction is essential in the ENT practice.
Very, very important.
Strong and well controlled system. Amazing.
Yes.
Here, well controlled.
So you use only the central section always, or for this kind of cases, or you use the portable one? What is your?
Yes.
Mostly I use the portable ones. Okay. That's a high power. And we have a good central section as well. Okay. So sometimes I use the central section. Even so this central section is very high power.
What is the minimum high power ENT should get in for practice?
Yes. If we invest in the micro debrider,
yeah.
First invest in the section.
So what horsepower or what is the average he should be looking?
Minimum 1 horsepower. Otherwise, if you don't have a good section, your life of the micro debrider will be ruined.
Yes.
The blade will be ruined more frequently, the motor will be affected more frequently.
These liposuction suction machines are also good, right? I mean,
Pardon?
the liposuction suction machines.
Yes, but most of the liposuction machines, you know,
Yeah.
are not durable.
Okay.
I've used even from some of the reputed companies, but you know, they charge a lot in the name of liposuction.
Yeah. But it doesn't work.
Yeah. So get it, you know, from your vendor, tailor-made.
Yeah.
See the optic now on this side.
Optic now. Yeah.
Yes. And see, this is the post-ethmoidal artery. This one.
Yes, sir. Yes.
See optic now and few millimeters anterior to it. This is the carotid which is dehiscent. But here, the optic now is not like opposite side, you know.
Yes.
Niche maar. See, on the opposite side was completely dehiscent and angry looking.
Yes, yes, yes.
Curved se maar. Which is not here on this side. That side, this side vision is preserved. So we are away from the critical area now. You can see. See, we are away from the critical area.
Yes. Oh, yeah.
Our next case is already induced.
What is that one, sir?
Again, blindness.
Okay. So following that is the JNA, right?
Yes. Be careful here at the skull base as you come anteriorly, because it is dehiscent most of the places. That's why these anterior facing blades, see this?
Yeah.
Are always safer. Now I will first define with the red 40 blade. My lateral limit here. See my lamina all the way.
Yeah.
Yes, sir.
Lamina all the way. And now our job left on both sides is the frontal. Probably will not take long. See, right, it's model skull base all the way.
Right.
Till the sphenoid.
You're still with 0 or 30?
So far 0 only.
Oh, wow.
So now I will stop on this side as well. At this side only, now the job left is?
Frontal.
So I will pack on this side and go to the opposite side. Now I will take 70 degree and finish up the frontal. The other case is taken, and I've asked for the maxillary sinus work already on the one side, both sides. That is a unilateral disease, but the sphenoid is bilaterally involved. It's a common cavity. So we'll have a complete exposure of the sphenoid like we have in the pituitary. Wash, wash. Now we have to define the need of the graph if required. Okay? Yes. Curved section. Curved section. Divider. And now, first we'll define the limits on either side. This is lamina on this side.
Yes.
Wash. पीछे देख के कर. Force दूसरी दे. See, I am warning my axis. That is most important before planning to enter in the sphenoid sinus, in the frontal sinus.
Can you orient us once?
Yeah, okay. See, that is the sphenoid sinus behind. Oh,
The optic nerve nicely seen.
वो तो छोटा गॉज. Yes, yes, I will orient you. उड़ देगा. This is something I want to cover. Yeah, see above. That is the frontal sinus. Side giraffe देना. That into the frontal sinus. See that?
Oh yeah.
Debrider. So let me expand the opening. That will give us an idea whether the graph is required or not. Giraffe. Giraffe. I told you it's a huge disease, huge disease.
Because the fungus expands, there is a chance that we might get off without doing a graph, right?
Yeah, that is what I am expecting. But never know the lacunations, you know. Now see, I am in the main cavity. See, after removing all septations, where I am exactly now, anybody? This is supraorbital cell.
Supraorbital cell. Yes, sir.
I told you going far laterally.
Yeah, great, great. Long cave.
I will show you the depth of the cell.
Yeah.
Whenever there is supraorbital cell, your anterethmoidal artery is always immediately caudal to it.
Yes, yes.
Right
Even
there.
a CT scan you can see.
Always pushed behind by this cell. See, just behind it, the anterethmoidal artery. Can you see?
Yes, 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 yes.
Nice.
Yes, sir.
Very nice.
That's a fixed anatomy. Once you find this cell, your anterethmoidal artery is immediately caudal to it. See, once the skull base is more and more pneumatized, these vessels are commonly so dehiscent. See that, the supraorbital cell.
Yeah.
Now see, I will give it a wash and it will completely come out. See this?
Yeah.
Give me, suction. See how big the supraorbital cell is.
Yes, yes, still.
That is the beauty of the suction.
Wow.
Feeling jealous of suction.
See now how big the supraorbital cell is.
Wonderful, sir. Yes.
Flush it. And I will widen the frontal if required by removing the party wall between this and the frontal. Now, anterior to this is frontal sinus.
Yes.
See, this is how you can easily orient yourself.
Yeah. Very nice.
Now, see this again, the man of the match, suction.
Yep.
Pulling it out.
So cheesy a material otherwise is.
Fungal museum.
Give me the bridle and the anteroposterior giraffe. Widen. Slip. Side giraffe, and then debrider. debrider. Turbinate का part है.
Shailesh Pandey from Mumbai wants to know the name of the company who makes the suction for you.
I have a local vendor.
Yes, local made.
Yeah. Companies are not going to make such sections, you know.
Yeah.
I think all these are, you know, who are selling the micro debrider, they themselves should sell this section along with the debrider.
Yeah.
What I believe. Debrider. Now reverse debrider after this.
Do you use warm saline for irrigation?
No, not for this. Not for this.
What are the indications for warm saline use?
I told you last time, like angiofibroma, yes. If you are removing from the sphenoid or some areas, I demonstrated last time the, you know, that olfactory neuroplasm tumors.
Okay.
See, your any pocket, if you leave behind miss, you can leave the suction behind. See now how flush it is.
Yes.
See now?
Yes.
Now give me the suction. Wash it. Wash it. The long suction. See, I will wash it out completely. See now? It is already descended.
For you.
It is already descended. I'm going. Already descended. That's it. Dislodged. Now I'll be through from this side in a minute or so. पीछे आगे
For a high debrider?
High debrider has a different role. Yes. See, this is coming out so easily.
Yeah.
In case doesn't, then I can easily. It is already on my table.
Yes.
See, the fungus is dying to come out. See?
Yeah.
I told you, tons of fungus.
When you send it for histopathology, do you get fungus in these things, or it is only the immune reaction, so you don't see them?
See, fungus has to be proven, you're right.
Yeah.
On the staining.
Yeah.
Number two, this is important to know this information for the immunotherapy later.
Yeah.
Would you recommend immunotherapy in this case? Electron?
Yes, I will. Because this original pathology in this patient is the reaction to the fungus. Allergy to the fungus.
Yeah.
We are so far treating the manifestations, you know.
Yes.
Not the root cause.
So for a classical AFRS patient, what is your post-operative protocol that you follow?
Irrigation. Almost up to 3 weeks in tapering fashion, we give oral steroid.
Okay.
Steroid is the mainstay of treatment. See this?
Yes.
Oral steroid for 3 weeks. And
Yeah,
then
in tapering fashion. In tapering fashion, 7 days like that.
Okay.
And oral topical irrigation after 2 days when you remove the pack.
Okay. And what about antibiotic a week?
No roll.
You give them or you don't even give them?
No, initially you have to give post-operative some broad spectrum, otherwise no roll.
No role. Antihistamine you don't give at all?
Not at all.
And apart from dosing, do you also give nasal spray, steroid nasal spray like fluticasone or mometasone, furavate, anything like that?
Post-operatively, there is no role of nasal sprays.
Yes.
Now we have opened the wire, the sinuses from inside.
Yeah.
Now you want to deliver the steroid inside, how the nasal sprays will reach?
Exactly.
Nasal sprays do not cross beyond the anterior 1/3 of the nasal cavity.
Good insight. Best tool is the best, I think.
Still there is a lot of fungus.
Yes.
Is there a role of douching with steroid?
और वो भी दे.
Steroid wash is the.
Oh, reverse. See, still some funguses,
No. Oh, RT.
And now this is reverse. See how the convolutions have trapped the fungus. Section. This is my, intersinus septum.
Yes.
See the opposite side.
Yeah.
Yes.
नहीं जाएगा.
So what kind of immunotherapy you give post-operatively? Slit or sublingual or subcutaneous?
Any, you can give any.
Your preferred mode?
Slit is more safer because it is not injected.
Yeah.
In India, there is no clear-cut guidelines about the slit.
Okay.
See this?
Yeah, stuffy fungus.
Yeah, huge one coming out.
If that comes out, I think we are done. That's right.
See where it was.
So for how long you give the immunotherapy for? 3 years?
3 years. That's the beauty of the section.
Yes,
Again.
yes.
Find out. Cool. See the fungus where it was. Oh.
Oh boy.
I told you, as compared to the amount of, as compared to the previous patient, the amount of fungus.
So coarse. Still lot of fungus is there.
Sometimes we need to use 2 sections.
Actually, we use 2 suctions with Y connection and 2 portable suction with 1 Y connection. So that also very effective.
Yes. See how it is coming. खोल इसको, flush कर. My God. You keep removing, it keeps coming. वहाँ नहीं पहुँच रहा.
What I think what is yes.
Now give me a wash. So this side is almost done. Section. See now, complete. See how deep the frontal sinus is washed.
Yes, sir.
Yes, yes.
That is the opposite side. You know, here that what you are seeing above. Medially is opposite side. Okay. Now give me 0 degree. Oh. You can imagine how carelessness a patient can have with this much of disease, and unfortunately it is painless.
That is the biggest negative point.
Yeah. Over there. Through biting. Curve through cut. So this is the finesse work being done. to flush the skull base completely. See, just to flush. Better. So this is finally the job done on this side.
There is a question from audience that would you incise the optic nerve?
Not really.
Inside? No,
Not needed. Once it is decompressed, inflammation is taken care of. This will do well. See, this is the final picture.
Very nice.
Okay.
You have a nice cavity now.
And then now the opposite side also only the frontal sinus work is left. Like that. So this is a marathon, you can say.
Yes, yes.
Huge. There's still 2 more
70.
cases left.
Section.
CH blockage.
Put up. See, the next case is not going to take long, I suppose. I don't know. Let us keep the fingers crossed, but
But the active fibroma is a huge one.
if you want, I can telecast. If you don't, I will finish it. I know it has been quite long. Arey dena, save long. Section.
We'd like to see, we have nothing better to do. So.
Now, the same story on this side.
Yeah.
Wash. क्या तो करे?
Like it is nice that you haven't kept stapes together. Otherwise, you would have done 3 or 4 stapes in between.
Covered there. Stapes in our daily list go like that. In between. See, what I'm defining is the beak.
Yes, sir.
See, this is the beak. And this is your sinus. Push kar niche ka section. Now, let me orient you. I have seen the frontal sinus. I will show you the supraorbital recess.
Yes.
Yeah, wash. Second.
The side of the frontal sinus is huge.
The same. Almost same.
But there was no supra orbit recess this side.
No, it is there is smaller one.
Small.
Zero दूसरा देना. See, this is the fungal material. This is my supraorbital recess.
Oh.
Wait. Opening this gateway. See, that is the anterior artery, which is immediately caudal to this supraorbital recess.
Yeah.
Just a minute, रुक जाओ. This is your frontal sinus.
Yeah.
Yes.
Most anteriorly.
Right.
Okay.
Right.
Okay.
And here behind, this here, this is your supraorbital recess. Let me remove the party wall. Stop later there. Here there is a small rent in the anterethmoid. Do you see?
Yeah, very nice.
This is a small rent, you know. That's it.
Just second.
See? So simple.
Yeah. And people were so scared of anterior ethmoidal artery.
Now this is the supraorbital recess. It is going laterally. See this?
Yeah.
Far laterally. And anteriorly the frontal. Let me orient them. See, this is the anterior ethmoidal artery.
Yeah.
Immediately anterior to this is supraorbital recess.
Yes.
And to show the interior of the recess, let me go and rotate. See, this is the interior.
Yes.
Interior. See this?
Yes.
Far laterally.
Very lateral.
So this is how you can differentiate, you know. No, whatever divider. Reverse. Give me the reverse divider. रुक इधर मान लेना रुक I am widening the excess of the supraorbital. Give me reverse. Now, give me the wash. See, this is my supraorbital recess now. पहले suction दे, फिर wash. Now it is wide open. Just a minute to reorient you. This is anterethmoidal artery, and here, this is your supraorbital. Now wash the work. And see what I am going to do now. To go there and
Flush.
see this.
Wow.
So widen the axis and then flush it off. Let me see inside first. Ruk ja. Again, let me see inside the recess. It has completely come out or not. See this? See inside the recess like this with 70 degree.
Yes, good. Beautiful.
Clear?
Absolutely clear.
Beautiful.
Wash the एक बार और. So once it is clear, give one more wash to see the clear, return.
Like Dr. Riyad Afridi from Pakistan is saying that he is happy to watch you till morning. He is so much addicted to your surgeries.
People will kill me otherwise.
So he has been following our webinar since afternoon. He has been regularly asking questions every half an hour.
Yeah, I know. He is. I have no words to express my gratitude.
He is seeing webinar since our first webinar, since first hour. Hello.
I remember he is a very committed person. I met him this year in January in a skull-based workshop in Nepal. Section. See now the huge fungus coming. Debrider. And debrider. This is polyp.
So many people are asking, do we need to do optic nerve decompression in this case to incise the epineurium?
No need of incising the epineurium in infective conditions.
Okay.
To invite inflammation, and this works so well. Once you have taken the source of inflammation and giving your medical treatment, it works like anything. Even without removing this, the moment we started, the patient admitted, the antibiotic steroid, it started responding.
Thanks.
Though we never promised him, because sometimes, see, there are two kinds of vision loss. One is sudden and another is progressive. And sudden vision loss, both the things can happen.
Yes, sir.
Good result with the early intervention. At the same time, it could be, if it is because of retinal vascular shutdown, then you can't do anything. See the fungus, pockets everywhere.
Yes.
Wash there. Now it is a role of wash and wash. Debrider. This is a polyp. 120 देता ना. Wash कर, wash कर.
The 120 that you're using?
Yes. 120. Now I will use 120 to reach inside under vision. See this?
Yeah.
That's the polyp.
Yes,
And behind the polyp is huge fungus. See that?
Yeah.
Still a lot of fungus is there. Sure. Give me giraffe. That's a septation. There. Oh.
You must be tired also.
No, I am fine. Section. Give me section. लंबी वाली थे. Bigger one. Yeah, this is the septation which is, need to be removed.
So again, Dr. Riyaz Afreed is saying God has given us the best gift in form of Dr. Satish Jain. He is encyclopedian in himself.
Oh. No. Section. Now I have loosened this to come out. See the posterior table descent behind.
Yes.
Here, see this.
Yes.
Debrider.
Long forceps for this.
Yeah, it will come out. This is half loose, so doesn't allow the grip,
Yes.
Side. Side giraffe. Side now.
This giraffe coats are from which company? This was or something.
Yeah. Now, see this. Giraffe. Yes. This is from stores. See this fungus behind. Wash.
Yes, yes, wash.
Huge one. See how deep we are. Even the longest instrument may fall short.
Yes.
Because these are beyond the limits of the frontal sinus now.
Extended frontal sinus. Something is there too.
Yes, sir. Some more wash.
Yes.
Still there is some fungus on the wall. Dip right of the neck. Simple 40. लंबा वाला लेके आए जिससे लगा के वॉश करना है. Now, see this. The long suction. Yeah. लंबा लगा बोला ना कॉपर वाला. See this in the wall superiorly.
Yeah.
See that?
These are what, fungus or mucin?
See this coming out.
Fungus.
Yeah. Now it is.
Still more less.
Then keyboard ejaculate. This will open up the gateway.
Dr. Suhas Chaudhary has asked a question. What is the role of mycotoxins?
What is that? What is the role of?
Mycotoxin.
Mycotoxin.
Yes.
I didn't get what is that?
It's nothing like mycotoxin.
So now you see, wash. Give me 1 or 2 good washes. ये लगा के दे. And finally it is done. Let me show you the entire picture from inside after some 1 or 2 good washes, you know. Yes. Once more. See superiorly anywhere. Can you?
Yeah, beautiful. Very nice.
Fantastic.
वो there, ये okay.
Absolutely clear frontal sinus.
हटा हटा.
These are warning cases. If they come in regular follow-up, they feel very better, very good.
Yeah, they respond so fast.
Yes, yes.
Once this much of the inflammatory load has come down, they behave so well. लंबा दे. सीधा.
I think he's asking mitomycin C to prevent adhesions.
Mitomycin, where are the adhesions?
Dr. Alif Alifti.
Yeah, but
He asked mycotoxins he said.
Where can the adhesion develop in this case?
No, I think nowhere because it is full cavity. Mitomycin C.
Mycotoxins, sir.
Actually, on YouTube, the question is mitomycin C. On YouTube, the one working.
Yes. So this is the final picture.
Yeah, beautiful.
And change karo. And finally, we went to the next case, which is already started. And it is some interesting finding which we.
This is of that
the
girl.
patient has a bilateral abductor palsy.
Yeah, that girl which you saw showed the video.
Yes. लगाई नहीं क्या?
Just share the MRI.
Yes. I'll share both CT and MRI.
Yep.
Just a minute. Yes. So this is the MRI of this patient, which I want to share. See this.
Wow.
Huge.
This patient presented with bilateral abductor palsy with vision loss on the right side. Now, look at the findings on T2. T2, see all this dark is what? Fungus. And same thing if you see on T1. You know.
Bright. It will be bright.
Yes. In T1 coronal. T1, see this is hyper intense in the sphenoid.
Yeah.
वो इसमें लगानी थी बस see this was hyper intense on T1 and absolutely signal loss on T2. Now how this patient developed, you know, all these neurological symptoms. Let me show you 3D drive. See this. All this is dark due to fungus. This is my optic now. Can you see here?
Yes.
Following. This is the optic nerve which we are following here. Compress. See this. Compress. This is bright optic nerve on this side. My goodness, she has a massive, massive disease. And see, fungus is never going to enhance on contrast. That is another finding. Hyper on T1, hypo on T2, and non-enhancing at all. With this expansion, this much of expansion of the sphenoid sinus. This is the cause of problem, and this must have induced the inflammation in the
Cavernous, yeah.
yeah, in the
Dorolus canal.
yes, in the abducent nerve, which has given to this kind of problem. My goodness. So this poor girl, side dekh le, side. So basically, we have to go and remove this fungus. What we have been doing for last couple of hours.
I think this it's an isolated fungus, sphenoid, so it should come fast.
Yeah, but sphenoid only, and sphenoid
Yeah,
is
sphenoid.
bilaterally common. And the rest of the other sinuses, let me, show you.
Dr. Satish, I'm sorry I missed the point. I was in a phone call. What was the reason for bilateral abductor palsy, is it?
Inflammation. Inflammation which this, fungus has induced.
Over the vagus or?
Yeah, it can lead to. See this. See the fungal material. See this. Completely, you never know. It can give inflammation in the cavernous sinus region or behind even, because it is right going up to the region of the petrous apex.
Okay.
See this fungus, where it is going. This is petrous apex, and see this is petrous apex, where the, the abducent nerve ascends towards the cavernous sinus. See this, the posterior wall is completely dehiscent. Huge bag of fungus. And it can easily induce inflammation of the cranial nerves. See posteriorly, there is no bony wall. See here. Let me enlarge it and show you. See here. Posteriorly, this is the level of the petrous apex. That is the level of the petrous apex. This is petrous apex. Can you see?
Yes, yes.
That is petrous apex, and see where the fungal disease is. See this hyperdensity, heterogeneous. This is the level of the petrous apex on both sides, and this is the, see the anteroposterior dimension of this sinus, sphenoid sinus. Imagine how big the sphenoid is going to be.
Almost 5 centimeters.
Yes. Let me show you on this picture how big the sphenoid is going to be. This is right from here. 4.5 centimeter.
Yes, yes.
4.5 centimeter sphenoid. See how much it has expanded. Normally, which is 1.7, 1.6 centimeter kind of a sphenoid.
Yes,
and
yes.
this anteroposterior expansion, not the lateral expansion much, which has given problem. Second thing is, if I reconstruct into coronal, see this, the lateral recess on this side. See where the fungus is occupying, the lateral recess.
My God.
Huge. And see the optic nerve here. Must be dehiscent. And see on this side is the onody cell. Right side has a vision loss. On this side. Because this is the onody situation. And see where the fungus is completely, bare the optic nerve. Completely bare the optic nerve. See this?
Yeah.
It is embedded in the fungus on this side. See the difference on this side and this side. This side is completely embedded in the onody cell, which has given rise to vision loss.
Yes.
So we are all set. Can we go ahead?
Yes,
sir.
Yes.
So now I am coming, and the next case is already induced. Final case.
So you give preoperative steroid in these cases?
In these cases, yes.
Yeah.
Steroid and antibiotic.
And
This thing,
post-op
antifungal.
means any for 2 or 3 days post-op also.
So what have you planned? Which nasal cavity you will go through first?
Left side. Predominantly the disease is on the left side.
But
the ethmoid and all.
But blindness is on the right side.
Yeah, let me see again to show you. Predominantly it is on the left side. See this? Disease on the left side, left ethmoids. Can you see?
Yes.
Right side is hardly anything. See from maxillary to the ethmoids, there is nothing. See that?
Yeah.
It is on the left side with all ethmoids involved. Maxillary is just secretions. Ethmoids also just secretions. It is the fungus right in the sphenoid, and this is the floor which has gone.
So you can clear the sphenoid right side on both the sides.
Yeah, I'll make a common approach because my concern is this, I have to go from the opposite side as well to go to the onodi. That is the cause behind this problem, this patient's problem, onodi. Any questions?
No. Just carry on. Whatever the lateral disease, you will expose it like same.
Lateral disease is already, pneumatized on left side.
Yeah, almost already.
Like you saw the lateral disease in the previous case.
Yeah.
We'll open it, flush it.
How are the fungal cases at your site? Dr. As you told, so many cases we have Vidyasagar. Dr. Vidyasagar, you have so many cases of this.
Yes, we do see quite a lot here.
Dr. Samit?
We also see a lot of fungal sinusitis, especially in young individuals. People coming with sinusitis, you do CT scan, find it.
Hello?
Yes, yeah.
Yes. See what has been done. On both sides, on the right side, already this, sphenoethmoidectomy has been done, the maxilloethmoidectomy has been done.
Yes, sir.
Beautiful.
This is for my axis.
Wow, this is already done.
Yeah, this is already, I got it started. I see that is the bulge of the sphenoid.
Yes, about to burst.
Yes. And on this side, already the maxillary sinus done. And what I am going to remove is the middle turbinate.
Yes, middle turbinate.
Quickly, so once we quickly finish this, our last case is, quickly we go and
So angiofibroma is postponed for Miss. We will do tomorrow.
we'll finish up, boss. We are already induced.
Okay.
You tell me whether to telecast or not. Straight.
I'm getting the feedback.
Jain has immense capacity, man. Hats off to you, sir. If we do one such case, we'll go and sleep all day.
See, this is fungus.
Yeah.
40. वो चालू करो. See, these cases I kept on priority because of the vision loss.
Yes.
Yes.
Otherwise, I would go by schedule to do the JNA first. So today the day is dedicated to fungus.
So many fungus.
Fungus and extra sinus involvement of the disease like inverted papilloma. It's all JNA, fungus and papilloma, all extra sinus involvement.
All would be stage 4, if you say.
Stage 4, yeah.
Everything stage 4, stage 4.
Suction कर.
You,
सामान लगवा लो.
the lamina right now.
See, I'm using 0 degree right now.
Yeah.
And removing all this visible portion. What I can do with 0. Look. No, drill. Oh, sorry, there's straight. Quickly, I am going to go behind to reach the sphenoid sinus. See the sphenoid?
Yes, sir. Yes,
Yeah,
sir.
yeah.
Filled with fungus completely.
Section कर लिया कर अंदर. Uncapping the fungus.
Suppose you find any CSF leak at in these such cases, extensive fungal sinusitis or like extensive fungus, what precaution you take while repairing the defect or in post-operative time?
See, once there is a see this inside.
Yeah.
Once there is a CSF leak, it has to be managed like any other CSF leak. See, this bone piece is dangerous here.
Yes.
Because all the structure going to be, descend behind.
Yes, sir.
And any bone piece pushed behind can be dangerous. See now, staying very careful with the debrider as you go behind. See the depth of the sphenoid sinus. Below.
Very huge.
See here behind. Look now, look now. So again, man of the match is section again.
Again, sir. So I think man of the tournament.
This is lateral recess.
Yes.
Code.
I think this is the perfect sphenoid sinus to explain everything.
That is the optic nerve, yes.
Yes.
Yeah, you can see all anatomy in the sphenoid. That is the lateral recess.
So can we reach the opposite side only from this side, or we need to go it from the other side only?
Yeah, let me see. I have not done that. That is lateral recess. This is the fungus. Oh God. What? The depth of the sphenoid there.
Yes, sir, yes.
See the posterior fossa dura. See this depth of the sphenoid. This is posterior fossa dura, clivus.
Yes.
Descent. These are paraclival carotids on both sides.
Yeah.
This is the sella. There. This is your paracellular carotid here. See the descent. See descent.
Yes.
And this is optic now. Ruk ja.
Sir, if by chance some part of fungus is left, can the douching take care of post-op, or we need to re-explore?
You never know if it removes or not.
Okay.
But the inflammation, goes on.
In this, you can show which is the planum and which is the tuberculum.
Yes,
in that situation, you have to take the help of, antifungals and all, and they have their own side effects. So many things.
So the primary surgery is the best chance to
Yeah, that is. I could see the optic now on the other side as well.
Yes, sir.
See that optic now?
Yeah.
Beautifully seen. So we can see the horizontal subtation of the sphenoid, I think, which we were seeing on the CT scan.
Yeah, I will show again. Section there. See ethmoids clear?
Very clear, sir.
Maxillary clear?
So the sphenoid has become just like a pituitary tumor. The amount of sphenoid we open in the tumor already be opened by fungus.
Yeah. I'll come from the opposite side as well, because that opening is important, for post-operative irrigation as well.
Dr. Satish, can you show the planum and the tuberculum once? Just before you go.
Yes. Sure, boss.
The anatomical...
Yeah, khol. Yeah, I will show, boss. I just want to open up the sphenoid opening from this side as well, widen this, so that my irrigation in the post-op goes freely from both sides,
Totally.
I think many of my cases means operated long time back with large sphenoid. They have some, means you can say, recurrent headache, especially in summer season. Could be because of the wide sphenoid opening or something else. They have recurrent headache.
No, that could be headache in many regions, but wide sphenoid opening
Because could be
is
the
never
direct
going to.
air.
No, no, not really. Give me the scissors. Even.
Yeah, Dr. Palaniappan is asking if the patient is diabetic, then what will be your protocol for post-op steroid to the patient?
That's what I said. In those difficult patients, post-op steroid is difficult. You have to give under physicians, guidance under insulin cover. But to minimize it, the focus is more and more on topical steroids.
Topical, yes, sir, yes.
And you may have to give a antifungal as a rescue medication.
Yes, sir.
रुक जाए, देखते हो मत डाला करो. I had a doubt of something behind this septa. Debrider. And I can see the opposite optic nerve as well.
Yes, sir. So please explain the sphenoid anatomy after this, as we have completely explained the sphenoid.
Definitely. Through cut. Through cut.
I think a very important message is never to use ballistically over this horizontal subcation. It's always
Yes.
Never.
See now, this is my optic nerve on this side, this one.
Yes, sir.
And see dehiscent, completely dehiscent.
Yeah. There.
Could you see this?
Yes, sir.
Yes.
This optic nerve is dehiscent, which led to her vision loss. In spite of having massive disease on the left side, the patient developed vision loss on this side. Now this your is completely good. No issues. Now regarding the anatomy, see this straight there.
The Dorillos area, canal
Straight
area.
section. Pardon?
The Dorillos canal area.
Yeah, I will show you what is Dorillos canal exactly. You can't see from here, but I will tell you.
No.
Divider for a while. Just a minute. Yes. Wide sphenoid, which can be irrigated from both sides now.
Yeah.
See how fast this could be done.
Yeah.
Now, first of all, the anatomy inside. Wash it.
So today has been like a mini rhinocon. We have all the rhinology cases.
Full rhinocon.
Now see, this is your sella.
Yeah.
Both sides are the paracellular carotid with the left side being dehiscent. See the dehiscent.
Yes.
Yes, sir.
This is sella and this is not dehiscent. Now, above the carotids is the opticocarotid recess. Can you see there?
Yes.
Yes, sir. We can see. Yes, sir.
This is optocarotid recess and this is the optic nerve. Again dehiscent on this side as well.
Yes, sir.
Both sides dehiscent. See that? And about cella, this thick bone is the tuberculum which is thinned out here. And this is the planum sphenoidal above. And see, yeah, that's what I'm saying. This is planum. And this planum extends anteriorly up to the posterior ethmoidal artery. The anterior limit of the planum is the posterior ethmoidal artery, which is roughly, you can say, this is optic now 5 to 6 millimeter anterior to it. Yes, until sir. There is the planum and anterior to that is the cribriform. Okay? In between this, section the cord, lumbar cord. This is the clival recess in between. On both sides are the paraclival carotid arteries. This is clival recess.
Yes, sir.
Yes, yes.
Behind this dura, the first structure is the basilar artery.
Yeah.
See the dural pulsation.
Yes,
yes, yes.
And this is your lateral recess. Give me a wash. The huge lateral recess. See this lateral recess?
Yeah.
Now,
Yes, sir.
can you
Yes,
see
sir.
some nerve in the lateral recess? There, laterally?
B2.
This
Yes,
is
sir.
V2.
Yes, sir.
This is V2. Yes, this is V2.
From Gautam.
And see this paraclival carotid artery. Now, about the abducent nerve, Dorello's canal. See, behind this is the basilar artery.
Yes.
Yes, sir.
And behind that is the brainstem.
Yeah.
Below this vesicle is formed by the vertebral arteries, below, two vertebral arteries.
Yes.
At the level of the vertebro-basilar junction, on both sides of the brainstem, the abducent nerve arises below, at the VB junction. And
Yes,
both
sir.
nerves go up towards the posterior wall of the cavernous sinus. This is going to be cavernous sinus here, towards the posterior wall of cavernous sinus here, in the posterior canal fossa. So before the cavernous sinus, this nerve runs through a venous lake. That lake is formed by, joining of various venous sinuses, inferior petrosal sinus, basilar sinus behind. All these sinuses form a venous lake through which this nerve passes. And that part of the nerve passing through the venous lake ultimately passes underneath the petrolingual ligament to enter the cavernous sinus behind. And that forms a sort of canal. It is not a true canal, but it was initially described long back by Dorello. It is known as Dorello's canal. Okay? And
Yes,
that
sir.
area is behind this. See, this is the carotid.
Yes.
See this behind this carotid here. Very close to behind the carotid is the abducent nerve. Behind this. Okay? And behind and below here, the carotid, here is the petrous apex.
Yes, sir.
This is one of the approach to the petrous apex. Sometimes you may have to mobilize the carotid artery in order to get access to it. So this is all about this case, and I hope recovery in all the three cases today with the post-operative steroids, some antibiotic going on, and of course in complication cases we are going to give itraconazole for few days, only in the vision loss situations, otherwise no need.
And finally, it shows that the sixth nerve palsy is because of the compression, expansion of the clivus and nerve getting compressed.
Pardon, can you repeat the question, boss?
What is the exact etiology of the sixth nerve palsy? It is the compression on the nerve because of the expansion of clivus, or?
Boss, sorry.
No, it's okay. The main cause of this sixth nerve palsy, what do you think? It is because of
inflammation. Inflammation going on in the surrounding, which has involved the nerve. That is the only reason.
Because Amit Kesi is asking, it could be because of expansion of the clivus and nerve getting compressed. That could.
Yeah, could be. In any compression and inflammation, these are the two reasons. There is no
Dr.
third
Shiva
region.
has re-clarified that
अजय क्या बोल रहे हैं?
the aflatoxins,
किसका? इधर आया क्या? ढंग से बोलना मेरे.
toxin and so many other toxins that can
See,
cause.
there is a good news. The previous patient which I operated just extubated few minutes back, and he's saying he can see now.
Wow!
Well, his vision has improved.
Wonderful.
Sometimes response immediately, you know.
Yeah, but even in this case, we'll also say same thing. You will get the same information after maybe tomorrow.
I hope so. I will update you definitely.
Yeah.
The best Independence Day gift the girl can get.
Yeah.
And Mr. One more question from Dr. Mohammad Radwan. This sphenoid is so deep, like it will work like a sump and big. So any problem later on because selection in that?
Nothing. It is so mucosalized, and it ultimately mucosalizes well, and it remains good. It doesn't bother much. Now see this next patient, another interesting story. This patient, you know, is a young, how old? 16-year-old. 16-year-old child with this kind of a picture. See, so variegated pictures, sometimes difficult to diagnose JNA. These are atypical presentations, you know. And see, even in the sinuses, see this tumor is right arching into the sinus.
Yeah,
yes, sir. Sinus is full of the tumor.
See, the tumor is full of sinus. Only this part of the sinus, most anteriorly, is having secretions. Rest of the sinus is full of tumor. The tumor has gone through the posterior wall right anteriorly into the maxillary sinus. See, so unusual. Yes. Imagine one of the cases I demonstrated previously had a huge, you know, maxillary sinus extension, which bothers you in finding the vessel.
Exactly. That's the same question I'm about to ask you.
Yeah. See, this is the extension in the sinus. This is lateral. This is behind the parapharyngeal. Can you see here?
Yes, sir.
This is nasopharynx. This is towards the opposite side from behind through the nasopharynx. And then as you go up, this is the hemorrhage into the tumor. And these are the carotid artery. This is the sphenoid sinus. And let me show you in the cornel. See now, first of all, right at the beginning of this is the tumor in the nose. No space.
Exactly.
Which Dr. Vidyasagar was asking in the beginning. So we will compress it, decongest it, you know, push it behind. And as you go behind, now see, as you go behind into the maxillary sinus, see maxillary sinus appearing, and immediately after that is the tumor. See this? On this side is the maxillary sinus. This is hardly any maxillary sinus. Only this part of the maxillary sinus you can see pushed antero-inferiorly. Can you see?
Yes, sir.
Rest of the tumor is coming from here. See this huge component of the tumor. This is the outline of the maxillary sinus.
Yeah.
This is the outline of the maxillary sinus, and this is the tumor. So we have to go posterolateral to it, catch the vessel.
Exactly.
Yes, sir. Yes.
Now, as you go up, see this tumor component which is coming from the nasopharynx to the opposite side of the nose. See this? So anteriorly in the opposite side of the nose.
Yes, sir.
See this huge tumor component in the nasal cavity. All the way, everywhere in the nose is the tumor. And then in the sphenoid sinus, see, it has a huge hemorrhagic component.
Yes,
and as you go behind, this is a large cavernous sinus component. See, this, let me show you, yes, this component at this level. See bar at this level on the axial. This is the cavernous carotid, and this is the tumor in the cavernous sinus. Can you see this?
Yeah. Is it the superior orbital fissure also?
Yes, sir, I think superior orbital fissure is also.
Superior orbital fissure.
Yes, yes.
And there is a huge component in the cavernous sinus. See, this is how this.
The temporal lobe also on the right side.
Now it is pushing.
Pushing. Okay.
See, this is the wall. Outline of the cavernous sinus lateral wall. It is pushing, not invading the temporal lobe at all.
Sir,
Now, yes, please.
Sir, CT angio, can you show the maxillary artery supply?
Yes. Now we have a MR angiogram. See this.
Okay.
Very interesting story of this patient. See, this is MR angiogram in the neck. This is the trachea.
Yes.
That's the carotid artery. Behind is the vertebral. As you go up, it divides into two, the internal and external.
Yes.
This is external going behind the mandible, see?
Yes.
And here it is leading to this internal maxillary, okay?
Yes.
And one more vessel it is leading here.
Yes.
This is directly entering into the tumor. See here. Oh my goodness.
Into the tumor.
Look.
Another thing, this is internal carotid. And there are two small vessels from the internal carotid directly entering into the tumor.
Yes.
Imagine how this tumor is going to behave.
Yeah.
Already too much of the component anteriorly, too much of vascularity. Maxillary I am going to take into control, but what about the two? This is internal carotid that even cannot be embolized.
Yes,
the only issue is this vessel entering here. That we have to, take care of. Okay?
Yes, sir.
And hopefully with your cobbletter, we'll be able to get rid of that. Now, coming to the classical CT angiogram.
Dr. Satish, I know you have answered this first itself, but I just want to ask you, why is that when we have a big tongue bleeding and all, we just ligate the lingual artery and it stops? So why in these cases where they are not endarteries, by taking a control externally, we will not be able to have the control on the vasculature? Is it because of the collateral supply, or is it?
Yes, it is not end artery.
Yeah.
See now with this much of the tumor component on the CT angiogram, see now.
Yes.
See from the nasopharynx, it is ascending to the opposite nose to this level.
Yes,
Can you
sir.
see?
Yeah.
Half of the opposite nose, and see here, it is going right up to anteriorly. Though after this angiogram, we have started, already we had started the antibiotics and steroids, and they do work to reduce the inflammation. And secondly, this tumor, let me show you, this is maxillary sinus. Let me change the intensity. Can you see this tumor is going right like this here?
Yeah.
Only this part of the maxillary sinus is cavity.
Yes, sir.
And this is the biggest obstacle. Now, secondly, my vessel. See this vessel ascending? See this vessel?
Yeah.
This is the vessel. This is the vessel. See this vessel? See this vessel? Going to the anterior part of the tumor.
Yes.
But quite high up. Quite high up. That is what I wanted to show you. It is difficult to find kind of a vessel. Let me show you why I am saying difficult to find. See this vessel? This vessel is here. See that?
Yeah.
And if I see the level of this vessel, see this.
Oh,
In the coronal. In the coronal. Now imagine. Oh.
Yeah, it is there. It is there.
See this vessel. This vessel is there. Now see the level of the palate.
Yes,
This
sir.
is so high up. So high up. See the level of the maxillary sinus so behind. See that?
Yes, sir.
How
Yes,
the
sir.
vessel is entering into the tumor. See this? See this? So high up and so posteriorly. See this?
Yes.
This is the tumor outline in the sinus, and this vessel is ascending just at this level, immediately behind this. Can you see here?
Yes, sir.
So that is a challenging situation again. So there are so many challenges in this patient. Number one, the anterior extension. Number two, the maxillary sinus extension. Number three, the immense vascularity from here and there. And number four is atypical presentation. Even the tumor is coming to the opposite nose. We have to go behind to the opposite nose, and this will pose a problem over there.
Yes, sir.
And then this amazing extension, and then let me show you where is the cavernous sinus tumor.
So the take-home message is for beginners, do not try this. So for beginners, they should not attempt this.
Why? That beginners should
If you understand the concept, it is a matter. That's why we are showing variety of situation. That how to deal with different situations. Angiofibroma is n number of varieties, posing different problems. See this vessel carotid artery, and this tumor is staying anterior to it. This is the tumor anterior. This is supraorbital fissure, and this is cavernous sinus. You have seen so many times now. Okay, and this is the sphenoid component, which is a big hemorrhagic part, which is not enhancing.
Is it going lateral to the optic nerve?
Lateral to the?
Is the tumor going lateral to the optic nerve?
Not really. Why so? See this. Let me show you. Let me show you. Optic nerve is a different anatomy above. See this optic nerve is there.
Yes.
Optic nerve is there. This tumor is in the sphenoid below. And see this huge ball. Huge ball occupying the nasopharynx. And this is eroding the floor of the sphenoid to enter into the sphenoid.
Right, sir.
See this? This is the hemorrhagic part in the sphenoid. So I need to have a bilateral access of the sphenoid completely. I need to remove the rostrum completely. And this part of the pterygoid process, I need to drill here completely. And see, this is in the pterygoid fossa.
Yes, sir.
That is the pterygoid process, and this is in the pterygoid fossa below. Can you see?
Yes.
And if you see the axial, see all these things to be seen thoroughly, otherwise you can leave the tumor behind.
So you think we will be able to do only with the endoscopy, or maxillary swing would be a better option?
Yeah, endoscopy was. Why maxillary swing? See, this is the tumor, this is the pterygoid plates, and this is the tumor going in the parapharyngeal space behind. That is the tumor. I can show you on the good MRI also with good contrast enhancement.
And this is going almost everywhere.
Yes. See this. This is the parapharyngeal component.
Yeah.
So it is everywhere. You see the pterygoid fossa. See this. This is the greater wing of the sphenoid, completely, involved with the tumor, and this is the tumor which is going laterally. This one, far laterally, and the vessel going far lateral to it. And this is the tumor. This is the pterygoid process, which has to be completely destroyed.
Yes, sir.
I need to almost remove the existence of the pterygoid in this particular case. And this is the component going in the cavernous sinus. I hope now you have got a full idea about it. And this is the ball in the nasopharynx.
Already getting palpitations.
Sir, covering 270-degree carotid artery also all around.
Not really. The carotid is behind. See, in the anterior posterior. See, this is anterior. Now I am going posterior.
Yes.
Posterior. This is the upper paracellular carotid.
Yes, sir.
And if I go behind, this is paraclival carotid.
Yes.
Okay. So it's behind. See this. Let me show you your concern in the sagittal. See, this carotid is behind.
Okay,
And
sir.
tumor is there in the cavernous sinus, pushed right up to the carotid.
Yes. And diffusion weighted image.
See this, how it is coming. Diffusion, there is no restriction. This is full of water.
Okay.
You see this diffusion. See this, no restriction at all.
Yes.
If this is dark, then it is malignant. Many a times we have, diagnosed such cases referred to us with JNA on diffusion with restriction turned out to be malignant.
Malignant.
So with these two JNAs, two different varieties today, with different extension, different tumor characteristics.
So we have saved the best for the last.
And this is real challenging case, believe me.
Sir, I hope people are.
We have not embolized at all.
Yes.
And we have to do a lot of things.
People are there.
This tumor will pose a lot of problems.
Getting so many, I've got so many messages of personal. Please don't stop, continue.
So many people who must be feeling sleepy must have been woken up after seeing this. Everywhere they must be now completely focused. It's like a thriller movie. About to...
But I think we should appreciate Satish. We should appreciate Dr. Vidyasagar and Dr. Samit. They are
sir.
Doing very well this study.
We are just sitting and watching.
The interaction with them is something mind-blowing.
Yeah, ultimate. It was
we are just watching
Thank you, boss. Thank you.
So Vidyasagar sir has made my life so easy. He has almost covered so many things by himself. Like my half of the job has been taken by Vidyasagar sir.
Oh,
Come on. Sir, you are serving the meal. We are just eating it.
A nice Sunday evening.
Yes.
What better to do?
Maybe play morning, early morning.
Oh yeah.
So we all set now.
Yes.
We have navigation installed, everything.
I saw first endoscopic angiofibroma almost 20 years back, done by Madam Renka Bradu. Do you remember, Satish?
Even
the
I
first,
have been doing it.
at that time we were in Mumbai, so we saw it. That was first endoscopic angiofibroma.
Rajesh sir, when you did your first endoscopic angiofibroma?
6 years back, 7 years back.
Okay.
6-7 years back. But not, you can say it was a combined. Initially with finger, then after I just checked with the endoscopic. But you can say 4-5 years back. 4-5 years. It was a wonderful experience. Now we can, after in 2 months, we can see we can do more extensive angiofibroma now after seeing all these things, after discussing all these things.
Totally true.
A lot of fear goes away by seeing Dr. Satish operate. He explains it so nicely.
Yeah.
You think you can do it.
Yeah. Are you getting the picture?
Yeah, beautiful.
Yes, sir, we are getting.
And now, can you show the navigation picture monitor? See that? Can you change to the navigation monitor? Can you see now the navigation monitor? And see, this is fusion, both CT and MRI together.
Yeah, beautiful.
Wow.
We can see.
Can you see?
Wow, that is great.
That is the beauty of this electronic system. This system is truly mesmerizing. Believe me, in our most difficult situation, this is like a warrior.
Yeah, true. Very true, sir.
Particularly in deeper tumors, we use.
So is there any situation which is difficult for you?
Pardon?
I'm asking, is there any situation which is difficult for you?
Oh, boss, we have to face challenges always. Now, can you put the endoscopic picture? Now, see the first challenge.
Yes.
surface coagulation.
Are you getting picture?
Yeah.
Yeah,
This
we're getting,
is
we're getting.
after, antibiotics and steroids. See that? This is the tumor which is coming far anteriorly. Can you see?
Yes.
Yes, sir.
Yes, sir.
This is challenge number 1, and what I am going to do, which will definitely help us, surface coagulation,
Yes, sir.
This will
Carpet
help
coagulation.
shrinking the tumor. See this. This will truly help us shrinking the tumor. See the vascularity behind. How angry the tumor is. See behind.
Yes, yes,
Yes,
yes.
sir.
I told you the huge tumor component in the nasal cavity. What I'm getting is more and more surface coagulation till wherever I can reach. To allow this tumor to shrink,
Yes,
Yes,
sir.
yes.
See, maximum possible surface decongestion to allow this to shrink. दवा की रखना। See, from here this tumor probably has gone in the maxillary sinus. I don't know. See, all this is tumor. See, multilobulated.
Huge. Massive.
See how much I have pushed it behind.
Yes, sir.
See this much.
Now we have some space.
Yes, some space at least we have gained. See, wherever I can, just keep coagulating on the surface to devascularize, to allow it to shrink. Now, give me. See now, lot of space is opened up.
Yes, sir.
At least some space to work.
You can actually see the inferior turbinate now.
Okay?
Yeah.
Yes.
Now this is your lateral wall. And the same story is within the maxillary sinus as well. Wherein, the tumor is coming far anteriorly. So the first problem we have overcome to certain extent. This is inferior turbinate. Inferior meatus, lateral nasal wall, and this coming right up to the pyriform aperture. See, that is pyriform aperture. This is now ablation.
See the orange light completely.
Oh, really? The last patient extubated, and according to her, her vision has improved.
Wow.
Wow,
Okay.
sir.
So
So
this
really-
was compression, simple compression. See, like what we did earlier.
Yes, sir.
Yeah, have you ever need to, has it ever happened to you that you need to convert an endoscopic case into a signal approach while operating endoscopically?
Not really, but many a times we do open approach
Okay.
for the indications. But what I say, all endoscopic surgeons who are doing JNA or intend to do must be well versed with open approach as well.
Yes, sir.
And certain open approaches, I tell you, are, amazing, versatile, like maxillary swing you mentioned.
Yes, sir.
Another is a left foot one osteotomy. It's again a very good approach.
And sir, lateral rhinotomy.
Lateral rhinotomy, these days, why to do? Everyone is able to do that much of endoscopic work requiring a lateral rhinotomy. But yes, lateral rhinotomy everybody should know for many indications. And the third is mid-facial degloving.
Yes, sir.
That is useful for not only this but many other indications as well. See, this is what I opened is the inferior meatus,
Yes, sir. Yeah.
And now I will leave a pack over here. Okay?
Yes, sir.
Now the next goal is to go to the anterolateral wall. No, take the deck. Take the deck. That is coming from little bit from the bone. Don't have to fiddle too much. Just pack for a while. and get on to the other areas. Now, see, this is the anterolateral wall.
Yes, sir.
Corblator. Yes. Now, this is subperiosteally.
Yes.
सिर पकड़ना. Yes. Lux. See the bone, difference in the bone in the previous patient and this one.
Yes,
Yeah,
sir.
it's very.
Previous had a very thick bone, you know.
Yes.
Quite thick.
Corblator. हटा, छोड़ दे. And this wall, you know, the anterior wall mucoperiosteum, I always make sure to coagulate this. You know, this takes care of the oozing as well as this stiffens the wall to prevent falling in between with the section.
Okay. So this is coagulation, not
Yeah. So that stiffens. Now, I will use the drill to make an opening, and we all know there is hardly, any area. Immediately behind is the tumor. Question?
Beauty of this well is that only tip move. That's the plus point.
Yes.
The rod doesn't move.
This is amazing. The best part, what I like, the shaft doesn't come in the way.
Yes.
And it is so easy to hold like a pencil.
Yeah. Same word we are searching for cochleostomy. And only tip move.
करते रहना. See, this is my entry to the maxillary sinus. I'm staying to the wall because I'm not going deeper as I may come across the tumor. करना सेक्शन नहीं कर रहे तो. See, I'm thinned out this wall so I can wash more, section more. See, now I have removed the bone anterior to the lacrimal sac. That is my lacrimal sac. See that?
Yes, sir.
What I did, I thinned out this bone and removed easily with the lux. I have not seen inside the maxillary sinus yet. I am in the process of removal of maximum bone. Now you see in the sinus, what is there? This is tumor. See that?
Yes.
This is challenge number 2.
Yes, sir.
How to deal with so much of the tumor occupying the maxillary sinus.
Exactly, but almost the same thing that I had faced on that day. So true. Very hard and difficult.
See, surface coagulation.
Exactly.
Yeah, beautiful, beautiful.
See, acquiring some space. Acquire some space.
Yeah.
As I told you, we have to go behind.
No.
For the vessels.
See that?
Yes, sir.
This is challenge number 2. Pack the इधर. तो बड़ा नहीं. See this? To compress this tumor a little bit.
Yes, sir.
From the wall. Okay?
Yeah.
Now, this is my nasolacrimal duct, and that is the tumor lateral to it. See this? As we always do, we have to do something to the nasolacrimal duct. Drill the bell.
Flashing it with the floor.
Yes. Now, Udbhav, you remember all steps.
Yes, yes, sir.
Udbhav is the expert now.
That is so good to know.
Bone are broken.
Oh, give me the kerosene. See the level of the roof.
Yeah, almost.
No, but here this duct has to be opened further.
Kerosene is still poor man's birth.
Pardon?
Kerosene is good for us, maybe like poor man's birth.
Because kerosene is such a useful tool.
It is one of the best, I think, one of the best instrument for
Yes,
I think.
yes, sir.
See this bone coming from all around.
Yes.
Drill lega. See, I have to flush with the floor.
Yes, sir.
Yes, sir.
See this? Drill देना. यहाँ तक. क्या कर रहा है? Yeah. Now I can cut this duct, you know.
Yes, sir.
And see then both parts of the tumor across the duct.
Yeah.
See this tumor?
Yes, sir.
The brighter. Straight. See, my both components of the tumor are in view now. This is part of the uncinate process to free the tumor. See the nasolacrimal duct above.
Yes, sir. Beautiful.
Sir, if we do posterior septectomy on the opposite side, can we get more space, sir?
Pardon?
If we do posterior septectomy on the other side, can we get space?
Pardon? I didn't get your point.
Sir, posterior septectomy, septectomy if we do now, can we get more space? Can we push this tumor on
Not
that
really,
side?
not really. No. See this terminate here.
Yes.
You know, holding lot of space here.
Yeah.
I'm getting rid of the terminate as well.
Yes, sir.
Early in the course, you know. See now the tumor components in front of me.
Superior extension.
See the multiple lobulations of the tumor are in view now.
Yes, yes.
You've got a good view superiorly.
I have not taken the vessel into control yet. I have not taken the vessel into control yet. Since it is a large, you know, nasal component, I have to manage it as well.
So true.
See this whole tumor getting exposed. See now?
Yes, very nice.
Yeah, beautifully seen.
Very
going little faster. Don't mind.
Not at all.
Usually it will be attached to the inferior part of the middle turbinate. Here, luckily it is not, right?
Yeah, it is. The inferior part of the middle turbinate is still inside.
Oh, okay.
I cut the middle turbinate and separated the upper part.
Yes.
See now, this much of the tumor is in exposure now.
Very nice, Doc.
Why I expose at this point of time, debrider, so that I can do a surface coagulation.
Yeah.
More and more.
Shrinkage and...
Yeah, see here, I can see the lamina preparatia now. See the lamina preparatia?
Very nice, very nice.
That is lamina. See this?
Yes.
See, all component what you see inside is tumor and tumor. What you see inside, everything is all tumor. See this?
Yes.
And see there behind in the sphenoid, see that dura dehiscent. We saw at one place the dura was dehiscent.
Yeah.
Yes, sir.
See the superior aspect of the tumor all the way. And now, why I export this at this point of time so that I can do a surface decongestion. See this, how the tumor behaves so well after that.
This is the longest webinar we had and still going on till now.
Oh, I'm sorry for,
No, sir. This is,
keeping you awake.
no, sir, this is a treat for us. Everyone is glued to their screen.
See, more and more surface decongestion,
Yes, sir, yes.
Watch. Now the field is much better. And here I will, coagulate the nasal septum also or its attachment, to devascularize this attachment.
Yes, sir.
Because this acquires a lot of blood supply many a time. Now this is the tumor in the sphenoid sinus. And that is the dura behind. Now here I will pack from there. See, right from the anterior part till the end of the nasal cavity, sphenoid sinus, everywhere is this bloody tumor. See this?
Yes, sir.
See, so many lobulations of this tumor. It cannot come out in one piece, for sure. See, such a huge component.
So huge.
Now, एक और देना पीछे, सेक्शन करो उसके पीछे सेक्शन करो उस पे, और दबा दो। बस। Now this part of the tumor do not debrider. Now I have to go lateral to the tumor,
Find the best way.
I have to do multiple, divisions of this tumor to get out the huge one. अरे यार काटता नहीं अंदर घुस गया उसमें देख कॉबलेटर दे see inadvertently it touched the tumor here which I never want at this stage. Anyway, give me the see now going lateral to the tumor.
Yes, sir.
Debrider 40. That is your infraorbital nerve. See this?
Nice clear. Seen very nicely.
Yeah. And see where the tumor.
So because you have achieved that much of space there, and because the vessel is going to be much lateral, I think with the space you would be able to catch that vessel, right?
Yes. See now, at this point of time. Yeah.
वो बक्सू का has a fat.
ये नीचे दिखे बस देखो.
Is that the infraorbital pad of fat?
No, buccal.
I mean, buccal.
I am in the posterior wall, you know, pterygopalatine fossa.
Okay.
Infratemporal fossa rather.
Oh, okay.
I am far laterally, you know. And what here I intend to see.
The fat indicates lateral limb.
Is the vessel entering the tumor, you know. I will tease out this fat. Give me the rider. Give me the.
I saw something like a big strand there. Was that the vessel?
Pardon?
Behind the fat, I saw something like a big strand.
I will see. Let me reduce some fat. Wash her. Let me reduce some fat here. See how I have entered behind. By means of devascularizing the tumor more and more and pushing it, you know, on this side, entered the area of interest. Keep teasing out the fat, you know.
Yes, sir.
Slowly.
The problem is so much of fat will be coming if you start to pull, right?
Yeah. Yeah. No. See, that is your nerve above. That is the nerve going. See that now?
Yes.
Yes, sir. You can see.
So my vessel, you're reflecting that.
Yeah.
That's the one of the vessel. Can you see?
Yes. Very clearly seen.
Can it be coagulated like the last case?
Yes.
It looked like 3 millimeter or in that range.
Yeah, it is not so big here. I can see, I can coagulate and see the vessel and the tumor.
This is the main vessel.
Yeah, that vessel one I have coagulated. That is another vessel. See that? That is the vessel here.
That looks bigger.
Again, I will not catch here, just coagulate.
Okay.
Detector. And this is the main artery, you know?
Yes, sir.
This one, which I again coagulated. See that?
Yes.
This will help me devascularizing the lesion to certain extent. Okay?
Yes, sir.
See, only one tool working all the time. See this. This vessel I have cobbleted.
Yeah.
Okay?
Yeah, very nice.
Okay, give me a back.
Nice.
Now. कर दे इसको आगे वाले को you know I'll have to take a chance now quick, to debulk this tumor a little bit. Let's see how it behaves.
I was about to ask that question. Even though you have only taken control of the main branch, there is one other big branch that is supplying backwards.
Yes.
So, will there be a chance to bleed?
Yes, so it is not a complete devascularization, you can say.
Yeah.
And this patient, I told you, that is another challenge to see the other branches coming to the tumor. Remember I had shown on CT angiogram, MR angiogram.
Two branches from internal.
See, this is the tumor.
Yes, sir.
And this is the nerve.
The nerve, right? Yeah.
Very good. All good?
Yes.
Now, take this. Now I will pack from there and try to devascularize, try to start dividing some part of the tumor in spite of I may face some bleeding, because this tumor right from here till end is a huge component.
Yes.
I cannot deliver it as a whole. So what I will, at least the anterior part, that will help me both ways. It will reduce the tumor and it will give me access to go behind. Isko pakad. See this? I intend to remove this part a little bit, you know. This is generally we don't recommend to enter into the tumor. But having done this much of the work, I can take a chance. I told you, this is I am taking a chance. With too much of the bleeding, I may have to, rethink. Now see, this will, you'll rarely see how I am dividing the tumor. See what I am doing? At the beginning only. Without having this much of control, this will not allow.
Yes, sir. Cutting like butter.
Yes. Sandeep, awake.
Yes, sir. Always.
दिखाना किधर?
Deep is there since the starting.
काट इसको. प्लग करें. See, this big component of the tumor has come out. Wash.
Yes.
Give us some additional space. Now the issue is the space.
Not very much.
Yes, sir.
Yeah. We'll do multiple debulkings. Wash. You know. See, hardly anything.
Yes, sir.
Yes.
Very nice. So if the good scenario has come into a play, so if by chance there was bleeding, what you would do? What would be your alternative strategy?
The first alternative strategy for this patient, looking at all this planning, I have kept 1 extra unit of blood for this patient. Number 1. Because expecting a little more bleeding, is a part of the approach, number 1. Now, during this, division, had I been facing extra bleeding, I would go behind and take the vessels more liberally.
With the endoscopy or with the...
Imagine this scenario, Dr. Vidyasagar. If somebody tries to divide this without taking the vessel into control, what the havoc it may give.
Yes, sir.
Yeah, that's it.
Now my question is like, if you wanted to take additional control over the vessel, what would be your approach? Again, endoscopy alone or open approach? For
No, endoscopically. Obviously, endoscopically. What color is that? Now, this part of the tumor, I want to take more.
Yeah.
See how big the tumor is.
Yes, sir.
I had to segmentalize it again and again. इतना बड़ा नहीं, छोटा कर. Only this part. This part. See, little bit I will more segmentalize.
Okay.
To get more access, I will not take a larger part because it may, I don't know, it may bleed. Why to take a chance?
Okay.
That to a patient which has an unpredictable blood supply as well. Slowly. My aim is to acquire space. If I acquire space here anteriorly, I will go behind, take a posterior-medial exposure, which I have not taken yet, to the opposite side. See, all this was a big problem. In accessing the tumor. See, we didn't have any access in the beginning. Somehow we managed to go behind. Wash karna. Now this component, see this? Hello?
Yes,
Yes, sir. Yes, sir.
You're there.
Wait, kar, nikalo.
Bleeding is there.
Yeah, little bit. Let me wash it. Bada big pack. No, ruk जा. Wash. Sit there. Give me a good wash. See this? I tortured the angiofibroma.
Yes.
So this is going to, but this is hardly any bleeding, believe me.
Not at all.
But still I want to get rid of some more tumor, you know. Pack for a while. Just 2 minutes, I will pack.
Wash.
And it will be, yeah, it will be ready again. No bleeding. See this? I want to get rid of this central component little bit more so that I can go behind. That is the whole game. A little bit more central component, if I get rid, I will be in the usual position like any other tumor. So later. See, this tumor is attached to the septum here.
Yes, sir.
That is the source of blood supply, which I am segregating here. See this?
Yes.
I told you we have to remove the rostrum as well to get a full access of the sphenoid.
Yes. Remember.
Yes.
See, acquiring more and more access.
Yeah.
Just give me to go to the opposite side at some place, you know. So what we have done new in this particular patient, it divided the tumor anteriorly. Wash. तू रख तेरे पास wash. Now see. The opposite. See this mucoperichondrium?
Yeah.
See, this is the tumor which is coming here. On opposite side. See this?
Yes, that's a tumor.
This much. Those are the opposite turbinates. And this is my, this is the tumor in the nasopharynx. See this?
Yes.
Yes, sir. Yes.
That is all the way. Tumor behind. That is the sphenoid sinus above. That is the sphenoid sinus above. Can you see?
Yeah. Tumor entering the sphenoid sinus.
This is the superior turbinate of the opposite side, which I have divided. See the sphenoid entry.
Yeah.
See the tumor in the sphenoid.
Yeah. Clearly.
Nice listen.
Very nice.
See, that is the tumor. In the sphenoid sinus. See that?
Yeah.
Completely being elevated.
Yes, sir.
Forceps. See, I told you earlier, this is a challenging case. And you have to be prepared with all these things, That is the sphenoid component section. See, completely elevated.
Yes.
Now here, after this, what I can do, I can place a peg there behind. And, I have to expose Yes, wait. See this? Not catching, man. There's some vessel there. Cob later. Yes, wait. Forceps. Yes, bring out. Yes. See this little bit of the wash. Yeah, this is irrigation to see anything behind. Oh, look. All this tissue has to go now pack. Now I can see the sphenoid very well.
Yeah.
Yes.
This is posterior superior exposure. Now for the posterior inferior exposure, take the knife off. lot of bone has to go. Boss, once I get this posterior inferior exposure, I will get the majority of the tumor out.
Yeah.
एक और देना है और देख थोड़ा लंबा दे क्या दिया just wait for a couple of minutes here and come to the anterior part. Wash. See the bleeding which was there.
No, it's gone almost.
It's gone. Yeah. Superb.
पानी डाला कर yes. और काटेंगे See now, situation much better. And now again I will divide.
Under control.
This is how you have to go on. खोल See, some more component I intend to divide. I have no option but to divide.
Yes, yes.
But too much of nasal component. Irrigation. Yes.
Sometimes when you're cutting, you will get like venous sinusoids kind of thing that will be opening up.
Yeah, yeah. See, I'm trying to acquire space. That's it.
Yes, yes.
That is the whole game.
And I remember you used to do with the monopolar suction monopolar the same thing before, right?
Yeah, you can do. But see, once you have a combination, you don't need anything else.
Yes.
See, if you have a patience, it cuts like anything.
Yeah.
And imagine if this part is debulk, how much space we are going to gain.
Definitely.
Forceps. See, this part I'm getting out, this medial portion.
Yes, I think so.
Lateral portion is nothing. You don't need to worry about that.
Posterior portion is the one that we need to worry.
Yeah, but this medial part is most troublesome, you know. Yeah, okay. See, this large component is coming out.
Very nice and easy.
Anyway, 2 पीस में ले ले.
Yes, sir. Yes, sir.
Yes, sir.
Yes, come on.
Yes, sir. Yes, sir. Yes, sir.
Yes, yes, earlier.
Yeah, and posterior superior dissection is already done, so we have the posterior.
Yes. Yeah.
Yeah.
Hold in the beginning. Yeah. Very nice. Very nice. I think now you would have more control. I think now you have more control.
Yeah.
Yeah. Yes. True. So, just anterior to the eustachian tube orifice, is that the place where you would just start coagulating to separate the tumor from the opposite side blood supply? Yes, yes, yeah. Yes. Yeah.
Yes, yes, yes.
See this. See its
Yes, yes.
attachment to the lateral wall, opposite side.
Yes.
Driving blood supply from there. See this?
Yeah.
Yes, yes.
This is something we need to segregate.
Do I hear a snoring sound?
I think somebody's close.
See?
Yes.
Completely, attached to the lateral wall. My goodness, such a huge component.
But that's not me snoring.
I know. I don't know. I heard some.
Not even me. Not even me, sir.
Now, I will remove the part of the rostrum to see. This is the component from the sphenoid.
Yes.
That is the hemorrhagic part behind.
Ah.
Okay, right.
Now, how much of the rostrum I need to remove, you will see. See, this is tumor component is 10 times than the previous one.
Yes, sir.
Never ending kind of a tumor. क्या कर रहे हैं? See this tumor, just a minute. I have to do something to the sphenoidal part, you know,
Yes, sir.
to bring it down.
In a way, we are so lucky that it doesn't attach itself to the sphenoid. Otherwise, it would be even more difficult, right?
See this whole tumor coming out of the sphenoid. See this?
Yeah.
See the amount of tumors there. Never ending kind of. See this?
Yes. Yes.
Yes.
पकड़ना इसको. Lux. Take a lux. And I will push it down.
Into the corner.
Yes, you have to bring it out of the sphenoid now. पकड़ना इसको. Yes. Now see the catch hold.
Yeah. Nice.
My God, so many components, so many lobulations, you know.
Yeah.
Section. Now, see the sphenoid component?
Yes, yes.
Yes, yes. Almost coming out.
Push down. Give me the pack. कहीं भी फेंक दिया कर पानी. Yes. See here I will put the pack from behind, so it will allow it to come back in the sphenoid, you know.
Yes, sir.
Still there are more than 10 lobulations of the tumor there. See, this is the dura which was dehiscent.
Yes, sir.
See, this is sphenoid component.
Yes,
Yeah.
sir.
Now we will divide from here. नहीं उसको रहने दो, इधर से. हाँ. Now we'll divide the tumor, this medial component completely and push it down. See this?
Yes, sir.
This huge one. And then separately we'll get the lateral component out. Now we are going to be through very soon. Only thing is that cavernous sinus component and the parapharyngeal component quickly, 5 minutes after that. Yes. Now, my goodness, such a huge one. Section karo. नीचे section karo. See, at the medial end of the maxilla, you know.
You can divide it, I think.
Yes.
Who is there? Sandy? Sandeep?
No.
Sandeep, who is there? Sandeep or Dinesh?
हाँ सर बोलिए सर.
No, you are not there. Sandeep is left.
See now, almost divided.
Yeah.
Yes, sir. Yes.
See the Eustachian tube on this side?
Yes, yes, beautiful, beautiful.
So it is at this juncture you get the tributaries from, branches from the internal.
Pardon?
The branches from the internal were supplying at this level.
Yeah, coming from behind.
Yeah.
So that is, I have left on my cobblator,
Yeah.
See all this little bit of the oozing coming is coming from there only.
Yes, sir.
Yeah.
One vessel is there. This one is.
See this, I am cutting through.
Yeah.
Now, how will this big component go inside, boss? That is again a big challenge. Even the nasopharyngeal component itself is so big.
Yeah.
Separated. Oh. This is plant division to get rid of this tumor,
Yes.
so that we can remove the rest of the tumor under vision properly. Push karo. See everything pushed down.
Yeah.
There is no space to push. Pani. See, there is no space to push, but it will. Let me orient you. See, above is the pack we have placed in the sphenoid.
Yeah.
Yes, yes.
See this, just to orient you. And laterally is the tumor which we have left behind.
Yes, sir.
See this laterally you have left behind.
Yes.
And this was the pack in the sphenoid.
Just mute Sandeep. Sandeep को mute कर दो.
See that?
Ignoring कर रहा है.
That is the tumor in the sphenoid?
Yes.
Yes.
See now the entire tumor is pushed down. Suction.
Yes, yes.
My God, this is a huge one. Upar. Pack the now upar. See now this is the sphenoid.
Yeah.
I will leave a pack there. Tumor is pushed down in the nasopharynx. See this? Entire area is open up now. We have to release some nasopharyngeal roof attachment and then deliver from the
Oral cavity.
Down.
Oral cavity. See the huge space we have recovered.
Yes, sir.
This tumor is in kgs, Push. This is the attachment to the roof of the nasopharynx to the periosteum. See here.
That's the periosteum.
Yeah.
Pull, pull. There we go. Pull down. See now.
Yeah, yeah, yeah. Nice.
See now. Both sides use second tube.
Yes. Really.
And what a tumor. Forceps. Forceps first. Yeah, section. Now pack. Now I will show you once I remove this home oral cavity what we have done.
Yeah,
Those you may have disoriented at this step.
No, no, we were okay. As of now,
See
we
now
are.
the panoramic view. दूसरा दे दे 0 degree. Dark कहाँ रहा है?
What's the lens actually? So,
See now
Not
the
so.
panoramic view.
Yeah.
Right from the postethmoidal roof, which is dehiscent, to the sphenoid, to the nasal cavity, to the opposite side. See this? Everywhere now.
Yes, sir.
Everywhere now, you can see the complete control, and this is the tumor now, lateral component, which is left behind. See, had we not removed this big one, how could we think of removing this tumor? Still, there are lots of parts of the tumor left behind, different components, but hopefully, once, like in the previous case you have seen, once you have removed the medial, the middle part,
It's a huge part. Wow.
My goodness. See this.
my God.
My goodness.
Potato size.
Yeah. ये डार्क क्यों आ रहा है? Light.
Light was come again.
Huh?
Light, the lens or.
Can you change the telescope?
Yes, I changed the telescope.
Let me change it.
That's better.
Now the color. I hope this is better.
Yeah, better.
Now give a good wash. Now the things are under control, you know.
Yeah.
Imagine where we started from, right from the anterior nares.
There's no space.
No space anywhere, anywhere all around. Challenges everywhere. See this? Now the complete anatomy you can see all the way. Now the important thing is the lateral part.
Yeah.
Now you have space to give traction on.
Now we have good space, you know.
Dinesh, can you check? I see some audience writing. Dr. Palniappan has said no audio, not able to hear Dr. Satish.
No, it's corrected.
audio? No audio?
Corrected? Okay.
No, corrected, long time corrected.
No, sir, it's working, sir.
Working?
Okay.
Working, sir.
Okay. See now. Nosing.
Yes, sir.
See, this is the strategy of segmentalization of the tumor in these situations. Not in all cases, but in these situations, you know.
That's the infraorbital. I mean the V2.
Yes.
Yes, sir. We do.
That is something you need to preserve. You have to dissect and preserve. See this?
Yes, sir.
Like we did in the previous case. See, this dissect and separate it. The nerve is? This was the vessel which we coagulated, opened up. See this?
Yeah.
Yes, sir. Yes.
Again coagulated. Because of this would have been possible.
Yeah.
No, इसको उठाओ, उसको उठाओ, उसको आगे वाला, आगे. What is this? What is this? This one? हाँ. Yes. See, now we are removing quickly the rest of the tumor.
Yes.
Yeah.
We have already separated our, V2.
Yeah.
Yes. V2 separate.
Soft. This is the main vessel. See this?
Yes, yes.
Yes, yes.
Give me a
yes.
clip. Clip. See, that was the main vessel which we coagulated there.
Yeah.
I am just dissecting a distance of this vessel, separating it away from the tumor,
But do you think it was coagulated completely, or we were?
No. Partially to the level that we can remove the tumor.
Yes. I think we were a little luckier.
And now, one more. See this?
Yeah. Nicely clipped.
It is the coagulation of this vessel enabled us to remove the tumor,
Yes.
But that was a temporary coagulation which helped us remove.
Yes.
Now see.
Permanent.
That's it.
Yes, sir. Yes.
Now.
You showed you showed two branches of internal maxillary supply.
Now see the tumor is coming out.
Yeah.
See the vessel there behind?
Yes.
Entire tumor coming out.
Yes, sir.
Nothing left behind, Now, which component of the tumor is this above the? This is above the V2. See this, straight forceps.
That is the supraorbital fissure.
Yes.
Oh, that has also come.
This component. See this?
Yes.
Yes, sir.
What I do, I decompress the fissure.
Yeah.
This is bony decompression,
Yeah.
to allow it to pull.
Heads off to Dr. Riyaz Afridi from Pakistan, Dr. Palini Appan, Dr. Arshad Imam. Some of the people are live with us since 2 o'clock in the afternoon, and they are still watching it.
See this component out?
Yes, sir.
Yeah, wash. As such, there is no bleeding now. Now,
I think it was the
let me
previous
show you. We have to drill the pterygoid and remove the tumor from the pterygoid and from behind the pterygoid.
So you told you will drill completely the pterygoid.
Yes, most likely. Let's see.
And also the VDN area, right?
Yeah, so wash.
The cavernous area has been completely removed, you think? Or maybe
No. I will see. पकड़ नहीं रहा यार. Lot of tissue. Suction करो. Suction. Cobblator. पकड़ो. I will come to the cavernous part again. Okay. This is, I broke this and it came out. Yeah. It came out of the anterior nasal cavity, And now I can remove it in no time.
So, question to you: how long this wand lasts? For one case or many, or depending on
one case. If you can do this, use DNA with one wand, nothing like it.
Yeah.
Sometimes you require.
Have you used it more than one?
Pack. Yeah, sometimes you may have to use more than one.
Okay.
Vidya Sagar, you must be using more than one in OSA
I
cases.
know, yeah.
See this. Now, from behind everything is clear.
Yes.
Now, where is the tumor? This is the pterygoid. Inside the pterygoid, behind the pterygoid, and this is the one.
Cavernous area and this
Yes.
superior orbital.
Sir, this is the final component left now?
Not now.
Two more.
देना कॉबलेटर ये पकड़ना
That is the orbital apex area.
Yes. See, this is the opening. Yeah, that is my V2, you can see.
Yes.
Yes, sir. Yes.
Cope. Now see, clean. ये क्या है? Section. Can see?
Yeah. Superior orbital fissure is clear.
It was going into the cavernous.
Yes, sir. Yes.
Yeah. See inside.
Very nice and clear.
Yeah.
Wow.
Inside.
So that is the cavernous sinus area, right?
And that is the carotid artery.
Carotid artery.
Yes, sir.
See the pulsation. I told you the tumor was going anterior to the carotid. Give me the Doppler. Give me the Doppler, please.
How much is this the Doppler probe, Dr. Satish ji?
I don't know. This Doppler is cost around 2 to 3 lakhs, I suppose. I've been using for long. I don't remember.
Okay.
But the probe is roughly, 45,000.
Okay. What company it is made?
I don't remember. Let me see. क्या लिखा है इसमें? See, this is optic now there.
Yes,
Yeah.
sir.
Below the optic nerve is the superior orbital fissure.
Yes.
And what is separating this bone is the optic strut.
Good. Yes.
Below the superior orbital fissure is the V2. It is separated by the maxillary strut.
Yes, sir.
VTI. ये दूसरे देना.
Yes, sir. Yes, sir.
Can you hear?
Yeah.
Yes, sir.
That is the cavernous sinus where the carotid was. Okay?
Okay.
And you may come across little bit of the venous bleeding. That's nothing else. See the carotid artery there.
Nice and clear.
Very clearly seen, sir.
So we remove till there. Okay?
Yes.
So that component is free. Now lastly is the pterygoid. Okay?
Yeah.
See, once you remove the medial component, there is nothing left. As simple as that. The main goal is to remove the medial component after 360-degree exposure. I hope you got the concept.
Yes.
Yes, sir. Yes.
Yes, sir. Thank you.
That is the main thing. Pack the mic, Pucha. Behind the whole concept. Remove the medial component. So our first unit of the blood is going now.
Okay.
This is after, probably 30 or 40 angiofibromas, we are, giving transfusion.
It's the first time in the webinar, I think, for the last 3 months.
Yeah, it didn't feel like, but here we should give at least 1 unit, and for this we were prepared.
I mean, just because you have reserved it, you are giving it. I mean, I don't see that much of.
Yeah, but it's still better to give it.
Demand the use of blood transfusion.
These are all children. You can't,
take a chance.
Yeah, their blood volume and all that, but still. Yeah, you can go away without that as well.
Yeah.
See now, this is the picture. Now coming to the pterygoid, this is the whole root cause.
90% chance.
I hope the picture is clear.
Very clear.
Yeah, very good.
Oriented?
Yes, yes.
And now is the pterygoid portion, that is the most important portion. And it requires a lot of drilling, lot of, give me the drill first. वो दे, चलिए दे. चलना देगा. See, I have opened the pterygoid fossa.
Yes, sir.
That is the lateral pterygoid plate, and here is the medial pterygoid plate. कहा था तुम? काली जवान. See that gauze came in.
Yeah.
Yeah. Anyway. See, for the cavernous sinus, it didn't even bother to put a
back.
See here?
Yes, sir.
Poblator. See this. Sagar?
Yes, sir.
Next time when you tell your wife that you are going to see me, she will never allow you to come out. Because I am sure.
Not at all.
Carry. Believe me.
Not at all.
So what time Vidyasagar you told ma'am that you will be finishing?
See, this is the pterygoid. See, this is what I am removing, pterygoid.
Yeah.
And see the tumor inside.
Yes.
Yes, sir, yes.
Now for pterygoid, again little bit of the bleeding is expected, venous bleeding.
Is it the pterygoid plexus of bleeding?
Flux.
That is why we get the bleeding.
Yeah, because that is venous bleeding and you can't help it.
Yeah.
And we saw in the MRI, it is occupying the whole fossa.
See this. This is the medial pterygoid plate. Can you see?
Yeah.
This entire bone I am removing to get rid of the tumor behind. See, this is tumor inside.
Yes, sir. Then we saw it on the MRI. The whole fossa is being involved by the cable.
Yes.
There you go.
See that?
Yes.
This is pterygoid venous bleeding. Get ready for that. And see the tumor inside. Section karne do. How will they see? See the tumor.
Yes, sir. Yes.
दिखा ना यार, होता रहता. See the pterygoid fossa.
Yeah. Yes, sir.
Pterygoid process. and see how this tumor invades the Haversian system. Like previous case also you have seen.
Yes.
Severe Vazine is there.
So we have to keep on removing the tumor and let the bleeding happen. It will stop it by itself.
Don't worry about this bleeding. Let it be. See now it has come out. Now what I will do.
Pack, wash, and pack.
Yes. मोटा ले ले सेक्शन थोड़ा ब्लीडिंग दिखता नहीं है तेरे को कर yes now wash yes okay see this pterygoid venous bleeding
Yes.
again expected. And see this entire tumor which is coming out like this. You have to pull it. You are not supposed to break it, you know. Each and every part. See, this is all venous bleeding.
Yes. Yes.
Yeah. Can you show below? Show me the Eustachian tube. Yeah, leave it. No issue, no issues. Anand. Yeah, show the Eustachian tube. Yeah. See below the Eustachian tube level.
So until then you have to do, is that why you are looking at it? Yeah.
This is pterygoid fossa. Now give me the drill. I will drill away the pterygoid. डाल इसके ऊपर See all this Haversian system of the pterygoid.
Yeah.
Yes, sir.
Has to be thoroughly drilled away. See the Haversian system?
Yes, yes.
To ensure that no tumor is left behind. Quick.
So if we don't do this, recurrence is bound to happen?
100%.
Oh boy.
This is the cause of the, tumor coming back. Almost always. Now give me the cobbletter. See the pterygoid fossa has to be completely. Now I am coagulating the venous plexus. Let me see the vein. This is one of the most one of the most frustrating thing one can think of.
Yes.
The pterygoid venous bleeding.
Yes. What if we keep a small pack there for a while?
Yeah, I will. But after removal of the disease, otherwise this will mislead me.
Okay.
Surgery cell you will put, right? After that.
because if I pack, I may not see the disease being there. I may miss. See the pterygoid?
Yes, sir.
This little bit of the bleeding we have to accept. You don't have to be panic. Now give me the drill. Suction कर दे नीचे. Yeah. See this?
Yes.
Once I ensure that no tumor is left behind, हटा थोड़ा नीचे कर. I will pack. See now the pterygoid fossa?
Yeah.
Yes.
And then the VDN we have here.
Yes, no question of leaving behind anything. पकड़ना यूँ. पकड़.
That looks like muscle only, no?
Yes. Give a pack. Now I can, pack a small surgicel there.
Yeah.
With the pack. See now I can easily pack.
Yeah.
Yes.
I could have done this earlier as well, but how would I ensure like I did that there is no tumor there? See, this small mistake can lead to a recurrence,
Yes.
दूसरा सेक्शन है. दूसरा सेक्शन. नीचे कर नीचे. पकड़ दबा. Yes. Now what I will do, this is my Eustachian tube, you see?
Yes, sir.
Give me the divider. Yes. This little bit of the oozing from the pterygoid will stop in a minute. I will have to apply the surgicel differently now. See now, no tumor anywhere.
Yes, sir.
But still I will drill the little bit of the pterygoid more to see.
Not the pterygoid, sir, but I want to see the VDN.
No, I still have a doubt. I still have a doubt of a tumor,
Oh.
I will show you where. That is going to be the last component. यार मैं ही कर लूंगा यार, वीरू छोड़. 1 घंटा लगाएगा.
Sir, Dr. Palini Appam and Dr. Jagdish are asking what about the parapharyngeal part.
Yes, that is what I have to look at. Whether, I don't think it was removed, I have to go behind. That is what. अरे यार. वो तो आ गया. पैक कर यार. See that venous bleeding is still on?
Yes, sir.
Pack. साथ के साथ दिया करो.
So if you follow see a doubt or recurrence, what is your protocol and when would you do? And
see, for first of all, to prevent that, spend some more time intraoperatively to ensure that you are removed completely, particularly from these areas where I am removing now.
Yeah.
These are the major cause of so-called recurrences.
Okay.
So the best thing is prevention, and that is intraoperative.
Okay.
Because the post-op radiology, you can't rely much rather than taking care of everything intraoperative. The removal of a recurrence is much more difficult, always.
Yeah.
See, now everything is good except I have a look in the parapharyngeal region. Later.
Satish, what's your plan tomorrow? Tomorrow you will be doing OPD and everything.
Pardon?
So what's your plan for tomorrow morning?
Morning we have a theatre.
Again?
Yes, yes, that is scheduled. Now see what I am doing.
Wow.
Can you see something?
Yes, sir.
It's a tumor.
This is the parapharyngeal component.
Yes, sir.
See this?
Yeah.
I told you in the beginning that we'll go behind the pterygoids to remove this. Wash कर दिया करो कभी गलती से. See this?
Yes, sir.
This is the component.
Sir, if you don't look at previously on MRI, many people can miss it.
That's why recurrences are so prevalent.
Yes.
That is actually going on to the Vidian, right?
Yes, yes. And see now.
Yes.
Because I not
It's a very, very controlled traction, you know.
Yes, sir.
Very, very controlled. It's not that you all of a sudden. And that is
Wonderfully done, sir. Excellent.
See this?
Yes, yes.
If this component had this component been left behind, then
That is what I was asking. If you don't have an idea that this is a component left in a live surgery, you can easily miss it.
yes, one can easily miss it. That's why the imaging, the planning, everything is important. See what is different in this case and the previous case. So many challenges, you know. Now see, completely drill.
Drill. That is the best thing.
Now the last part is this part of the drilling. That's it. See this venous reading.
Yes,
Don't worry about that. See, once you remove the tumor from the pterygoid, basisphenoid, You know, you have to be ready for this venous bleeding, you know. And this is pure diamond now. What are this? Let it be. I will just use this here section just to ensure that
Dr. Nias Afridi has mentioned from 2 to 2 non-stop. What an amazing commitment. Afternoon 2 to night morning.
He's been standing and operating non-stop.
Yes, seriously, it's amazing. The heads off to you.
this is the, you know, most important part of the tumor which I removed, which is responsible for otherwise the so-called recurrence. क्या कर रहा है?
Dr. Dhirendra Singh Vishwath has asked, where is the site of foramen lacerum or carotid?
Foramen lacerum is behind. When you follow the median, that is further behind cobbleter. And this last, we will pack this with the, you know, what you call that, Surgicel for 10 minutes.
Yes,
all
sir.
this will stop by default.
Yeah.
See, now there is no more tumor.
Very nice.
This is all venous bleeding. That signifies that tumor has been removed. And I have cobbleted all, see this?
Yeah.
Drilled all that bone, cobbleted everything.
Very
See,
nice.
majority of the, drill, one more time, drill. Lastly. See, this surgery, at first surgery, even a slightest compromise can ruin the life of a patient, you know.
Yes, yes, that's true.
So
This
when
is
will you
this
first
is-
follow MRI? Like,
This is Beji sphenoid bone, yes, what?
check your follow-up. Like, first follow-up MRI, when will you plan?
No, no, why?
I will follow it endoscopically.
Okay, okay.
In case any symptom or finding warrants, because now I have, once I have done, I have the idea that I have removed it thoroughly. See what I am doing? This
Yes.
Beji sphenoid bone, even a slightest, you know, I really want to flush it completely. Not to take a chance. Again, see this Beji sphenoid bone.
Nice.
Now clear?
Very clear.
See here, there is just pterygoid venous bleeding, nothing else, no tumor. See behind is the cavernous sinus.
Yeah.
See, this is periorbital cavernous sinus.
Amazing, sir. Complete.
Now, we'll just put a pack over here and some Surgicel for 10 minutes. Dal dena. And then we'll remove and there will be no bleeding at all. See now, this area, I told you in the dissection 1 square inch critical area. See where my suction is. What is there in 1 square inch? Above and behind is the cavernous sinus and carotid. Above here is the superior orbital fissure. Here is V2. This is pterygoid. This is the base of the temporal lobe here. Then here above is the this thing optic now. And behind from here 1 inch is the carotid artery. Again the parapharyngeal.
Nice, sir.
See from this suction point 1 square inch. Can you see?
Yes, sir. Sir, Dr. Oli from Ladakh is saying ki in the textbook it should
Yeah,
be
check it.
that antidote for Jain is Dr. Satish Jain.
No, boss. This is, science is always evolving, you know. There may be some better technique in future, but we have to, you know, change. So, let me come to the, come. Pack kar dena usko. Let me come to the, you know, the parapharyngeal component. Let me show you. Hello?
Yes, sir. Yes.
Yes.
This one and this one. See, this was the component.
Yeah.
The switch.
Yeah, it's connecting.
Switch to laptop.
Yes.
Tomorrow morning again 8 o'clock bus?
Yes. That is, tomorrow is Monday. Big day. Yeah, can you see?
Yeah.
This is the component which was in the parapharyngeal space. Can you see this?
Yes.
Yeah, which was taken.
This is what, and this is what we removed as a whole. Okay?
Yes, sir.
And along with this part invading the pterygoid bone.
Yes.
Greater wing of sphenoid and the pterygoid here, which came along with this component. See this? These two pieces came in the end. That was the end. See this, use the sphenoid one. Now you see which component you have not removed. Everything.
Everything.
So this tumor has so many lobulations, more than 10 lobulations. Every possible given extension, you know. What extension is not there? All possible difficulties one can pose is all there in one case. That is what I kept with some different extensions. So in future also we'll keep some difficult JNAs now.
Yes, sir. So they should be kept in the curriculum of all the medical colleges for JNA.
But see what a difficult pathology it is. Now see as a whole, see this, how big the tumor is, right from the anterior to posterior.
Yes, sir.
See, this is like a kg of a tumor.
And this
Full
was a
kg
breast
of
case.
tumor. Huge one.
You have done an endoscopic. That is even more appreciable.
And this tumor removal of endoscopic is, you can understand how difficult it was. But coagulator, taking vessel, see I coagulated the vessel, segmentalize multiple times with the coagulator to get on to the depth of the tumor, then went to opposite side and brought the sphenoid and the choanal part together down to get rid of the space, you know. And then the lateral component easily came out, and then the bone, the component in the pterygoid bone is the key. That is the cause for recurrence, always. And see how difficult it was.
In your textbook, when is the time when you would opt for a external approach?
Few situations I can show on my MRI screen as well. When the tumor has an intracranial component and acquiring vascularity from the, you know, internal carotid system, from the intracerebral branches of internal carotid, not only internal carotid, intracerebral branches, okay?
Yes.
Let me give an example to clarify.
I think the audience are going to be upset with me for asking.
Okay. Let me find out that, you know. Let me find out.
And in those cases, what external approach you would do?
Yeah, I do mostly a combination of subtemporal and a maxillary swing. That is like through and through. You know, let me explain it. For any most difficult extension of JNA, you know, like we have a cases like, you know, in kgs, many a times, you know. in any most difficult extension of the JNA, I tell you, what you need to do is, just a minute. Yes, now it is coming.
So when you do a maxillary swing, this part will be accessible.
Yeah. So what we do, subtemporal from above. Show this. Subtemporal from above like this.
Okay.
Retract the temporal lobe and you have a tumor coming up.
Okay.
Vascularity coming from middle cerebral, any branches you can coagulate under vision. That is one.
Okay.
And below is the maxillary swing.
Okay.
Maxillary swing.
Yes.
Swing the maxilla. Everything is there in front of you like a book.
So
and then you remove the tumor from above, tumor from below, and make it through and through. Make it through and through like a book. Even if the carotid is involved, 360 involved, and you put a microscope and do under vision with both hands. No issues. So I found that what I wanted to show you.
Dr. Satish, I'm having a small doubt here.
Yes.
The maxillary swing, I thought it is always rotated laterally. You
Yes.
rotate it medially here?
No, laterally.
Laterally only.
Obviously, obviously. You have to rotate the maxilla. Like see, this patient. I'm giving you one or two examples, you know. Look at the tumor of this patient and decide what endoscopic approach can do anything to it. Every possible, you know, challenge was there in this tumor. Every possible. See this tumor.
Oh, okay. Oh.
Oh, words, sir. Speechless.
Carotid to
Every possible, you know, all the external, even the, you know, this thing, what do you call this? The preauricular artery, what do you call that?
Superficial temporal. Superficial temporal.
Superficial temporal was giving a huge branch to it. Facial artery was supplying it like anything. And then the huge component from the internal carotid. Now see the situation of the internal carotid. Now see. See the internal carotid was coming like through the lake of the tumor. Lake is all around at least 4 centimeter tumor around. How will you find the carotid? Impossible. With lot of branches of the internal carotid coming to the tumor. See this. Entirely. And lot of branches from the, let me show you the CT angiogram. Here it is. Yeah, it is. See this. Yes. This was the tumor and lot of branches from the internal carotid supplying this. How will you see? Reconstruct 3D. Come to the axial, coronal, and reconstruct to the MIP. Now see. Can you see?
Yes, sir.
In the lot many branches, even the main trunk of the internal carotid was giving branch to it. See this?
My God.
This is a branch from middle cerebral artery coming to the tumor. And then this carotid, see this carotid coming out through the tumor and giving a huge branch. Can you see this?
Yeah, big, huge.
From the internal carotid, imagine how can you remove this tumor like this.
So you had to stent the carotid.
See the bunch of vessels into the tumor. When the internal carotid comes into action, you can't imagine.
So did you have to stent the carotid system or?
Yeah, so we, in this particular patient, the cross flow was good. So we, you know, did a coiling of the carotid pre-op. Right from the petrous to the supraclinoid, completely till here. Complete coiling and remove it and block. A combined approach. Combined it again by combined approach. So this was one example. Many a times you never know, like we plan many a time, like this case we planned, and later on we realize, oh, this patient has a huge intracranial branch coming. And then the entire thing was, it was looking like it will come easily, endoscopically. It looked like